Welcome to the second Global Neuro-Ophthalmology Case Festival 2022. The Neuro-Ophthalmology Special International Group, NOSIG, originated in India 7 years ago for the sole purpose of case discussions in neuro-ophthalmology. Expertise in neuro-ophthalmology resides all over the world. It is truly global now. So with the success of the first Global Neuro-Ophthalmology Case Festival came greater expectations for a second one. With inputs from the members of NOSIG, the program has been put together and will be moderated by 6 of us over 2 days. All clinical queries for the cases can be typed in the chat box to be considered for discussion. Do spend both days with us and make the program a worldwide success. Thank you. Now I'll be introducing the first moderator. Dr. Shikha Basi is Deputy Director, Neuro-Ophthalmology Services at Shankar Netralaya, Chennai, India. She is a member of the Optic Disc Drusen Consortium. She is a recipient of the Athavale Award at the APAO AIOS in 2013 for her work on OCT in papilledema and pseudopapilledema, with and without disc drusen. She has been the organizing secretary for many national and international conferences in cataract and neuro-ophthalmology and has given numerous talks in national and international meetings. She is a reviewer of several journals like BMC Neurology, PLOS ONE, International Ophthalmology, and Indian Journal of Ophthalmology. Over to you, Shikha.
Thank you, Satya. So I'll start sharing my screen. So welcome once again. And before I start the first session, let me introduce Dr. Satya Karna. Satya Karna is already very famous. He's famous already because he's connected all the best of the neuro-ophthalmologists from across the world on this platform. And he is working with JP Hospital, Noida, New Delhi as the director of the ophthalmology department. He's authored the Shankar Netralaya Atlas of Neuro-Ophthalmology, 2 editions, and a book, Step-by-Step Neuro-Ophthalmology Examination and Diagnosis. He is the Joint Secretary of Indian Neuro-Ophthalmology Society. He is also the moderator of a group, Neuro-Ophthalmology Special Interest in Neuro-Ophthalmology International Group. It's called NOSIG Group. And he is a reviewer of the journal Neuro-Ophthalmology and Indian Journal of Ophthalmology. So Satya is doing a wonderful job in connecting everybody in neuro-ophthalmology and taking neuro-ophthalmology to greater heights world across. So with that, we'll begin. He's already introduced me to start the first session. Let me first introduce the panelists for this session. And I invite for this session, Dr. Naveen Jayakumar. He's been my teacher. He is, I've learned my neuro-ophthalmology under him at Netralaya. And he is currently honorary director at Darshan Eye Clinic, Chennai. And he's also a visiting consultant with Vasan Eye Care Hospitals. And he was the head of our Department of Neuro-Ophthalmology at Netralaya till 2005. And he then went to the Chinese University of Hong Kong to help establish a Department of Neuro-Ophthalmology. And he's been a member of the editorial board of Journal of Neuro-Ophthalmology. And he is the only Indian who has been invited to this prestigious position. In 2016, Dr. Jayakumar was conferred the APO Academic Achievers Award by the Asia Pacific Academy of Ophthalmology. So welcome, sir. Next, we have Dr. Rashmin Gandhi, again, a very well-known name in Indian neuro-ophthalmology. I've learned ophthalmology under him. And he is currently Managing Director, Foresight Worldwide India. And he is also associated with Center for Sight as the consultant and director in Neuro-Ophthalmology. He is adjunct professor, University of Hyderabad, India, and he is also a founding member. He is the vice president of Indian Neuro-Ophthalmology Society. He has received the award for academic excellence by the then Honorable Chief Minister of Gujarat, Shri Narendra Modi. Welcome, Dr. Rashmin. Next, we have Dr. Meenakshi Dhar. She is a professor with Amrita Hospital in Faridabad, New Delhi. And she has worked as a professor of ophthalmology for 2 decades at Amrita Institute of Medical Sciences in Cochin. Her interests include multiple sclerosis, visual fields, and OCT in neuro-ophthalmology and IIH. She has presented in many national and international fora, and she is the sub-editor of the glaucoma section for Indian Journal of Ophthalmology and has been on the editorial board of Amrita Journal of Medicine and Kerala Journal of Ophthalmology. Welcome, Dr. Meenakshi. Next, we have Dr. Revati Ramesh, who is a senior consultant with Dr. Tony Fernandez Eye Hospital, Aluva, Kochi in India. And she has had her education at Chennai and then moved to Kerala, where she has worked in several private sector hospitals. She did her observership in neuro-ophthalmology at Shankar Netralaya, Chennai, and went on to head the department at Dr. Tony Fernandez Eye Hospital. Welcome, Dr. Revati. So with that, we'll begin the first very, very interesting case. And I have the honor of introducing Dr. Helen Mayer. She is Sir William and Lady Stevenson Professor of Ophthalmology and Head of Academic Neuro-Ophthalmology and Glaucoma at the University of Auckland, New Zealand. She completed her fellowship training in neuro-ophthalmology and glaucoma at Bill's Eye Hospital in Philadelphia. She subsequently received a doctorate of medicine and a doctorate of philosophy from University of Auckland. She's published more than 200 peer-reviewed articles. She's the chair of Glaucoma in New Zealand Charitable Trust, and she serves on the Basic and Clinical Science Course Neuro-Ophthalmology Committee for the American Academy of Ophthalmology. She is also the chair of Scientific Program Committee for the RANSCO Congress, and she's a member of Court of Examiners for Royal Australian and New Zealand College of Ophthalmologists. She's a very, very important person and ophthalmologist in New Zealand. So with that, I invite Dr. Helen. Over to you, Dr. Helen. I'll stop sharing the screen.
Hello, good morning, good afternoon, and good evening to everyone. Are my slides coming up okay?
Yes.
Wonderful. Okay, well, I will get started with the first case. I'd like to thank you for having me as part of this esteemed lineup, and I look forward to hearing all the cases. The case I'd like to start the session with is a 45-year-old woman who presents with intermittent diplopia. Her background is that she had 4 weeks of frontal headaches, neck pain, and back pain. And she had the occasional episodes of transient visual obscurations. She described these as when she would change position from sitting to standing, that her vision would blur somewhat. Systemically, she comments she'd been a little bit unwell with a bit of nausea, fatigue, and falls, but she presented following a 2-day history of binocular horizontal diplopia. This had progressed from being intermittent to now being a permanent diplopia. She had seen her general practitioner who did a CT scan, which was reported as normal. She was otherwise well and had not been in hospital with no other problems. Her past ocular history was of myopia, and her social history was that she had moved to New Zealand from Hong Kong in 2003. She was a non-smoker. She had 2 children with minimal alcohol intake. So on examination, her visual acuity was 6.6 in both eyes. Color plates were full, and extraocular motility assessment demonstrated limitation of abduction consistent with the left sixth nerve palsy. The rest of her slit lamp examination was unremarkable. There was no cells in the anterior or posterior segment, and I am about to show you her disc photos. There was no afferent defect. And so these are her disc photos, right and left, and our interpretation of the photographs was that there was mild bit of optic nerve head swelling, predominantly superiorly and inferiorly. It was, as always, more obvious clinically when you see the patient. Her visual fields were within normal limits. And so at this juncture, we decided what investigations to undertake. Would you like me to keep going or open it up for discussion?
I think you can you can continue.
Okay, so we decided to do an OCT, which is our standard practice, and perhaps this is a point that may be interesting for the panel to discuss later, the role of OCT in neuro-ophthalmology. But the OCT, we find it's useful to sometimes identifying subtle disc swelling, in particular in tilted or myopic discs, which may be difficult. And the OCT suggested some mild disc swelling, which was consistent with our clinical appearance. The ganglion cell layer was normal in both eyes. So at this stage, we had a 45-year-old a woman of Asian background who was otherwise relatively well until her recent illness. Her key features were that she had a left sixth nerve palsy and mild swollen nerves with preserved function. She had a normal CT scan, which excluded any large space occupying lesion, but it was a non-contrast CT. So at this stage, the question was, what is the differential diagnosis? Well, naturally, when you see swollen nerves and a sixth nerve palsy, one of the things that comes to mind is pseudotumor cerebri or elevated intracranial pressure. The question was raised: is it really just an isolated sixth and the nerve's appearance within normal limits? If it was an isolated sixth, one would think of myasthenia or cavernous sinus abnormality, or is it a demyelinating lesion? Or other possibilities were an infective cause, in particular, given her systemic unwellness that she described over the last week. Inflammatory process such as sarcoid, autoimmune, or other rare conditions. And of course, infiltrative cancer has to be on the list. But our top consideration was whether this was some form of pseudotumor cerebri. So the investigations we arranged were for her to have an MRI and MRA with gadolinium, and this was normal. It was really normal, and that's why I have not showed any images, is because it was unremarkable and there was no abnormality to be detected. So the serology tests that she had were also all negative. She had negative syphilis and a paraneoplastic screen and a battery of blood tests as well. She had also she had a quantiferon gold, which was negative, but it became available a few days later. So we had really excluded the major infections that we were concerned with. So at this stage, the question was, is we have a bilateral disc swelling with a sixth nerve palsy. So where is the lesion? And I guess the most common unifying area would be the meninges, or elevated intracranial pressure, with the sixth being a false localizing sign. So she underwent a lumbar puncture, and this was essentially normal. The opening pressure was 26, which is on the upper limit of normal. So the question for the panel is whether a pressure of 26 is something that you would normally attribute to seeing a sixth nerve palsy with elevated intracranial pressure, or does one really need to see a higher opening pressure to explain a sixth nerve palsy? So at this stage, I wasn't satisfied that a mild opening pressure of 26 could explain her complete symptoms of a sixth and her swollen optic nerve. So at this juncture, we had eliminated infection. I wasn't convinced that it was a classic IIH. There was no suggestion of any inflammatory features that were present. It was definitely, in my mind, a swollen nerve as well as a sixth nerve palsy. So I was hunting further evidence of abnormalities in the meninges. So initially the neurologist did not want to repeat her lumbar puncture because they said, look, they've done one, there was nothing abnormal in it, and they did not think there was indicated to do another one. So because of that, we hunted for signs that perhaps there was something else that they should be looking for. And she had a CT of the chest, abdomen, and pelvis, at which stage we identified a right upper lobe solitary mass. And then at this stage, the neurologists were prepared to consider repeating her lumbar puncture. So this time we asked for a large volume lumbar puncture. And I guess there are a couple of interesting features on her lumbar puncture. The first is naturally the immunohistochemistry stands out, which showed metastatic lung adenocarcinoma. But interestingly, her opening pressure was significantly higher on the second lumbar puncture, and this was only 1 week later. So again, perhaps the panel could comment on the variability of opening pressures in IIH or when we do them, and her CSF glucose was also low. So she had a PET scan, which to stage her metastatic upper lobe adenocarcinoma, and she has since gone on to have a right upper lobe lobectomy. These CSF malignant cells staged the cancer despite primary lung carcinoma, and she has been referred to oncology for further treatment. So in my mind, the learning points was to understand the neuroanatomy can help differentiate where the abnormality is and direct us to what appropriate tests should be taken. And most importantly is that sometimes to exclude a CNS malignancy, you specifically need to have more than one lumbar puncture and request a large volume CSF. I open up this case to the panel for discussion.
Very interesting case, very, very interesting case. There are a couple of points, Helen. To begin with, this is a case of papilledema with a sixth nerve palsy. Though the papilledema is much less compared to the papilledema is, the amount of papilledema is not matching with the sixth nerve palsy. You expect a little more evidence of papilledema. So the reason for asking for a repeat TAP was that the two were not kind of matching. Because what was your thought process in, were you looking for metastasis? What were your differentials when you asked for a repeat?
Well, I think that when I looked at her, I agree. My thoughts were like yours, that normally when I see a sixth nerve palsy, I see more obvious papilledema or features of, more fluid, acute papilledema or more chronic papilledema. This was a bit of mild swelling, so it was incongruent in my mind. She didn't fit the phenotype for idiopathic intracranial hypertension. So, and she did, and so therefore, in my mind was that if she had elevated intracranial pressure or something else, there had to be a secondary cause, either infective or inflammatory. And the first lumbar puncture didn't reveal much to us other than a borderline pressure. So, but my suspicion was that the abnormality still had to be in the CSF because of the location of where else would you find elevated bilateral disc swollen nerves and a sixth nerve palsy? So if you're thinking from neuroanatomical principles to hit both the optic nerves with swelling, but still to have preserved optic nerve function doesn't suggest an infiltrative process in the nerves itself, and to have the sixth could be. So in my mind, I needed to explore the CSF a bit further. And I guess with experience, I've seen this situation several times previously, so I know sometimes you have to keep hunting. But she had no other indication. She was not a smoker. She was no history that would have suggested lung cancer. In fact, if I was looking for anything, I was probably more suspicious of a breast cancer, which would be more common in women. But I didn't have any preconceived idea of what it was. My suspicion was it was in the CSF.
It was in the CSF, meaning it is the meninges, carcinomatous involvement.
Yes, that was my thought. But I guess that it was interesting in the second lumbar puncture, she had an elevated opening pressure of 33.5. So could it have been an pseudotumor cerebri in the sixth with a false localizing sign?
Yeah.
So, or rather than in the meninges. So it could actually have been that, and that the first CSF opening pressure was not accurate.
So, because not every IIH patient has a very, the papilledema doesn't show up. You can have very raised ICT with near normal disc also. So once we've documented an elevated CSF opening pressure, raised ICP, sometimes, you will just treat it as IIH, and, then eventually, the things could have evolved later. But you thought that there the,
yes,
kind of hunch, that led you to investigate deeper. But usually the metastasis, when the sixth nerve, I did a bit of literature search. This is supposedly only the third case of sixth nerve palsy with adeno of lung, that you're reporting. And usually it is the skull base that is involved. The metastasis is in the skull base, and if it is presenting with isolated cranial nerve palsies, or in the cavernous sinus. So it's either in the lower down or in the cavernous sinus, or around in 10 to 12% of cases, probably in the meninges. So it's not that common. What you're reporting is it's a very rare thing. But to really think that, and even the meningeal involvement, actually there are subtle signs on the MRI. The flare, it seems on flare, you can be the involvement of the sulci, the sulcus, you can, it enhances with contrast. So we would have loved to see those MRI images, because the whole story, we have to kind of rule out everything, from the MRI. Because the CSF opening pressure, it is documented high. There is papilledema. Papilledema may or may not be there with raised ICP, and you can have sixth nerve palsy. Many would have stopped at, just treating it as IH. Let's have some comments from the other panelists also.
There's an interesting comment from Neil Miller. He says, in 1939, Frank Ford and Ed Murphy at Johns Hopkins wrote that, and quote, one determination of intracranial pressure in a case of disease of the CNS is no more instructive than one determination of a patient's temperature during the course of a fever. That's a beautiful quote, Neil, and I think that that's one that I should send to all our neurologists, because often they would prefer to just do one lumbar puncture and call it a day.
Yeah, I wish I had said it. It is great, but it is one of the things that I go by.
Yeah, I will. I'm going to screenshot your quote and bring it out as necessary as ammunition from now on.
I'll send you the actual report. It's in the bulletin at Johns Hopkins.
Fantastic. And actually, we had conference with the neuroradiologist reviewing the MRI carefully and the neurology, and it was truly normal. Andy Lee has asked me about the spine imaging, and again, she did go on to have spine imaging, and it didn't show any leptomeningeal infiltration. But a question for Andy and Neil and the rest of the panel is that, do you think this was early leptomeningeal infiltration that we either didn't see on the scan, didn't get good pictures, or was it the 6th was a false localizing sign and an elevated pseudotumor cerebri?
It could have been, I'm sorry, it could have been anywhere, Helen. It could have been an early brainstem. It could have been early cavernous sinus. It could have been early meninges. It could have been anywhere.
I agree.
The main thing is that it's the neuroradiologist. You know, a lot of things. You know, how closely you know, they are watching, they're looking at the images, and because we take our clues from the imaging, and then we convince the Clement has written that, you know, any other neuroimaging would have helped, because to convince the neurologist, you know, to go for a second tap. But I believe that it's quite an in thing there. I see a lot of senior neuro-ophthalmologists, including Dr. Miller, you know, advocating it, that, yeah, if you're not convinced, but what I'm saying here is probably as a neuro-ophthalmologist, I myself could have, you know, we've got a bilateral disc subtle edema proven on OCT with the 6th nerve. I don't know how much further I would have digged.
But she wasn't a typical IIH patient. So, you know, she was very thin.
Helen, we see all kind of IIH patients here who are anemic and they're thin, and, you know, I don't know.
I tend to LP mine and still, you know, hunt a bit more. If I have a thin person, I'm a bit more suspicious. I keep hunting a bit more than if that. I'd be interested to see what the rest of the panel does. But personally, I'm a little bit more suspicious of someone whose phenotype isn't classic.
Yeah, certainly in the Western Hemisphere, we would be very nervous about thin patients or males, or, you know, anybody out of the normal area. This reminded me of some of the cases we've seen of leukemia, in which it's really hard to know whether there's infiltrate, unless there's an overt abnormality in the optic nerves on MR. Or even, and one of the problems is diffusion weighted imaging can sometimes show if there's a lot of cellularity, you can have a restriction of diffusion, but usually it's not quite good enough to really be sure. But we have seen some infiltrative cases in which the fact there was a restricted diffusion in the optic nerve, and that told us that this was an infiltrative process rather than simply increased intracranial pressure.
Neil, question, do you think the fact that the optic nerve function was normal helps differentiate the underlying mechanism of the two?
Yeah, I do. I mean, the first question I had as you were presenting is, this is increased intracranial pressure until proven otherwise. Unless, as I say, the thing that really confuses us sometimes is if there's mild, because the swelling was, I couldn't see the numbers, but this, as you pointed out quite correctly, I mean, on a basic level, is those discs could have been passed as okay, and yet you could see the obvious swelling, particularly on the right. So, I'm sure everybody on this panel has found that our ability to identify mild degrees and even moderate degrees of swelling varies considerably, but the OCT really helps.
Don't you think that was the clue, Helen, that it was like there's this disconnect between the amount of disc edema and that 6, suggesting that it's something other than just ICP alone causing it? I get really nervous when I have a 6 and that's all I have for pseudotumor.
I agree.
I know that exists, but man, I don't like that.
I agree. And that's why, you know, when you asked me why I kept pushing further, because it was because of that very point. It just wasn't consistent. Yeah.
Very, very nice case. Thank you, Helen, for sharing it.
I think Dr. Gordon had his hands up. Oh, yes, I just wanted to agree. I think that I would emphasize the transient visual obscurations in this case, though, because it's much more suggestive that raised intracranial pressure was playing a major part. And in this situation, we often early go for intracranial pressure monitoring because this can be an intermittent problem with raised pressure causing all of this, as it probably was. But as to the actual final cause, you're not really sure what it is because you didn't have any abnormal constituents, but there's cancer somewhere in the CNS which is causing this.
Wouldn't this patient present with systemic features also? If it is because of there'll be an acute, that means there's an acute rise of the ICP. Patient won't have vomiting and headache, severe vomiting, headache. If it's
complained of headaches, I thought she mentioned.
Patient will have, if it is because of the raised ICP and these patients, a couple of reports of carcinomatous infiltration of the meninges causing 6 nerve palsy because of the raised ICP. They're systemically very unwell. So probably it could be hidden somewhere else too, just the beginning of somewhere else too. But very interesting case. With that, we'll
Thank you.
We'll move to, I invite Dr. Claire. Let me share the screen once again. So it's my honor to invite Dr. Claire Fraser, who's an associate professor of neuro-ophthalmology at University of Sydney, Australia. She's trained at Sydney Eye Hospital and did her fellowship at Moorfields Eye Hospital, London, and at Emory Eye Center, Atlanta, USA. She has specialized in neuro-ophthalmology, strabismus, and visual electrodiagnostics. She is a consultant visiting medical officer at both Sydney Eye Hospital and Liverpool Hospital, and is also in private practice in Sydney. So over to you, Claire.
Thank you so much for the invitation to be with you. Well, it's evening for me here in Australia. And so good morning for everyone else. So hopefully you can all see my screen. Is that all okay? Perfect. I think you can all see my screen now. So my case I've called the case of the black diamond. So this was a 72-year-old Caucasian man with a 12-month history of describing a dark central blob in his vision like an elongated diamond. It suddenly came on, but then it progressively worsened. So it was quite a sudden onset. It was bilateral, symmetrical, and constant. He'd been sent by his referring ophthalmologist and had previously been diagnosed with dry AMD with retinal thinning, and his family history was unremarkable. However, his past medical history was quite significant. In 2003, he'd had idiopathic portal vein thrombosis, resulting in esophageal and gastric varices with secondary liver cirrhosis, and had undergone a choleduodenectomy. He was on rifampicin for pruritus. Rifampicin alters the bile salts and so makes the itch of the pruritus less troublesome for the patients. He was also on propranolol for his varices, allopurinol for gout, and Somac for his stomach. When he was sent to us, his visual acuity was 6.7.5 in the right and 6.9 in the left. Reading acuity was N8. He had a mild red, green, and yellow color deficit. He was orthophoric with normal cranial nerve examination, no anisocoria, no RAPD, and his anterior segment examination was completely normal. His fundoscopic examination was also looked very normal. You'll have to exclude these Optos photos, which make everything look a little bit green. But basically, the optic disc looked normal, so did the vasculature and the retina. And on fundus autofluorescence, there was no striking abnormality. His ocular coherence tomography of the optic disc showed a very healthy retinal nerve fiber layer bilaterally, no clear thinning, particularly in the temporal area, given that he had central loss. And his macular OCT really did look very normal. It was quite this thought of retinal thin from his other ophthalmologist. It really didn't look that abnormal. I've only got one visual field here, unfortunately, but it did have this kind of central scotoma, which was all sort of in a diamond shape. So maybe with a little bit of patchy peripheral change, but really a central deficit. His MRI brain and orbits was normal, according to the patient. He hadn't brought them and couldn't remember where they were done, so we couldn't chase his report at that time. His blood tests, he said, were normal, and he'd been decided to have a 30-day trial off his rifampicin, which didn't result in any improvement to his vision. So really, the first question in this case was he was referred to me as rifampicin optic neuropathy. And the question that I had, and I'm particularly interested in what our Indian colleagues say, is there such a thing as isolated rifampicin optic neuropathy that anybody has seen? Now, would you like to stop and discuss this at this point, or should we have all of our discussion at the end?
Whatever way you want, Claire, whichever way you want to take it. If you want to ask the panelists, you can. Dr. Revati, would you have any comments? Other panelists? How do you want it, Claire?
Yeah, so I would really like to know if anybody has seen isolated rifampicin optic neuropathy. So this is not a patient with TB. He's not on isoniazid. He's not on ethambutol. It's purely rifampicin for his pruritus from his liver problems. And so do people think that this is something that's possible?
So senior most neuro-ophthalmologist here, one of the senior most, Dr. Plant is also here. Dr. Neil Miller has already written with 2 exclamations and a question mark, rifampicin optic neuropathy. So
we saw a couple of cases a while back. I mean, we all grew up with the fact that INH can cause an optic neuropathy, but I think that we had a couple of cases some years ago of rifampicin optic neuropathy, and there was a study from Turkey, I think, where they looked at they checked this with a bunch of rabbits and were able to see evidence of optic neuropathy in the animals as well. So I think it exists. I think it's really rare, but I think it exists. But here we don't know what structure is involved yet. And that's the crucial issue for me. Is I teach the residents, whenever you get to the end of the exam and you don't know what structure is affected, rather than doing a whole bunch of tests, you need to do to find out what structure it is. OCT is helpful, as we saw with Helen's case, for structure, but not necessarily for function.
Helen?
You know, you go for, we need functional studies.
Sorry, Claire?
Yes.
Claire, did the patient notice any difference with light level on his symptoms?
That's a very good question. So shall I carry on? Because I think that Neil and Gordon are kind of really getting to the crux of the case already, as I knew they would. So I guess I didn't find the Turkish study on rabbits, but I did find one on rats, Neil, and they actually gave the rifampicin as an intraocular injection, and that caused retinal ganglion cell damage. So if you give rifampicin intravitreally in a rat, perhaps not so good, but I couldn't find anything about oral use of rifampicin, and I didn't see the rabbit one, so my apologies, I missed that one. So look, rifampicin, as we've said, is often used with ethambutol and isoniazid, which certainly can cause an optic neuropathy. But I really wasn't convinced in the literature that I could find any cases of isolated rifampicin optic neuropathy from an oral intake. So exactly as Dr. Plant and Dr. Miller have said, unexplained sudden central vision loss. We've got normal optic discs, normal retinal appearance. What do you do next? Well, obviously, you would go back and take a more detailed history, which Dr. Plant was suggesting, and the patient said he stopped driving at night because he was really struggling with his night vision. We also went back through his medical history, and late last year he'd had a gastroenterologist, and at that point he lost 10 kilos in weight. I don't know who's drawing on my slides, but thank you. We went back and reviewed the MRI and the blood tests, as you should always go back and have a look at the images yourself. And as Helen in her team, you go back to an MDT even if you're not sure. But the patient's MRI brain and orbits was completely normal. The only bloods he'd had was a full blood count, kidney function. His liver functions were obviously abnormal, but stable. He'd had a VDRL, because everyone in Sydney gets tested for syphilis, that we just test everyone for it. ACE, ANA were normal, but no other blood tests were done. So look, we've got unexplained sudden central vision loss with normal discs, normal retinal appearance, night vision difficulties. And so the further investigations for unexplained vision loss in a normal fundus with normal OCT, exactly as Dr. Miller said, we've got to work out where the functional abnormality lies. So at Sydney, we have standard VEPs, but we also have this multifocal visual evoked potential, which displays a printout, which is very like a Humphrey visual field. So where you see the little dark patches, that is where the VEP within the visual field was abnormal. So in this patient, what this printout is showing with the right and the left eye is that we've got reduced amplitudes of the visual evoked potentials in that central area of the visual field that was tested, very much matching the patient's Humphrey visual field. So we've got reduced VEPs in the area where he had poor visual fields. So bilateral central reduction in VEP amplitudes, we're done, right? He's got an optic neuropathy. We're going to write this up. First case of definite rifampicin optic neuropathy. What do we think? Are we done, having proven that the VEP is abnormal?
The problem is you don't know if the VEP is abnormal because the retina is abnormal. And what we've learned the hard way is that we never do, or almost never do, a VEP without doing an ERG as well.
At Millfields, a VEP is never, ever done without an ERG.
Absolutely.
That's been the case for decades.
I completely agree. But what we sometimes find, particularly with our neurology colleagues, is they've got VEPs themselves and they'll finish at that point. So part of this case was definitely to say that a VEP cannot be interpreted without a test of macular function, and particularly, well, certainly my institute at the Safe Sight Institute, we have pattern ERGs as well as multifocal ERGs, which are great tests for macular function. And the patient also needs a full field electroretinogram. So this is the patient's ERG, and I've got the right eye, left eye, and an example of what would be a normal trace for our institute at the bottom. So the dark adapted 0.1, this is the rod specific response. And so what you should see is a nice waveform with this B wave showing the rod responses in the dark. And in our patient, you can see that these responses are subnormal compared to what we would consider a normal response. The dark adapted 3.0 is the bright flash in a dark adapted retina. So you get dark adapted cones and rod photoreceptor responses in the A wave, and then the inner retina function in the B wave. And in this case, our boxes here are showing us that the A wave should be hitting down into this area. So we've got reduced photoreceptor function in a dark adapted retina in this patient. We've then got the light adapted 30 Hertz flicker response. So now the patient's in a photopic setting, and you've got a 30 Hertz flicker, and this is a cone specific response. And in our patient, it's looking pretty good, but I'll show you in the next slide that these responses are just a little bit delayed compared to where they should be. And then we've got the photopic single flash ERG, which shows the cone photoreceptor and again the inner retinal responses, which weren't too bad. The main abnormality in this particular case was that this patient's dark adapted rod responses are very reduced compared to what should be the normal 290 microvolts. Our patient was 40 and 60, and the cone responses were slightly delayed, which shows some cone dysfunction, not loss of function. In addition, at the end here, you can see we've got the pattern ERG. So this is our test of macular function. We should get a nice P50 response, which is predominantly driven by the macular photoreceptors. and the N95 waveform, which is the retinal ganglion cell response. And in our patient, we've just got noise. There is really no macular function for this poor patient. And so it's a nice example of showing that you've got reduced macular function. And so the abnormality on the VEP is consequent on this particular. So just in summary, we've got reduced rod-specific ERG, we've got borderline amplitudes in dark adapted mixed responses, cone flicker and slightly delayed. We've got loss of the pattern ERG to the central 15 degrees. So this combination of rod photoreceptor abnormality with a bit of cone dysfunction and a maculopathy. So the question at this point is whether this is acquired or a late onset inherited disease. And that can certainly happen. You can have patients presenting much later in life with these inherited diseases we're finding now in our cases. So the potential could be a retinitis pigmentosa, but there's no pigmentary retinopathy. Iguchi's disease can have this much more rod abnormality compared to cone abnormality, but it's incredibly rare and he's not showing the typical golden fundus. The acquired cases could be siderosis, zinc deficiency is associated with night blindness and a reduced scotopic ERG, and vitamin A deficiency, which I think a couple of people in our chat have already started to twig onto as a cause for this. And that's exactly what this patient had. So when we went back and tested him, he had a vitamin A deficiency. He also had vitamin K and D deficiency. He was given 10,000 international units of vitamin A twice daily. And 3 months later, his night vision was subjectively improved by about 85%, and his acuity had improved from 6.9 to 6.7.5. And I thought this was a really nice example. This is from a case report of someone who was actually given intravenous vitamin A, showing their scotoma that they're hand drawing in the hours post-injection, showing how their visual dysfunction improves really rapidly with the time on that. So this was our patient 2 months post-treatment. His dark adaptive responses have returned to normal. His cone flicker responses have also normalized, so there's no further delay. And his pattern ERG responses are now really nicely visible and back to normal. So malabsorption of vitamin A has been well documented after gastric surgery. It's one of the fat-soluble vitamins. And don't forget this patient had had a cholangioadenectomy as well as having liver problems. He'd also had that severe gastrointestinal illness with 10 kilos of weight loss pretty much at the time of the onset of these visual symptoms. And so a febrile illness can increase metabolic demand for vitamin A and cause what would appear to be quite a sudden change in vision. And so it presents like a sudden loss of vision where we normally think of B12 or one of those other vitamin deficiencies is causing a much more gradual deterioration of vision over months. So vitamin A is the one nutritional deficiency that can have quite an acute onset, typically in children after a bout of measles, but also seen with severe gastroenteritis and bronchopneumonia, and they can lose vision in both eyes within a few days if their vitamin A was borderline. So nyctalopia is probably the most common kind of finding in terms of visual dysfunction because the retinal combines with the opsins to create rhodopsin, and you require a constant supply for phototransduction. So disease is typically seen at less than 20 micrograms per deciliter. Normal levels are 30 to 40. They may present with a dense scotoma due to congruent areas of retinal involvement. You might see these small intraretinal dots with focal loss of pigment at the RPE, like in this picture, which our patient didn't have, and we never found it despite imaging him several times. The visual field typically recovers in about 1 to 2 weeks after oral treatment, and the lesions will fade out. I just wanted to show, because I'm seeing in the chat a couple of people are sort of questioning macular dysfunction with vitamin A. And it has been reported, this was a study from the Moorfields group, and 2 out of their 3 cases of vitamin A deficiency did have reduction in pattern ERG. And this is really not commonly reported in the textbooks, which is why I thought this was quite a nice case to present as well, because it does show that you can get this central loss of function as well as the typical night blindness that we're perhaps more used to seeing.
Claire, that was actually one of the things that fascinated me, was the pattern ERG, because with the N95 and let alone the P50, do you think this is a transsynaptic degeneration of the ganglion? Are the ganglion cells still there but not working because there's no transmission, or is there actual loss of ganglion cells in these patients?
I think it's that the photoreceptors aren't driving the ganglion cells, because the P50 is not there. So you know that the macular photoreceptors aren't driving that N95 response. And that is why that the VEP is then also reduced. We never saw any loss of his retinal ganglion cells on the OCT structurally, and he made an excellent recovery on both that N95 response and his VEP after treatment. So I do think it was purely a dysfunction related to the macular photoreceptor.
It just shows you that you can have a wipeout of the pattern ERG in certain things and still have potential for recovery.
Neil, the point here is that the cones are affected in vitamin A deficiency.
Yeah.
I mean, the reason I was talking about light level, of course, is that with optic nerve disease, patients do have very interesting differences in how their vision is at different light levels, but nothing like what happens with photoreceptor disease. But this business of the cones being involved was first brought home to me by a patient with vitamin A deficiency who was a photographer. And he said that his vision was like looking through a yellow filter. And we were able to show, he's probably one of those Moorfields series. We were able to show that there was cone involvement. It just comes later and is less dramatic, but it responds equally rapidly. I mean, we did ERGs the following day, and they were back to normal after his vitamin A supplements. Of course, with very prolonged deficiency, you can get more permanent damage, I'm sure. But there is cone involvement with vitamin A deficiency.
Yeah, I think we were seeing that with this case, Gordon, that he was just had that early dysfunction, but his loss of function was just very borderline at this point. So
I think it explains the pattern ERG. It explains the pattern ERG. There was a reversible photopic deficit.
Yeah, thank you.
Okay, so with that, Dr. Revati, you're the panelist, discussing for this case. Any comments from you?
No, I think most of the points have been already brought out. I was just listening to the various speakers here. Very interesting case.
Thank you. Thank you. With that, if Claire, you'll stop sharing your screen, I'll introduce the next speaker. That is Dr. Celia. Dr. Celia is now a clinical professor at the University of Australia. Just give me a moment. So it's my honor to introduce Dr. Celia Chen from South Australia. She is the clinical professor in the Flinders University, Adelaide, South Australia. She is currently the president of Neuro-Ophthalmic Society of Australia, and she completed a prestigious Neuro-Ophthalmology fellowship at Wilmer Eye Institute, Johns Hopkins Hospital. She has over 90 peer-reviewed papers in the leading journals, and she is also a recipient of American Australian Education Fellowship. Also a recipient of South Australian Science Excellence Award and Asia Pacific Academy of Ophthalmology Achievements Award. So with that, I invite Dr. Celia Chen to share her case with us.
Okay, thank you very much. Okay. Okay, can everybody see the slides okay? That's great, thank you. All right, so my case is titled As Rare as Tasmanian Tiger, and that's a picture of this Tasmanian tiger, which is thought to be extinct. So hopefully as the case goes on, you understand why I use this title. Okay, so this is an 18-year-old girl, and she came to me for a fourth opinion regarding her loss of vision. Now, I'm going to present the case in chronological orders about what happened when it first started and some of the information where I feel like archaeologists having to sort of go back and keep digging and get all the records. So it actually all started back in 2010. At that time, she was 17 years old, and she was actually sitting the exam to go into the university with a lot of stress. And she went to the optometrist complaining of blurry vision. At that time, the optometrist noted the vision being 6 on 24, 6 on 9.5. And she was having trouble seeing the blackboard. You can tell that that was the days before the smart board or the whiteboard. And so family were obviously very anxious and sent her to an ophthalmologist. She was referred urgently for suspected optic neuritis given her young age and acute decrease in vision. The first ophthalmologist saw her within a week of the presentation. And remember how initially her vision was 624 and it is now 6 on 60 in that affected eye. Okay, did not improve with refraction. In the notes from the first ophthalmologist, there was no mention about relative afferent pupillary defects. And all I could see from his notes was that this person commented on bilateral nasal optic margin being blurred, but did not have any fundus photograph. Okay. And the person did do a visual field. This is a Medmont visual field. And I know that with automatic perimetry, there are different visual fields. I go by what Helen taught me, the grayscale is where you put your coffee cup. But in most of them, you actually can see something that's equivalent to pattern deviation. And in this case, the equivalent of pattern deviation is seen here in the bottom panel. Okay. Now, the second ophthalmologist then saw her. So at that time, the general ophthalmologist, the first person referred her to a neuro-ophthalmologist. The vision was 6 on 60, 6 on 12. And the Ishihara plates, and I don't know what it means by half correct or all correct, whether they did it out of all 38 plates, and meaning half of it was correct. But the neuro-ophthalmologist did comment that there was no RAPD detected. And that is why that ophthalmologist was actually quite suspicious with a vision of 6 on 60 and 6 on 12, but no RAPD, that this is a young girl who's going through a stressful time. This is her way of calling for help. And he actually diagnosed her as functional visual loss. So poor girl sort of struggled through her year 12, didn't end up doing very well, didn't get on to university. And by the end of that year, her vision was 6 on 60. The parents were absolutely tearing their hair out and trying to get some answers. The third ophthalmologist at that time, in his notes, he did say bilateral optic dysplasia. And this third general ophthalmologist has done ERG and VEP. And we'll be talking about that in a later slide, as some of the comments were made earlier that you should always do them together. The ERG was normal, but the VEP was abnormal. And so this third general ophthalmologist thought that it's worth having another look. And that's when it's been sent to me. So I saw the person almost 1 year after the loss of vision. And she is an 18-year-old girl at that time, no past history. She's on oral contraceptive pills only. Now, she says that she's a social drinker, which I know in Australian standard can mean different things to the rest of the world. And she was with her mother. I wasn't going to get any answer. And this is her family tree. She's got a brother who's unaffected. The mom's side did not have, well, to the mom's knowledge who came with her, there was no one that's affected. The father's adopted, so we don't have any history. So it's thought to be quite an isolated situation in the family. And when I saw her vision was 6 on 120, 6 on 76, no RAPD, and I checked with a natural density filter too. And with that vision, she was only able to see gross color in both eyes. Okay, she wasn't able to do a visual field in the right eye, and this is the visual field in the left eye. Okay, now remember earlier on we had a Medmont perimetry that shows something that looks like a central scotoma. And in this case now, we definitely have got quite a fair bit of loss of vision. And this is a fundus photograph. Okay, I see a few people leaning in to look at it. And I think all of us would be saying, yep, that doesn't look good. That looks pretty pale. There's nothing I get more worried than a swollen nerve, and that's a pale nerve. Okay. And so that's a high definition. And as you can definitely see that we are seeing optic dysplasia. Okay. And I'll come back to this photo a bit later as well. And this is OCT, fairly much at the floor level. And I think Neil here has a nice paper with Carmen talking about what's the floor effect. Most people think that, if you still have 50, you are quite safe, but in serous, it's about 60. That's actually the floor effect. And the ganglion cell is circumferentially affected. So what's going on? Okay, so I came from the New Miller School of Neuro-Ophthalmology. So I did with bilateral loss of vision, and I think all of us have our own little sequence thinking about if it's bilateral, is it toxic nutritional, is it infiltrative, is it compressive? So, and a lot of it is also because she's had 3 neuro-ophthalmology opinion, previous MRI scan, a lot of it is also chasing what was done before. And definitely toxic nutritional screening, including vitamin A, no previous surgery, no vitamin B12, B6 deficiency, vasculitic screen, all normal, infectious screen, pretty unremarkable other than previous herpes zoster infection, and MRI scan, and I never take as face value, but I did get the neuro radiologist to have a look, and especially with the previous concern whether it's an optic neuritis when she first presented, squeaky clean. Okay. Now, at this point, what else would people like to do? I'll open it up to the floor at this time.
Would you think of doing a GCC IPL screening? Means it actually could have been done, and this is the first change which occurs on the OCT, but in this patient already the changes are there.
Yes, the changes are already there, as you saw from the nerve fiber layer thickness. Okay. And as I said, my job was actually playing detective Celia, because a lot of things were sent before, but that's actually a scary thing. Some of them were not followed up, and I had to look at, I actually have to contact each of the lab and say what was sent. Sorry, that were just more images of the spinal cord, and that definitely there was no spinal involvement, being a bilateral. Very topically, are we talking about MOG or MOGAD disease? And that was all negative.
Celia,
yeah.
The MRI was done at the time the OCT was done?
The MRI was, we've actually got 2 sets of MRI. The first one was actually done by the first ophthalmologist in April, which is within 1 week when she was suspected of having optic neuritis. The second MRI was done by me, and I did ask for all the correct sequencing, including T1, and also with compressive, also looking for sort of T1 fat suppression, and also the being a bilateral process, whether it is an infiltrative process, and that was definitely all normal.
The chiasm is looking very healthy in the MRI. It's not looking thinned out. It's not going with the OCT images.
Hang on, go back to that MRI. Here we go. We got the chiasm here. So you can see that we do have a chiasm here. Okay. And I'm sorry that I should have given you the axial, and definitely the chiasm looks pretty good. I think you're thinking about chiasmitis, is that right?
No, not chiasmitis. I was asking, was this a progressive kind of decrease, or it was like
it's a sequence. Okay, well, we're definitely seeing sequential. Okay, so remember the right eye was affected 624, 660, 6120. But then the left eye was affected. So we're dealing with a bilateral sequential progressive loss of vision.
Subacute.
Okay, so yes, what else could it be? We've ruled out toxic nutritional, infiltrative, compressive, and inflammatory. What else could it be? Well, at this point,
it's open to discussion to all the panelists. Professor
Looks like
Sakshi. I think everybody in the chat has written LHO.
Oh, very good. Very good. And lo and behold, yes.
Dr. Miller started it and everybody's kind of agreeing to it. But we should have some differentials from the panelists. What else it could have been?
It's interesting to see that actually a Tasmanian tiger is not actually a tiger. So maybe it's the LHO and something else.
Oh, you're thinking we've got a masquerader here. All right, I'll tell you about the tiger story in a second. Okay. And so, yes, lo and behold, this is definitely, as we said, we have to go through the surgical sieve process. Okay. And so don't forget, very importantly, genetic, okay, especially in a bilateral sequential loss of vision of a subacute onset. Okay. Now,
Celia, I wanted to emphasize that lack of an RAPD at the time.
Perfect.
It was unilateral.
Absolutely. I'm coming to that. I've got a slide on that.
Okay. All right. I'm sure
I'll get you to comment at that point. Thank you. Okay.
No, I'll
so
shut up now.
No. And I'll be, thank you. Don't steal my thunder. So we are dealing with a case of Leber's hereditary optic neuropathy. Okay. Now this is her disc. Okay. And remember how we said that it's dispalar. Another interesting thing is that usually, and I hope the bottom one is normal because that's mine, we should be able to see this nerve fiber layer. Okay. And I still use a red free, but what happens is that notice how in this case for a 19-year-old girl, we're not seeing that nerve fiber layer. Okay. And this feature is quite well described, is that we usually sort of start seeing the temporal nerve fiber layer thinning. In previous days, we used fundus photograph. And in these days, we've got OCT, and that's one of the features that's quite well documented, is that the temporal nerve fiber layer loss is the first thing to go. Okay, now, why the Tasmanian tiger then? Okay, so the nice thing in Australia is that we've got David Mackey, and he has a very keen interest in Leber's, and he's actually gathered all the cases in Australia, and once you find a mutation, you go to him and say, I got this mutation. He is able to trace it. As it turned out, we thought that this is an isolated case, and also another thing is that a lot of people still think Leber's happen in male. There's a confusion about X-linked versus mitochondrial. Mitochondrial can happen in female, okay? And I still have sometimes people say to me, it can't be, this is a female. No, yes, it can be. Female can get mitochondrial disease. And remember her family tree, she was thought to be isolated. As it turned out, she's actually linked to one of the biggest family in Australia with Leber's, which spans over 5 generations, over hundreds, about 100 members that's affected. And just because the family has moved from Tasmania to South Australia, we were still able to trace it and connect her with all the long lost cousins. Many of them have got vision loss. Okay. And as you can see, this is from the Australian population. The mean age is around that 16 to 19. Women do get affected, but it's about 1/5 of male. Just because it's called maternal mitochondrial inheritance doesn't mean it can't happen in female. Okay. Now, one big thing is, remember how just because she didn't have an RAPD, she was thought that she was functional. How many people see the hidden message here? LIAR. Okay. Now, I'm not asking you to always be suspicious, but and this is one thing I actually learned from Neil, is that if someone's got no RAPD when there's unilateral loss of vision, think about Leber's or think about whether there's something else going on. And why Leber's? This was actually described as early as 1995. And I remember when I presented once in Japan, the guy Wakamura actually came up and sort of expanded on his theory. His theory is that there's a preserved M ganglion cell population, which I think now we call that the melanopsin ganglion cell. And remember, that's 1995 before we had all the research on that. But another school I have heard, and which I'll be interested to ask the panel, is that we sometimes, because there's subclinical events already happening in the other eye with the ganglion cell loss, and that is why you don't get RAPD. So, Gordon, what do you think? Do you think it's the M ganglion cell, or do you think it is because there's already subclinical events in the fellow eye?
Celia, I think you're simplifying the history of this a little.
Okay.
Because it was always controversial when it was purely based on measurements and so on. It was always controversial. And then, of course, because the cases inevitably become bilateral, you then have the problem of that we can't really say that a pupil light reflex is abnormal in an isolated eye. So it was always controversial. And I think what Alfredo Sadoun showed with the pathological study was that the IPRGC cells probably are affected, but less so. So I think it fits nicely with the literature that the pupil light reflex, sometimes people find an RAPD, sometimes that they don't with labors, but overall, clearly it's less affected. I mean, someone with a 661 eye and still normal vision in the other eye, whatever else is going on there, you'd expect them to have an RAPD. So I think it's that little controversy over those years has been explained, and the fact that it was controversial was because it's not an absolute sparing, it's partial.
And as you know, in the study, the bromonidine study, Nancy Newman found that even when it looked like it was purely unilateral, she could identify small scotomas in the, quote, normal fellow eye.
Yes.
But I have to admit that many years ago, as you showed there, Celia, 1995, in 1994, Wakakura, I was at a meeting and Wakakura came up and talked about his theory. In those days, we didn't know about the intrinsically photosensitive ganglion cells. And Wakakura was really the first person who said, I just don't see an RAPD. And I thought he was nuts. I thought he was absolutely wrong. And I've always felt bad about that. But I think that it's probably some sort of combination. As Gordon says, the IPRGCs are affected, but as Alfredo and others have shown, not nearly as much. But there is also at least some degree of anatomic damage to the optic nerve, even when there is apparently a unilateral process.
This is Dan. I have just a remark just to complement what Neil and Gordon were saying. So I was part of that study with Sadoun, providing the ADOA patients to that study. And it was absolutely fascinating that there was a sort of resistance to neurodegenerations of those IPRGCs for a reason that we don't know. But not only with the pathology by Jens Hannibal in Copenhagen, who's the expert at immunohistochemistry, but also the melatonin profiles in those patients were remarkably preserved. And number two, we also had the chance to see in Copenhagen a patient with a strictly unilateral, I mean, what was strictly unilateral, believed LHON, and we did a pupillometry, quantified pupillometry, and the deficit of the recovery, which is the measure of the pupillar response, which is a measure of the IPRGCs, was minimally affected, 10 to 15%.
Okay, thank you for that.
There does seem to be a similar situation with DOA. That, of course, is more difficult because it's always symmetrical.
But it's fascinating.
We've also looked at circadian changes in those patients.
Right. So, it's a fascinating
bilateral effect.
Right. I think it's a fascinating thing that this goes beyond LHON. It's something about all the mitochondrial disease, and we don't know what yet.
Very interesting. Oh, watch the space. And again, just going back to whenever someone has got bilateral sequential or cause loss of vision, before you commit them to non-organic cause or functional vision loss, always think about what else could it be. And going back to that electrophysiology, and remember how the ERG was normal, but VEP was abnormal. And, and this was from my fellowship days. I still have that little diagram in my head, which is in this situation, we need to think about if the ERG is normal, VEP abnormal, we're dealing with optic nerve and beyond. And so definitely trust your patient. Okay. And as we just heard that, in hereditary optic neuropathy, people think about dominant recessive X-linked, but don't forget the mitochondrial. And just because something is mitochondrial, it is not sex-linked, which means that it's maternal inheritance, but can still happen in female. And so the teaching points from this case is that labors can happen in women. It's not a Tasmanian tiger. It's not extinct. It's still there. Okay. In sequential occult loss of vision, think front to back and exclude organic causes. Okay. And in investigation for the occult visual loss, we all have our little sort of surgical sieve, but always remember the electrophysiology test and genetic testing will be important in this case. Thank you very much.
I also wonder, and I'd be interested in the panel, it is said that in children, labors, and I don't know if this woman is really considered a child or an adult given the age, but labors is much more subtle, much more autosomal dominant like in children as opposed to adults. And adults, as we all know, it's generally an acute process, rapidly progressive. But in children, it may be much more subtle. I wonder if that's the panel's experience.
I saw quite a number of patients with children, and I feel that the prognosis is for sure better in children. Now, what I don't know, children when they are small and having it is maybe just their ability to manifest symptoms, and that's the difficulty to understand if it was really acute and manifest or not. And another thing that I can just intervene with two things is that, so apparently one of the prognostic factors is the CD ratio, which could be interesting in LHON. And another important thing, I think, I don't know what Celia's opinion of this, it's interesting, Neil, you said it's almost like an autosomal dominant, because this year there have been described a couple of nuclear genes that manifest as LHO. And I think it is a very important thing, because our lesson was if a father has labors, the kid will never have it. And that may not be true anymore. And this is true. It's a couple of months old info.
Okay. Can I just say something about the electrophysiology? In Leber's hereditary optic neuropathy, because it's a primary retinal ganglion cell pathology, you'll lose the Apnea N95 very early. And so in a very early optic neuritis, if you've got quite a distinct loss of the P50N95 ratio, that's a really good sign that it's a Leber's rather than any other optic neuropathy, because that takes time for that P95 loss to come back. Down, back down the nerve. So that would be really helpful in one of these cases.
One other thing may be that, when we first started seeing the 11778s, the Mishima basically said, they're only about 4% will recover. It looks like it's a lot higher than that, even in the 11778s, maybe as high as 25% will recover usually in a year or two. So I think while it's not super good news, it may be a little bit better than we thought when we first started seeing these cases.
I think, David, so there was a little paper out which Claire and I are both on board as well from David Mackey's group. When we look at the Australian population that came out in Human Genetics recently, they said it's 7.3 in the Australian series. And another interesting thing is we're talking about the younger population. As I said, in Australia, being a little island, and it's quite a defined population. After this family, that just says all the South Australian ones, there's a bit of a lead time bias because of the family. They are presenting earlier in their teens, about 10 years old. And just last week, I saw one of the boy who's 10 years old, extremely mild. And again, whether it's because, again, the awareness rather than waiting for things to go too far before they present.
How has this patient progressed over the last 10 years? Is she still under your care?
She's still under my care, but as we were saying that even in 2011, if you look at the OCT scan, it's fairly much already at the flow effect, and the ganglion cell loss was already circumferentially wiped out. At that time, her vision was already 6 on 120. Her final vision is hand movement in one eye and counting finger in the other eye with no recovery. At that time, it was 2011. It was the days before Idebenant was on the special Medicare scheme, so she did not get the idebenant.
Generally, they say if like smoking and fumes, paint fumes and all can become a trigger for worsening. So this, I know she is a young girl, and was there any such history that could have?
I didn't get any, but as I said, you know, Australian standard of drinking could be different to the rest of the world, especially for a young girl who says she's a social drinker.
Because on one hand, she was on oral contraceptives as well. So we can't really rule out as an age factor holding that back. And the other thing is, can anything be done? What would the panel's view be as to how we can help them retain their vision? Or because there is a lot about giving them supplements of nutritional supplements. What is Dr. Neil's or Dr. Gordon's opinion on that?
My philosophy is if you have a good diet, you don't need nutritional supplements.
I think every country differ, and so for instance, for those with the proven mutation in Australia, you can get idebenant through a special scheme, and that's subsidized. But also, a lot of the patients are quite resourceful. The families are pretty desperate, and they will source their own medication if they want to.
So I think with that, we'll move to Clement's case. A wonderful case and a very interesting discussion. Really enjoying. So let me invite Dr. Clement Tan. I'll be sharing my screen. So it's my pleasure to invite Dr. Clement Tan, who is the Cluster Director for Ophthalmology at National University Health Services, Director of Division of Graduate Medical Studies, National University of Singapore. He's also the co-chair of the Joint Committees on Specialist Training in Singapore. And he says he struggles to balance these interesting portfolios in health administration and medical education with his first lab, that is clinical neuro-ophthalmology. So with that, I invite Dr. Tan to share his case.
Thank you very much. Can you all see my slides, I hope?
Yes.
Okay. So let me just jump straight in. Good morning, good evening, and good afternoon to everyone. And it's really great. I just want to say again, Satya, it's so impressive how you bring the whole world together for all of this. So let me just get straight into the case. This patient is a 74-year-old Chinese man with a past medical history of hypertension, hyperlipidemia. He had his prostate cancer successfully treated years ago, but then he came down with Philadelphia chromosome positive B-cell acute lymphoblastic leukemia. He was treated with dasatinib, prednisolone, and it responded, but he could not tolerate more aggressive chemotherapy or an allogenic transplant. He had a relapse 2 years after first being diagnosed, after what was a first remission. This was a bone marrow relapse. And then he had more chemotherapy. And then the next year he had a central nervous system relapse and again was treated with more chemotherapy. He presented to an eye department in March of 2016 with progressive worsening of vision in the right eye over 6 to 8 months. And it was attributed to cataract progression due to steroid intake because he had quite a significant cataract. No afferent pupillary defect was detected at that time because the patient, as I suppose in the protocol of the clinic, had been pharmacologically dilated before the ophthalmologist saw the patient. But the disc was noted to be normal in appearance. So he underwent uneventful cataract extraction with a multifocal lens implant. But then at the first post-operative week, there was no improvement of his vision. And in fact, he said it was worse. This time, someone saw an afferent pupillary defect, and then there was, as you can see in the photograph, pallid diffuse swelling of the right optic disc. The Humphrey visual fields were all very unreliable, so I've not shown them here. was in view of his past history, he was admitted urgently for neuroimaging, and you see that the MRI shows a thickened and contrast enhancing optic nerve, right optic nerve, which was thought to be consistent with infiltration. So he underwent a lumbar puncture, and he was given intrathecal chemotherapy. He was the CSF eventually returned B-cell lymphoblast on flow cytometry. He continued to be treated with chemotherapy and some prednisolone. And 6 months later, his vision had more or less returned to normal, although it was still a afferent pupillary defect, some mild temporal dispel, but no more swelling. And so the oncologist continued to treat him with chemotherapy, intrathecal chemotherapy as central nervous system prophylaxis, and eventually the CSF was negative for blast cells. So this is his first ophthalmic plus CNS relapse, and it appears that remission was achieved with intravenous and intrathecal chemotherapy. A year later, though, he presented again with declining vision in the right eye over 1 to 2 months. This vision was hand movements with a significant afferent pupillary defect. And again, he had mild diffuse disc swelling, as you can see from the photograph. Again, the MRI showed what looked like recurrence of the right optic nerve contrast enhancement, thought to be the infiltration again. This time, the CSF was negative for lymphoblasts. And he was retreated with steroids and chemotherapy. His vision recovered very quick within a month to 6/9, but because he had toxic leukoencephalopathy from the intrathecal chemotherapy, this was discontinued, and so he was deemed unsuitable for further treatment with chemotherapy at that point. Thereafter, he had various other illnesses, including a pneumonia, and he was not seen in the eye clinic for a while. So this is his second ophthalmic relapse, and the vision seems to have recovered with intrathecal chemotherapy, but the question is he in remission? Finally, he presented again in the few months after that, at the end of the year, the same year of his second relapse, and this time he had lethargy, and he had a right-sided painful proptosis, as you can see from the photos. There was an afferent pupillary defect. The eye was proptosed, there was chemosis, injection, and you can see from the Optos photograph, palate disc swelling, but this time with diffuse retinal hemorrhages and even a cherry red spot, but no vitritis. So the MRI again showed the right-sided proptosis with this time contrast enhancement involving all the orbital tissues as well. And of course, his blood markers showed that he had, something that looked really inflammatory or infective. So in view of what looked like an orbital cellulitis, there was consultation with the primary hematologist and infectious diseases physician, and he was commenced on amphotericin B and piperacillin and tazocin. The lumbar puncture showed a normal opening pressure, normal protein, glucose, white cell counts, with a differential of lymphocytes of non-B cell origin. Smears for and cultures for bacteria and fungi were negative, but the Aspergillus galactomannan antigen was positive. So in view of that, the amphotericin B was switched to voriconazole, but the serum galactomannan and Aspergillus PCR were negative when they were finally returned. With the worsening of the orbitopathy despite the antibiotics and antifungals, the decision was made to start him on some oral dexamethasone, and that seemed to bring about a dramatic improvement over the next 10 days. So then, with the discussion with radiation oncology, infectious disease, and hematology, it was decided that he should undergo a course of radiotherapy, but they wanted tissue diagnosis first. So this time he had a right optic nerve sheath biopsy, which was performed by the oculoplastic surgeons. And this showed CD45 positive large cells, which then were suspicious for the recurrence of the B-cell acute lymphoblastic leukemia. He was commenced then on palliative orbital radiation therapy, and the antifungals were stopped. But as he was being observed for response, he then had a hospital-acquired pneumonia, desaturated, and then he passed away within a week. And so this is the third ophthalmic relapse with an attempted radiotherapy, but the patient unfortunately died from pneumonia, and we never got to see the effects of that radiation treatment. So in summary, this is a 74-year-old man with a recurrent acute lymphoblastic leukemia with relapses in the bone marrow, the central nervous system, one ophthalmic relapse with CNS, one ophthalmic just orbit and optic nerve, and finally one more with the orbit. And so I guess the question for discussion here is, why did he have so many ophthalmic recurrences, and what can we learn from this case? And so perhaps at this point, I'll just open it to the panel for discussion.
So any comments from the faculty here? I think Rashmin was to discuss the case. He's not there. The other panelists.
I have heard that in some of the cases, the chemotherapy does not get to the orbital region, and they actually need to use neural intervention in order to be able to deliver the chemotherapy directly to that area. Could that be one of the reasons why this person has got a lot of the orbital situation, just because basically the eye is in a privileged area that is not responding to the conventional treatment?
Yeah, so I think that's one of the thoughts that we, in retrospect, had, that maybe the chemotherapy, whether both intravenous and intrathecal, did not really completely eradicate the leukemia in the orbit. Although he had very good clinical response and his vision returned back to normal with the first 2 rounds of treatment. There was a
Yes, Dr. Tan, you can continue. I'm sorry.
So there is of course some literature out there to say that such patients ought to also at the same time have orbital radiotherapy at the same time, and there are numerous case series where patients have combinations of chemotherapy and orbital irradiation, and it seems to suggest that there is a reduced rate of recurrence of the leukemia with the addition of orbital radiotherapy, and I wonder what the experience of the panel is like in such cases.
Dr. Miller, Dr. Gordon Plant, Dr. Andrew Lee, and all the.
I'd certainly agree with that, and I think that with when you have a combination of a systemic disease, but with very, very local features like this, I think our oncologists would generally recommend local treatment, local radiotherapy. Neil has a lot more experience with.
Yeah, we would do exactly that. I mean, I don't have any more experience than the rest of you. I mean, we've seen these cases, and we give systemic and local therapy as early as we possibly can.
I would just echo the immunoprivileged thing, because a lot of these newer agents, the biologics, don't penetrate into the orbit, the eye, or the CNS. And so even though they have a peripheral blood smear might be normal, or their bone marrow might be even clear, and yet they have an extramedullary central nervous system relapse. So I think the whole immunoprivileged thing is the driver. So we are doing the same thing as Neil and Gordon, offering adjunctive radiation therapy.
I think the hardest thing is convincing people. I mean, it's easier if the MRI is abnormal, but sometimes, as we heard from the first case, from Helen's case, it can be confusing if there's not an overt abnormality of the optic nerve in these cases of leukemia. And we say, well, we're worried about infiltration. And the radiotherapists say, well, we don't see any sign of it. We don't want to radiate. And we've been sort of doing it almost like germ cell tumors, let's try some radiation and flow and start it and see, because sometimes these things will respond to very low doses of radiation. I mean, 2000 centigrade, or 20 gray, and not have a problem. But we're, having lived through those days, as Gordon intimated, that we're very aggressive in terms of radiation therapy for presumed or definite infiltrative process.
I do agree, Neil. If there's nothing to see on the scan, it's harder to convince people. But I think that's part of our job so often, isn't it? In neuro-ophthalmology, we're convincing people that's where the problem is, even though the scan doesn't support it. And going back to what you said there, Andy, I'm certainly beginning to think much more in terms of the compartmentalization. I think that's the word, compartmentalization of the immune system. And we know that the CNS compartment has its own integrity, and so does the uveal compartment, and so on. And the optic nerve is kind of at the border zone of these. So I think this is with these immunotherapies, this becomes very relevant again, just as we've been thinking of it in terms of NMO and with a systemic immune response, and MS with a CNS compartment response, and so on.
Yeah, and I would echo that by saying it's not only compartmentalized, but it can lead to a compartment-like syndrome. So that whole, it was in the sheath, that's what caused the combined CRVO, CRAO, the penetrating portion at the dura. That's a very unusual presentation, that both a CRVO and a CRA, it really puts the lesion right in the sheath at the penetration of the central retinal vein and central artery. So I try and convince them, look, this is a palliative thing for their vision. We don't have time to be waiting for your systemic chemo and your systemic intrathecal thing. We need to relieve this infiltrative compressive compartment syndrome right now. So it works.
How can you, Andy, how can you differentiate between a sheath process compressing the nerve and infiltrative effects on the vessels? I'm not sure I could be sure.
It doesn't matter.
No,
to me, it doesn't matter. You're going to radiate it because.
Yeah.
But if you try and explain that infiltrative in the wall thing that's not going to work. It has to be really simplistic explanation, I think, to get them to do it.
Yeah.
So another question, maybe while we're talking about this, is so in a fair number of cases with radiotherapy, it's often because the vision is poor or did not respond very much to chemotherapy at that time. But when you have a really good response to this, does it become harder for you to convince the radiation oncologist to irradiate the orbit?
Yes. I mean, that's the whole point of your case, right? I live next to a cancer hospital, UT/MD Anderson Cancer Center. They only do cancer. So just like if retina sends it to me and it's retina, if the cancer hospital sends me a case, I know it's cancer. And it's because the peripheral smear is sometimes normal because the chemo or the biologic actually has treated it. The peripheral blood is clear. The CNS is where the action is. And as Gordon said, it's compartmentalized. They think they have control of the disease, but they do not.
I have an interesting historical example. It's just made me think of it, that when I first started seeing the retinal lymphoma cases, we used to irradiate them. And they did very well. But of course, then they all developed CNS lymphoma some months later. But actually, they did very well and had some recovery of vision too, with local radiation for retinal lymphoma. I don't think people would do it anymore. But in those days, often we weren't so sure that this was going to be that they were going to relapse. We soon found out that they all did, of course. But it was a thought.
So I guess at this point we can thank panel for their comments, and I guess as they have already intimated, the learning from this is that the orbital cavity and optic nerve are potential sanctuaries for leukemia even after conventional CNS prophylaxis. Leukemic optic neuropathy is typically an indication of CNS involvement and usually carries a poor prognosis, and there is a case to be made that they should have both chemotherapy and radiotherapy, even if the vision response to the chemotherapy seems to have been very good. So with that, thank you very much.
Thank you, Dr. Tan. Very interesting case. So with that, I'll invite the last speaker of the session. Oh, Dan, Dr. Milia, you'll have to stop sharing. I have to introduce you first. Could you just stop sharing the screen? I need to tell the audience about you. Thank you.
He's so keen. The young. If I wish I was young again.
I've got great stuff to say about that. Okay, so it's my honor and pleasure to introduce Dr. Dan Milia. He's the head of the Visual Neuroscience Group, Singapore Eye Research Institute, SERI. He is also a senior clinician in the Neuro-Ophthalmology Department of Singapore National Eye Center, that is the SNEC. He is professor of ophthalmology at Duke NUS Graduate Medical School in Singapore. He is also a professor of ophthalmology in Angers University, France, and honorary professor at Copenhagen University, Denmark. He's published over 220 peer-reviewed index publications in several textbooks and book chapters in ophthalmology and neuro-ophthalmology. And he's been an invited speaker at more than 200 national and international meetings. So over to you, Dr. Milia, to share your interesting case.
Yeah, give me 1 second, please. That's exactly what I feared. I won't be able to do it now. Give me 1 second.
I'm so sorry.
Should be fine now. Okay, I hope you can see my screen.
Yes, we can.
Okay, lovely. So I understand we're a little bit late, so I won't be too long on my case, which is not that difficult, but I thought it was quite interesting. So the story is the following. Is a patient, 76-year-old, with no significant past medical history, who presented from a neighboring country with bilateral visual loss that happened over approximately 4 months. The dialogue was not that simple. And he was referred by a retina guy. So I think Andy might have the diagnosis already. Patient had low vision bilaterally, and the optic discs were normal. If you have doubts about that, the retina specialist told me that the RNFL were normal. So that was the referral. This is a patient, 76-year-old, bilateral severe visual loss, maybe RAPD on his left side, normal fundus, normal RNFL, and OCT. I think that's a very reasonable referral from a retina guy. So what critical info is missing in my information? I think it's quite simple. There was no visual field. That's a specialized investigation that we neuro-ophthalmologists would do. And this was the visual field. And I think you can appreciate it was bilateral bitemporal visual loss. And our first question is, can the OCT, so this is probably info for the younger participants to this meeting, what else can OCT give us than the fact that RNFL is normal? Well, in our institution, we do it all the time. We're looking at the GCIPL, and you probably can appreciate on the color maps that there is a binasal dropout of GCIPLs, which is consistent with the bitemporal visual field loss. So I think that in this context, it's quite reasonable to suspect a lesion that is in the cellular region. So I think with no surprise, the next step was an MRI, but before that, there was also an endocrinological evaluation showing that there was profound panhypothyroidism, probably related to that pituitary dysfunction that we were expecting. So this was the report that this was a large pituitary adenoma. I don't know if the panelists, Dr. Navin, if you want to comment on this.
No, I do see there's quite an extensive supracellular extension on that.
Right. Okay, and this is, I think this is quite fair.
Dan, when you said panhypopituitary, was that posterior pituitary as well as anterior?
It's a very good question. There was posterior involvement as well. Absolutely.
Aha.
Yes, that is a critical question.
And
so,
Dan, what was the visual acuity for this patient?
Oh, it was very poor. Let me show you. 645. No,
645. Okay.
645.
Okay.
So, right. So that's my story, a pituitary adenoma. No, it's not. There is more.
Not with posterior pituitary involvement, sorry.
There is more. There is more. And also, looking at other slices of the MRI,
there seems to be some infundibular involvement and hypothalamic involvement as well.
I agree. The stalk is involved, and there is supracellular involvement as well. And looking at other slices as well, this is really a bad pituitary adenoma because it also goes into the tracts. Probably. Now, the challenges in this case were double. Number one, it was referred by a retina guy. Number two, it was a time constraint. The patient was coming from a neighboring country and he wanted a rapid fix. And this has its importance in the story. So the neurosurgeon who saw the patient went for transsphenoidal surgery for what he considered atypical pituitary adenoma. And the result was quite a surprise. This is not the image from this patient, but still the same pathology. It's adenocarcinoma. Now, who in the audience has seen adenocarcinoma of the paracellular or pituitary and infiltrating? Well, probably not as a primary lesion, but my next question is, what would be your next step, Dr. Navin, since you're there?
I would obviously wait for the biopsy, but I was just thinking in a 76-year-old with posterior pituitary involvement, are we dealing with just a pituitary or is it a kind of a metastasis?
Right.
So the pituitary as well.
Maybe I was not clear. So the patient went by the neurosurgeon. He had a transsphenoidal surgery of that lesion.
Mm-hmm.
That pathology was adenocarcinoma. So we had a formal pathology for now, but I fully agree with you that the next question is look for the primary. You are looking for, probably this might be metastasis, but you're looking for a primary. And I fully agree with you that intellectually this was probably not very satisfying to have a pathology from a brain surgery, but we still had to deal with things. The problem was that the patient wanted a quick fix and we just couldn't do anything more. But after we had the certitude that this was not a benign tumor, we did a comprehensive investigation with CT scan of the abdomen, the thorax, and there was probably lung malignancy with lymph nodes that were involved. And the final diagnosis of this gentleman was metastatic lung adenocarcinoma to the cellular and paracellular space.
It's actually fairly common, but usually not this overt. I mean, in pathology cases, you can often see, because the pituitary is so vascular, so you see these a lot in the pathology case, but rarely something this large and heterogeneous.
Right. I fully agree with you, Neil. And also, I think what was striking, and looking at the literature, apparently the vast majority of pituitary metastasis happens in patients who have a known primary and they have an MRI because they either have some headache or visual loss or some manifestations related to the region. But it's still, I thought, in my experience, it's still very rare to have this as a first manifestation. And interestingly enough, I looked at the recent literature, and there is this paper reporting 13 patients from an Italian team. And in fact, although maybe intellectually not very satisfying, I still it makes sense to have a neurosurgical intervention in a blind gentleman with a pituitary metastatic adenocarcinoma. But these are the results in their experience. And as you can notice, there are only 1, 2, 3, 4 patients with visual symptoms as the presenting signs in metastatic pituitary metastasis. And so this is basically my story. I open the discussion if you're interested.
Dan, the other situation where you see pan-hypopituitarism is hypophysitis.
Exactly. Agreed.
And that's obviously the presentation and so on can be very different, but we do see it in males as well as females. But those are the two situations: pituitary metastasis and hypophysitis, where you have a combination of anterior and posterior involvement. It's very unusual in pituitary adenomas. Craniopharyngioma, of course.
Right.
Yeah, that's what I was going to say.
But that's a different. Yeah, the imaging's rather different with that, Neil.
Right. So this is
the other thing, Dan. I think you were showing there edema in the optic tracts, weren't you?
Yes, absolutely.
This is something that we wrote up years ago, and I never called it the wishbone sign, but I wish I had. But we wrote it up in craniopharyngioma. And in fact, apparently, I was with Bill Hoyt at the time, and apparently at the Walsh meeting that year, they showed a case,
right?
And Bill had already seen my report and stood up and said, "Oh, it must be a craniopharyngioma." But since it certainly occurs, it's another important sign with. It's very rare with with pituitary adenoma. But you see it with carcinoma, with craniopharyngioma, and with other things.
Gordon, was that the paper where you pointed out the fat optic nerves from infiltration by the cranio?
No, that's another issue. This is just edema, and it goes away. It goes away once it's occasionally with meningioma as well. But it does go away when the tumor is treated. So it's just passive edema.
Correct.
But cranios also can not only compress the visual system, but actually infiltrate it. And there was, I remember at one of the Walsh meetings, they had the fat chiasm, not from edema, but actually craniopharyngioma within.
And there was also the pot-bellied optic nerves. Do you remember those?
Yeah, that's what I was. I had forgotten the pot-belly comment.
No, I can't remember what I wrote about that. Must have appeared somewhere. It must have appeared. So we might have mentioned it in that paper. I don't know. Must have appeared
You've
somewhere.
written so much you can't remember what you wrote.
Well,
so I have a question for Dan and Gordon and maybe Neil. That here, I think the diagnosis was reasonably easy to make because you had a large suprasellar mass to explain the bitemporal hemianopia, etc. But suppose it was not there, and maybe you just had a endocrine issue and maybe a kind of a plus minus chiasm. How would the diagnostic challenge there be if the MRI findings were not very prominent? We jumped from the tumor to the surgery, the biopsy, and the lung CT, and picked up the condition. But what if there was no pituitary swelling? It was just a chiasmal infiltration.
With this, if I was managing this particular case from the start, I would have done a whole body
of course
CT,
Of course, but remember, this was a special.
This has two radiological features which make a straightforward adenoma pretty well impossible, both the optic tract edema and the involvement of the posterior pituitary. So I'd have been looking for a cancer straight away with this one. Of course, if you're talking about very small lesions, like a small metastasis that's doing causing a lot more problem with the with vision than you'd expect from compression, then yeah, you've got to have your wits about you for something like that.
Right. I fully agree, Gordon. But remember, this was also a time constraint. So we had to do something within a couple of days. So after all, although discussing with the neurosurgeon, it was clear that this is not the garden variety of adenoma, it was still a reasonable way to have tissue and at least to try to give some vision back to the patient. But of course, when we had the pathology, it was clear that we had to continue with the whole workup.
So with that, I think we'll have to move to the next session. And we thank you, everyone, all the speakers, very interesting cases, all the panelists, and over to Dr. Padmavati.
Thank you.
Neela, I agree with your last point on that slide, but that wasn't a homonymous hemianopia. It was heteronymous. The term is heteronymous hemianopia. Thank you.
So may I introduce to all of you Dr. Padmavati Maharajan, who is the Chief of Neuro-Ophthalmology Services at Aravind Eye Hospital, Tirunelveli, Tamil Nadu, India. She is the post-graduation section in charge of Indian Neuro-Ophthalmology Society Times. She has 18 publications, international, national, and state to her credit. Her areas of interest are disc edema, supranuclear palsies, and OCT in neuro-ophthalmology. Over to you, Padmavati.
Thank you, Dr. Satya, for the introduction. Moving on to the next session, I have with me 3 other panelists we are awaiting for a much awaited, more interesting cases. Let me introduce my first panelist. It is Dr. Ambika. Let me share the screen. Is my screen visible?
No, not yet.
Not yet.
Okay, give me a minute. Yeah. Now, is it visible?
Yes.
Yes. It gives me pleasure to introduce Dr. Ambika. She heads the Neuro-Ophthalmology Services and Visual Science at Shankar Netralaya, Chennai. She has authored several publications in ophthalmology journals. She is also the author of Atlas of Neuro-Ophthalmology. She has also authored the Shankar Netralaya Atlas of Neuroimaging in Ophthalmology. She has several chapters in ophthalmology and neuro-ophthalmology textbooks. She is an executive board member of Indian Neuro-Ophthalmological Society. She was the best outgoing postgraduate and associate consultant. She also received the Best Paper Athwale Award in 2014. She also received the Best Paper Award in ICTRMS 2015. Her areas of interest are optic neuritis and demyelination, ocular myasthenia gravis, IH, LHON, and neuroimaging. The next panelist is Dr. Krishna Vaidishwaran. He's a consultant neuro-ophthalmologist at Moolchand Mid-City Hospital, Delhi. He's a fellow of the Royal College of Physicians and Surgeons of Glasgow. He has developed several surgical as well as non-surgical techniques of management for the treatment of vision as well as associated disorders. His main interest in optic nerve surgery, especially optic canal decompression, sheath fenestration and vascular surgery, chemodenervation, data analytics, and meta-analysis in ophthalmology. He is also the editor of the book Current Perspectives on Ophthalmology edition, 5th Elsevier. The next on board is Dr. Naveen Jaykumar, who is also the director, as Shika had also introduced as a director on Darshan Eye Care Chennai. He's also the director. He was former director of the Department of Neuro-Ophthalmology at ASN Chennai. He's also the member and editorial board in the Journal of Neuro-Ophthalmology. Now moving on to my first speaker, it is Dr. Stephen Harmon. He is a clinical research associate professor as well as a consultant neuro-ophthalmologist at the Department of Ophthalmology at University of Copenhagen, Denmark. His specific interest centers around optic neuropathies. In particular, his focus is on the pathology of increased intracranial pressure states, ischemic optic neuropathy, and optic disc drusen. In addition, his group is aiming at developing analytical tools and interpretation guidelines for advanced imaging modalities of the optic nerve with a particular focus on the distinction between papilledema and pseudopapilledema. He has published more than 100 peer-reviewed scientific papers. In 2015, he founded the International Optic Disc Drusen Studies and of the Studies Consortium, of which he is the chair. He is also the chairman for neuro-ophthalmology of the European Reference Networks for Rare Diseases. Over to you, Dr. Stephen, for your interesting case presentation.
Thank you very much for this kind introduction. I hope you can all hear me. And my talk is entitled Breathless Papilledema. I have no financial or proprietary interest in any of the material I will discuss. So I'll start up with a little clue to the diagnosis. And I'm well aware that this probably only works for Gordon Plant, but he would probably easily have guessed the diagnosis anyways. But Gordon, if you already want to give it a shot, you're welcome. Otherwise,
Stefan, I don't know what the dickens you're talking about.
All right, great, Gordon. All right, so this is a 58-year-old woman referred from her own eye doctor because of bilateral optic disc edema. And she complains of puffy eyelids, and she's seen initially by her own eye doctor for potential eyelid surgery, and she has no visual complaints. She reports a 1.5-month history of increasing edemas generally, and also including the eyelids. And this has happened after she changed from Central to Furex. And for the past 2 weeks, she has also become increasingly tired and short of breath. She has no other complaints. She's a robust lady with a BMI of 33. She has a normal visual acuity, and a full neuro-ophthalmological exam is completely normal, except for the ophthalmoscopy. And this is how she looks like when she comes to our department to start with. And you can all see here that she has bilateral optic disc edema. She has venous congestion, and she has some hemorrhages. So one naturally wonders whether this could be due to raised intracranial pressure. An acute CTC is suggested, but the patient is anxious, she refuses, and she leaves. The next day, she comes to the neurology department by appointment, and she has slightly elevated blood pressure, but her saturation is very low, only 84%. She has a normal neurological examination. So the neurologists also think that an acute CTC is warranted to rule out an intracranial mass, but the patient refuses and she leaves. So what happens subsequently during the next 2 weeks or something? She becomes increasingly tired, short of breath, and has peripheral edema, especially in the legs. And she's admitted to cardiology via her GP, who measures an oxygen saturation of 74%. So when she comes to the cardiology department on day 15, she has lip cyanosis, she has cutaneous changes due to long-standing hypoxemia, and she has a severely prolonged expiration. Acute arterial blood gas analysis is performed, and this shows hypoxemia, hypercapnia, and elevated bicarbonate. So this, per definition, is a respiratory acidosis, and she remains admitted due to the dyspnea, hypoxia, and hypercapnia. She has a chest X-ray and subsequently a chest CT performed. This shows emphysema, right-sided pleural fluid, and bilateral atelectasis. An echo Doppler is performed showing cor pulmonale. An abdominal ultrasound shows ascites, and she's started on treatment with oxygen and continuous positive airway pressure. She's also, because she's in such a bad state, she's intubated and she has positive expiratory pressure treatments. And finally, on day 18, she starts getting better, and an oxygen saturation of 92% on 3 liters of oxygen is measured. So this is a case of, well, probably you all guessed it, or many of you, but it's obesity hypoventilation syndrome, also known as the Pickwickian syndrome. It's the combination of obesity and daytime hypercapnia in the absence of a neuromuscular, mechanical, or metabolic cause of hypoventilation. The prevalence of this condition is estimated to be about 0.5% of the population. This is a little uncertain number, and it's by far the most severe manifestation of obesity-related respiratory disease. Putative causes are the inability of the brain to manage a person's breathing, perhaps also excess fat-producing hormones causing a person to breathe ineffectively, and the extra weight on the chest making it difficult to breathe normally. It is associated with significant morbidity and mortality. It's over and above other respiratory disorders associated with obesity, especially obstructive sleep apnea. And the recent guidelines recommend that clinicians use a serum bicarbonate level below 27 millimolars per liter to exclude obesity hyperventilation syndrome in low suspicion cases. And this is probably because patients, when the blood gas analysis is performed, they tend to hyperventilate, which gives them a falsely elevated carbon dioxide level. So what about the papilledema? This was first reported in patients with pulmonary emphysema back in 1933. It actually occurs in about 10 to 13% of patients with respiratory insufficiency. And the pathophysiology is usually due to a combination of hypercapnia, hypoxia, increased venous pressure, and or polycythemia. Papilledema has previously been reported in association with OHS, but it is not always that the connection is made, and here we definitely risk a doctor's delay. The treatment of the papilledema is the treatment of the underlying disorder. So in sleep-related breathing disorders, you can get secondary intracranial hypertension. The most well-known reason for this is obstructive sleep apnea, but there's also the obesity hypoventilation syndrome. And how do these differ? So the obstructive sleep apnea, here you have obstruction of the airways. You get a forced expiratory effort at sleep. This causes snoring and apnea episodes that cause hypercapnia. And the intracranial hypertension is probably because of the forced expiratory effort against the closed glottis. This increases intrathoracic pressure, which is then transmitted into the head. Also, the hypercapnia that stimulates the cerebral vasodilation. This results in increased cerebral blood flow and raised cerebral venous pressure, leading in turn to raised CSF pressure. On the other hand, you have the OHS, which is due to central hypoventilation, where you have a decrease in PaO2, increase in PCO2, and increase in bicarbonate. And the intracranial hypertension is seen because of the right-sided heart failure manifesting as increased central venous pressure and increased venous pressure in the lower extremities and the peripheral edema, and also because of the hypercapnia with the same reasons as for OSA. Cor pulmonale is seen because of the chronic hypoxia associated with the disease. If you want to learn more about this distinction and the Pickwickian syndrome, I suggest you go and see the beautiful little lecture by our colleague Andy Lee on YouTube. All right, back to our patient. Finally, on day 21, normal CT is performed, and she's released from hospital on day 25. A planned MRI of brain and orbit, as well as a CT venography, is also finally performed 2 months after the first visit, and these are all normal. We see her again at the eye department 2 months after her first visit. And now you can see the papilledema has almost completely disappeared. Peripapillary or parapapillary hemorrhage seen on the left side with a slightly more remnant of the discedema. And finally, at 3 months, we see her with the papilledema is completely gone away, and the hemorrhage is also slightly disappearing. So this is to some of our findings here. In the eye department, the treatment was initiated on day 15, and we saw her again at 2 months, and here were her visual fields at that moment, and again at 3 months. And you can appreciate the RNFL is completely back to normal, but with no ensuing atrophy, which tells us that this probably wasn't an initial NION, but it was papilledema. The visual field remained stable, and the visual acuity was normal all along. So to sum up, this was a 58-year-old obese woman with papilledema due to obesity hypoventilation syndrome. The papilledema resolved completely after the respiratory function was restored. Take-home messages is that not all obese patients with papilledema and normal neuroimaging have IIH, of course. This is always important to reiterate. You should think of OHS in an obese patient with papilledema complaining of shortness of breath. OHS is characterized by obesity and daytime hypercapnia in the absence of an explanation for hypoventilation. And with the rise of obesity prevalence worldwide, so will the prevalence of this condition probably also. Obstructive sleep apnea is not the only sleep-related breathing disorders. It's definitely the most well-known, and they can that are associated with intracranial hypertension. That they can often be coexisting, and patients with OHS often also have obstructive sleep apnea. Once diagnosed, this is a treatable condition, and the treatment is of the underlying respiratory disorder as well as weight loss, saving vision and saving life. I'd like to thank you for attention, and as I said, Gordon already guessed the diagnosis. This is a nice painting by the British painter Cecil Alden, who illustrated the cover of the posthumous papers of the Pickwick Club by Charles Dickens back in 1836. It's also called the Pickwickian syndrome because there was a character in this book who was obese and falling asleep all the time. And that was the one who gave the name for it. So thank you very much. And I open the floor up for discussion.
Thank you, Dr. Stephen. It was a really wonderful case. I have a question. What are the chances of recurrence in these conditions, whether the chance of papilledema to recur, is there any high incidence with the hypoventilation?
I'm not. I don't know actually if anyone has looked at it in particular, but I think the biggest problem with this condition is that it's actually quite dangerous, and second, that it's not always that the clinician make this diagnosis. So you risk of losing a lot of time examining and perhaps treating this for potential idiopathic intracranial hypertension, doing lots of unnecessary examinations. And this woman, she was also quite in a quite bad state at a moment. But once they recover from it, usually we know that this can, of course, happen again, and we're much more aware of it at an early stage. So the positive airway pressure treatment usually works very fine for these.
I would like to add a comment on this. In our scenario, we do have conditions where anemia could be one of the associated factor. With treating anemia, the disc edema resolves. Just as you had pointed out, the hypoxemia resolves with treatment, the disc edema resolves. Ambika, you can take up.
Stephen, that's an excellent case. And as Dr. Padma had raised, I just was wondering about the chronic treatment for this patient, because you have taken over the acute part of it and it is settled. So let me ask post-pandemic conventional question. Was there a history of COVID?
That's a good question. Certainly not at the time, but she probably, like everyone else, has had COVID, but it was not something that she had at that time exactly. But history of COVID, yes. But I think as far as I remember, it was a couple of months ago.
So because we see nowadays a lot of patients coming up with hypoxia, and as you had mentioned, when you have an obese patient walking in and when you see a bilateral disc edema with a blood pressure of, I think on day one itself the blood pressure was high, and there were some AV crossing changes also. So number one, could it be just a raised blood pressure, because we have not put the patient apart from oxygen therapy, not any other modalities of treatment for the reversal of the disc edema? Was it just maintenance of the blood pressure and her hypoxia being relieved that itself has given her a resolution of disc edema?
I don't know, but well, her blood pressure wasn't that elevated. It was slightly elevated. And of course, this could also have been playing a role for the way everything looked. The daytime hypercapnia is not, something that you usually see in the normal elevated blood pressure states. So I'm quite sure of the diagnosis of OHS, but whether it was the sole role for the papilledema, this can be discussed, of course, and that could definitely be a component of elevated blood pressure as well.
Was there an LP done?
No. She suffered from anxiety, so that was why she left the eye department, and on the second day she left the neurological department before any scan was done. So she wasn't that fond of being in a hospital.
Okay. And her AHI index or any sleep study or anything, was it performed for her?
No, nothing like that. No. Every time she had the chance of running away, she did.
Okay, got it. Thank you. That's a nice case.
Thank you.
Stefan, where I've thought there definitely was a cause like anemia or obstructive sleep apnea, I try to avoid doing a lumbar puncture because provided, that the vision was still good and so on, because then you'd be more confident if the patient recovered, responded to an iron infusion or to CPAP and so on, you'd be much more confident that that was the entire cause. So in that situation, I tended to avoid doing an LP because there's always this, well, it may be controversial, but I certainly believe that some of these patients are helped by a single lumbar puncture.
Yeah, definitely.
Longer term, but certainly over a period anyway, longer than you'd expect from the effect of the removing a bit of CSF.
Yeah, I agree.
So would we continue them to be on a chronic CPAP or any other modalities of treatment? Would you recommend them along with the cardiologist advice, or what will be your chronic way of preventing a relapse of she developing such optic nerve problems?
She should definitely be managed by the lung specialist, and now I get a little bit out of my comfort zone when talking about the best treatment for her pulmonary condition, but she keeps in the good hands, keeps being in the good hands of the lung specialists. and they gave her some treatments and monitor her treatment. I'm not sure that she gets CPAP on a regular basis. I'm sorry.
Thank you. Dr. Padma, you're muted.
Yeah, thank you, Dr. Stephen, for the interesting case. I think we will move on to the next case. It is happy to introduce Dr. Gordon Plant. I'm sorry, I think the slide is not moving. Yeah, he's a consultant neurologist and neuro-ophthalmologist at the National Hospital for Neurology and Neurosurgery at St. Thomas Hospital and Moorsfield High Hospital, London. Dr. Plant is a fellow of the College of both Physicians and Ophthalmologists and has particular clinical and research interest in neurological disorders that affect vision. His work has been as a full-time LNHS consultant, but he has found time for research with over 300 articles to his credit and a high index of 76. He has a particular interest in neurological disorders affecting vision. He has retired from, though he has retired from clinical practice, he still maintains an interest in teaching and research as honorary associate professor at University College London. Dr. Gordon, over to you for your interesting case.
Can you see my slides?
Not yet.
Okay, just something. Now?
Yes.
Yes.
Okay. Well, I actually don't know the diagnosis with this case, so I've been interested in any views. So this, well, I think it might be a, oh yes, yeah, just a thanks to Doctors Dong and Braithwaite of the Medical Eye Unit at St. Thomas's, where I was consultant for quite a few years. So 77-year-old white European male.
Dr. Gordon?
Yes.
Yeah, that's fine now. That's fine.
Am I okay?
Yes, you are.
Yes, you're okay.
So he noticed reduced peripheral field in both eyes, especially the left, infranasally. And these symptoms started 4 days after he'd had a 13th infusion of gemcitabine chemotherapy for pancreatic adenocarcinoma. And at the time he was first seen, these visions were stable. He had his usual symptoms after the chemotherapy infusion. He had headache and some joint pains lasting over 24 hours. There was nothing unusual about this. He'd had usual monitoring, blood pressure and so on, and no one had noticed any change. So 10 days later, he's presenting with visual loss progressing over several hours. So the background to this is that in January of 2020, he developed jaundice, and this was due to adenocarcinoma of the head of the pancreas. He had a Whipple procedure and then went on to the usual combination of Creon therapy. He'd recently also been on B12 and folate supplementation because he developed an anemia. This supplementation was ongoing for several weeks by the time the visual loss occurred, and that's his chemotherapy. Past history of mild asthma, Parkinson's disease, diagnosed a few years earlier, and he'd had surgery for spinal stenosis. So he was otherwise feeling as well as he had been, and he hadn't any symptoms suggestive of GCA. He hadn't any transient visual obscurations. He was a non-smoker and no excessive alcohol intake. And just more detail about his medications: the Creon supplements for exocrine pancreatic insufficiency. He's also on the oral multivitamins supplements, plus recently B12 and folate. He's on carbidopa and levodopa with rasagiline for his Parkinson's disease, omeprazole, vitamin D supplements, and loperamide for diarrhea. So 10 days following this, he was first seen at St. Thomas's, and he had good acuity and color vision, no afferent defect, but bilateral nasal field loss on confrontation. And so this is him 10 days following the onset of symptoms. And as you can see, he's got bilateral disc swelling with some hemorrhages. That's the right eye. And that's the left eye. The people who examined him at that time were concerned, of course, about GCA. They didn't find any signs of that, and we've already said he didn't have any symptoms of it. His OCT confirmed the disc swelling, and as you can see, there's also quite a lot of subretinal fluid appearing here on the peripapillary disc scan. And you can see he's got some folds here. And here's the left eye. And again, a bit of fluid here and some folds, this swelling, and these little flame-shaped hemorrhages around the place. So, any thoughts from anybody?
Gordon, would this be accurate to say this was a kind of a disc edema with coincident pallor as well?
I agree. Yes, I agree. I hadn't said that, hoping somebody might note that actually these discs are not just swollen, they're already pale, aren't they?
Yes. So in such a situation, the first thing that would have come to mind was, of course, ischemic optic neuropathies.
Yes, absolutely, and the little hemorrhages would go along with that. So our first thought is that this is likely to be a bilateral ischemic, anterior ischemic optic neuropathy because the discs are swollen.
But just as a starting point.
Yes, and of course the pallor is significant because certainly with garden variety anterior ischemic optic neuropathy, we would not expect to see that.
Yes.
So we have bilateral acute onset, simultaneous painless optic neuropathy with disc swelling, disc-related visual field loss, and preservation of central vision. And I've just made a list here of all the things that could cause bilateral simultaneous disc swelling. And actually, anterior ischemic optic neuropathy, as we know it, as we usually see it, the idiopathic variety, is unilateral, although, of course, there's always a risk to the other eye. So unilateral, but maybe sequential, sometimes with quite a long interval between the two eyes. But so could this be something toxic, nutritional? Could it be an optic neuritis? Could this be infiltrative? We've been talking about that earlier. We know this patient has had an adenocarcinoma, could there be some infective process going on? And in view of his metabolic problems, someone's put calcium deficiency or excess in there, both of which have been associated with disc swelling. I remember I once had two patients with disc swelling, one with hypocalcemia and the other with hypercalcemia, in at the same time, and I actually they were in adjacent beds on the ward, and I did just wonder if something would happen between them to even things out, but it didn't. So here's some initial investigations. Again, nothing going for GCA. CRP is only 4. It's got a negative VDRL. You can see there that he's got a thrombocytosis of 566, 400 being the upper limit of the reference range. He's a little bit anemic with a slight macrocytosis. Not much else, but in fact his at St. Thomas's we do active B12s, which gets around the problem of needing to check methylmalonic acid. So active B12 was normal, folate. They still check the methylmalonic acid, but you don't need to with active B12 levels. And he's a little bit iron deficient there. And the oncologist looking after him didn't think there was anything particularly remarkable about this, or that there'd been any great change, except that he'd recently, of course, been treated for folate and B12 deficiency. So that's where we were. Now, I don't have the brain imaging, unfortunately. It was done somewhere else, and although we did see it, it wasn't saved on the system. And what was noted was mild prominence of perioptic CSF, but otherwise no changes in the anterior visual pathways. We've learned already today how uninformative a normal scan can be in the presence of pathology. And he had a CT venogram, which showed he did have a hypoplastic left transverse and sigmoid sinus with a dominant right sinus, but this was considered to be within normal. And he had a lumbar puncture. Opening pressure was on the low side as recorded, and the CSF was unremarkable apart from a slightly elevated protein. And here we are with all those investigations, and when seen again 5 days later, his vision has deteriorated further. Reduced to, he's now got reduced central acuity, corrected, and his color vision is starting to go down in the right eye. Both discs still look swollen, and then there's a few blot hemorrhages have appeared in the peripheral temporal retina, and those are his fields at this point. So if you remember, what he first noticed was this infranasal loss in the left eye, and he's now got more inferior loss in the left eye, and on the right he's got more of a supranasal loss, but again with a nasal and altitudinal emphasis. Here's an OCT of his disc. This is a week after the ones we just saw. We've still got the disc swelling. There is a lot of subretinal fluid again, not unusual in disc swelling from various causes, but it's there. So, well, somebody decided to give him some vitamins. Any other thoughts from anybody at this stage?
Did you do the GCC, Dr. Plant? GCC? Because the GCC loss is immediate and ischemic. You had subretinal fluid on the retinal nerve fiber layer you've shown, but that is in favor of ischemic cause. If there was GCC loss in the early stage, as early as 2 days, if the GCC is thinned out, it's red, then it points towards an ischemic cause.
That's a very good point. I am going to show you that.
Okay, thank you.
The other question I had, Gordon,
yes.
Was, were there any lower spinal cord signs or anything like that, which, you know, sometimes you have obstructions there which could result in a low pressure on LP, but an actually higher CSF pressure above that?
Yes, that's a very good point. I mean, as things developed, we didn't, in fact, do any further imaging. But you're absolutely right. I mean, I because the usually with an obstruction, the protein will be very high in the CSF, and I rather thought that was probably a spurious measurement. But it's a good point, and certainly if we were thinking here of metastatic disease or raised cranial pressure as the cause of this, we'd be thinking about we'd be wanting to examine the spine very definitely. And there's an Optos, and the thing was that he had developed this little. Can you see my pointer?
Yes.
Yeah, we thought he had just a little peripheral hemorrhage. We thought it was probably a little peripheral vein occlusion over here. So, but so what I suggested was that we do a fluorescein, because as many people have intimated here, this looked to me to be a bilateral simultaneous ischemic anterior optic nerve problem. And as you can see, there is severe loss of perfusion of both optic discs. And particularly on the left, which is the more severely affected eye, and it was quite patchy on the right, and you can see if you sort of flip the fluorescein and look at it with the fields, you can get some impression here that we're looking at sectoral loss of perfusion of the disc, which is of course what we see with anterior ischemic optic neuropathy. We just don't see it happening, and it can progress. AION can certainly progress, but for it to happen simultaneously in both eyes doesn't seem to be something that happens. So, and I think it's always interesting to look at this combination of disc-related visual field defects that you see with sectoral hypoperfusion. Of course, arcuate and altitudinal are common, and the nasal step is a feature here. Of course, the whole nasal step concept comes from glaucoma, but still, and more rarely, we can have cecocentral scotomas if we have sectoral infarction of the temporal disc. And there's also this very rare temporal wedge that you see with sectoral infarction of the nasal nasal disc. I always like to show these pictures, which this one was never published. Actually, these were from some work that Hugh Perry had done in Oxford, and he was injecting HRP into the optic nerve of primates just behind the eye, you can see beautifully here. This is where the optic disc would have been, and this is the fovea. This is a hole because it's very thin. This is a hole because this is where the optic nerve was. But with a pellet of HRP in the dorsal part of the optic nerve, you can see how this horizontal raphe is respected by these stained retinal ganglion cells. It's not 100%, interestingly, but the raphe, of course, is more like a parting in your hair. It's not an anatomical structure. It's just that the ganglion cell axons from the retina below this are all going to the ventral part of the optic disc. They couldn't be further apart in the optic nerve, the axons of adjacent ganglion cells across here. This is the one that we published, which was the ceca central projection. So this is pellet of horseradish peroxidase in the temporal optic nerve just behind the eye. And so this is the projection of not just the fovea, but also all the ganglion cells between the fovea and the optic disc, which go together into the temporal optic nerve. They then, of course, migrate into the center of the nerve, which is another story for central scotoma. It's just quite a nice illustration of the anatomy there. So we repeated this OCT. He's now a month down the line, and he's starting to lose nerve fibers now. There's still a lot of fluid around, as someone requested, here's his ganglion cell volume, which is much depleted, and it's the same in the left eye, only less so here. Sorry, more so, the left eye is worse. Although in terms of ganglion cell loss, the left eye is less severe, but in terms of, because there's more preservation of central vision, I presume, but certainly in the involvement of the disc, it's more affected. So here we have something which is, it is a non-arteritic. We have no evidence of arteritis, anterior ischemic optic neuropathy, but it is also bilateral, simultaneous, and subacute. And there's much more extensive disc-related visual field loss than is typically seen. So, what do people think could have happened here? I mean, of course, we see this with systemic hypotension occasionally, transient elevation in platelets following chemo. Could that have been relevant to this? And what about the gemcitabine? Little vein occlusion added there. Maybe that's related to his platelets. So any other thoughts from anybody? As I say,
yeah, thank you, Dr. Gordon. I have a basic question. Is the terminology atypical ischemic optic neuropathy relevant in this scenario, or can we use just like we use an atypical optic neuritis? So can this fit into a diagnosis of atypical optic neuritis? Apart from the MOG and MO, you had done the workup, but still.
Well, I don't think you're asking if this could be optic neuritis.
No, could it fit it in the spectrum? That's it.
Not with the fluorescein.
Yeah, that's right. But I would like to know whether the terminology atypical non-arthritic AON apt.
Well, I think that this is, if we compare it with the garden variety of anterior ischemic optic neuropathy, as I say, it does not occur simultaneously. However, there are situations, for example, acute hemorrhage, acute hypertension. There are situations where we have an anterior ischemic optic neuropathy by definition, because the disc is swollen, and we have hypoperfusion, sectoral hypoperfusion of the optic disc occurring in malignant hypertension or something like that. So it is an anterior ischemic optic neuropathy in the sense that that is affecting the prelaminar optic nerve, and we have the disc swelling associated with it. But that's to distinguish it from a posterior ischemic optic neuropathy, which is a retrobulbar event, and the disc looks normal.
Any comment on the diabetic status as well as the coagulation profile?
Diabetic.
Diabetic status as well as the coagulation profile.
Yes, it's a good question. No, he's got no evidence of diabetes. No, I should have mentioned that somewhere.
The next question is the regression of RNFL edema, as you had shown in the OCT, is comparatively faster. Is it possible in an ischemic setting?
As opposed to what other setting? I mean, I think
because many times it takes for us 2 months almost to see the regression of edema, but it is quite faster.
Yes.
That's the reason why I asked the question.
Yeah, absolutely. Well, I mean, that's another reason why this is unlike garden variety anterior ischemic optic neuropathy, isn't it? I mean, we've got many reasons for saying it isn't, although by definition it's an ischemic optic neuropathy affecting the anterior optic nerve. It's behaving in many ways.
The next question is
typically much more likely, much more similar to what we would see, for example, in malignant hypertension.
Yeah. The other thing is actually what you had shown is the macular ganglion cell analysis. What we were speaking is usually we do a macular ganglion cell thickness. This usually the retina people do. We don't do this macular ganglion volume. We do the macular cube with the analysis, macular RGC thickness. That when you see in the first visit itself, as Shika had said, there is a reduction in the macular RGC thickness compared to papilledema or any other condition. So this was the question she had posed, but you had shown us the macular volume, I think.
But you're talking about changes in typical garden variety AION.
Yeah, right.
Yeah. Yes.
But as a neuro-ophthalmologist, we are more concerned with the macular ganglion cell thickness rather than the volume. We prefer doing it here, but I would like to have a comment from the other panelists as well as the speakers.
Yeah, I don't have any other pictures to show you, I'm afraid, of the OCT.
That's fine, but I just wanted a comment. That's it. The next one was, I think, bone marrow biopsy. Will it be helpful?
Bone marrow biopsy. Looking for what exactly?
Gordon, I have a question, Stephen, here. You said you don't have any more OCTs, so I'll not ask whether you did an OCT looking for disc drusen, but we've seen optic disc drusen related AION bilaterally and with a shorter sequence in between the ischemic events, not exactly simultaneous here. I agree everything points in some direction of a systemic underlying condition causing this, but I still think it would be very nice, especially before doing stuff like bone marrow biopsy, to do a dense optic nerve head scan, looking at the more laminar near anatomical conditions in the optic nerve head, because we've seen that even a small buried optic disc drusen in the wrong place can cause quite severe ischemic optic neuropathy with the peripapillary fluid, as we saw in this case. So I would definitely do this also. The drusen don't go away, so they're still there if you do the examination.
it's really what I'm trying to emphasize here is how unlikely it is to have this simultaneously. Whatever. I mean, we don't know what his disc looked like before. He may have had crowded discs, and of course, crowded discs are a risk, the major risk for developing drusen, and they're also the major risk for AION. So it's not surprising that you get both. But of course, the question would be whether there was any different behavior when drusen were associated from classic AION. But it's really what I thought about this was that this was related to the gemcitabine. Although he'd had many treatments before, and I don't have any better explanation. And the reason I say that is because gemcitabine has been associated with posterior reversible encephalopathy syndrome.
Yeah, that's right.
And I saw back in the day, we used to see this not uncommonly with cyclosporin. Now, of course, the PRES was not so well understood in those days, but we used to see patients with PRES, and we also used to see patients with this happening to the optic nerves. And it tended to be referred to as a toxic problem related to the drug, but the fluorescein would clearly show that it was ischemic. So it would have to be a vasculopathy, vasculopathic problem. And there have been a few cases, and I've seen a couple where they've had PRES in the brain and this happening in the optic nerve. So I think it's possible that this is what PRES looks like in the optic nerves. Now you're going to say, where's the reversible component in this? Well, it isn't always reversible in the brain. What we see is not cytotoxic edema on MRI. We see tissue edema, which is reversible. But I think the optic nerve may behave differently. And it's certainly the case that some of the PRES patients do have permanent damage, even in the brain. So that was what I thought about this. If anyone's got any other suggestions or comments on that.
Gordon, I believe you have a couple of more slides.
Yeah, well, we didn't find any cases like this, but as I say, there's many other cases with similar cases with antimetabolites, particularly cyclosporin, not used so much these days. So that was my view. It could be a variant of PRES localized to the optic nerves, and there is a lot of fluid being. PRES, of course, is a vasculopathy, and there is a lot of tissue edema here. I mean, we've just looked actually at a very, very large series, 100 cases of anterior ischemic optic neuropathy, and you see subretinal fluid, not in so many, maybe in about 10%, something like that. But PRES is important in neuro-ophthalmology because it so often affects the occipital lobes, and the patients present with visual loss due to that, from preeclampsia particularly. Okay, that's my lot.
Okay.
Thank you.
Thank you. I think we are running short of, we are running behind schedule. I would like to introduce the next, Dr.
Okay.
Garden. Can you stop sharing? Because I have to.
I'm not sharing, am I now?
Yeah, fine. The next speaker is Dr. Mariana Devergelis. She's the head of the Neuro-Ophthalmology at Pedro Legles Ophthalmological Hospital, Austral University Hospital, in Argentina. She is the Neuro-Ophthalmology coordinator of the Argentine Congress of Ophthalmology. She is also the head of practical work in the field of ophthalmology of the Medical Career University. She is also the coordinator for Argentinian Ophthalmology Council. She is the Neuro-Ophthalmological coordinator for the Southern Cone Course. And she is also the coordinator of the book of the Master of Ophthalmology of the Argentine Council of Ophthalmology. She is the resident coordinator of the Pedro Lagles Ophthalmological Hospital. She is also the principal investigator in the neuromyelitis protocol. Over to you, Dr. Marian, for your case presentation.
Thank you so much for the presentation. Let me share here. Okay. So thank you so much for the presentation. Incredibly excited to be here presenting this case here today. So I have no financial disclosure. I would like to share with you a clinical case of 59-year-old man who complained of floaters OS of 1 month evolution without other symptoms. The only positive is he had recently traveled to Italy, and he is vegan, the only. So physical exam at fundus, right eye unremarkable, left eye, you can see the blurred optic nerve with flame-shaped hemorrhage, vascular tortuosity, peripapillary exudates. At OCT, you can see the mild swollen disc and a detachment of neuroepithelium at a temporal foveal level. Visual field, the enlarged of blind spot. So the leakage at the angiogram, on the fluorescein angiogram. So the prescriptive diagnosis of the retina section were IAON, atypical optic neuritis, papillophlebitis, preocclusive phenomenon, neuroretinitis. The most likely diagnoses were papillophlebitis and preocclusive phenomenon. The evolution 20 days later, you can see a OD disc edema and, sorry, I have all of you. So OD disc edema and decreased vision of OS to 2030. So the retina section refers the patient to the neuro-ophthalmology section. So we ask for a brain and orbit MRI, MRB, and consultation with cardiology, hematology, neurology, and infectology services. So here is the contrast MRI, where you can see multiple focal compatible with gliosis and some venous sinus with hypoplastic appearance. So 7 days later, the visual acuity OS goes on decreasing. The patient refuses to be admitted. So hematology, all acquired and congenital thrombophilia regions negative, rheumatology sedimentation, CRP negative, cardiology Doppler of neck echocardiogram normal, hypo or hypertension negative, and infectology HIV negative, syphilis, sarcoid, tuberculosis negative. After 7 days, what's new? Decreased vision acuity, OS, to hand movements. So we insist on LP, hematology, neurology. Here we have the first result of lumbar puncture and was normal, almost normal. Only the opening pressure at limit, counting that he is thin. So we decided to start with acetazolamide. Neurology, CSF, NMO negative, infectology, and cytology negative. 7 days later, what happened now? Decreased visual acuity, OS, keeps going down to light perception. So at this time, we said, we wonder if it's an inflammatory mechanism. So we decided to start with antibiotics and intravenous corticoid. So infectology results were all negatives, and total body CAT scan negative also. What happened 12 days later, he lost 6 kilograms, and some symptoms were added. He felt palpitations in the head and ears, loss of sphincter control, tingling in his hands. So we insist on admission to do PET, PET, MRI brain, orbit, spine, MRB, MRI, and LP. The PET, the pre-report, the only positive sign was hyperuptake at the level of the optic nerves. So at this time, we thought about infiltrative optic neuropathy. We tried to rule out the neoplastic and neoplastic causes. And 13 days later, he added left sixth nerve palsy, as you can see. So they recheck the PET. We asked to re-evaluate the PET, and you can see in this brain MRI the increase of ventricles, and the lesion is increasing in size and number, thickening in the meninges of the optic nerve and the optic nerve infiltration. And here the new landmark is the narrowing of the arterial vessels. The cervical spine MRI, unremarkable, but they reevaluated and found at PET this hyperuptake at the gastroesophageal level junction. The second LP, the opening pressure was high, the glycemia low, the protein high. And the upper endoscopy shows the exophytic lesion at gastroesophageal junction that extends towards gastric roof. So the pathology reveals at stomach and esophagus level the signet ring cells. Oncology treatment begins, but CNS lesions, metastasis, perineoplastic, meningeal carcinomatosis, associated pathology. The oncology service thought about perineoplastic, but our service thought about meningeal carcinomatosis. So this is an article published in Fukuoka Medical Association where described three clinical cases, and the final conclusion was the administration of intrathecal chemotherapy may improve survival. Perineoplastic syndrome, we know, and multiple paraneoplastic antibodies. So a paper, this paper published in Ophthalmology, the conclusion were PON is relatively rare, bilateral, poor visual prognosis, perineoplastic antibody tests contribute to the diagnosis of PON distinguished from the other optic neuropathies. So the third LP, low glycemia, low glucose, high protein, and we performed an optic nerve sheath biopsy and was negative. So now we need to know what happened because prognosis and treatment changed between this. So the neuro services intervened and the pathology revealed bone, dural, optic nerve, biopsy, absence of neoplasia, but brain biopsy, meninges, and diffuse infiltration by atypical epithelial cells with signet ring cells, meningeal carcinomatosis was the diagnosis. So take-home messages, never disregard a simple symptom. The diagnosis ill of CSF in meningeal carcinomatosis is low. And finally, I want to highlight the importance of multidisciplinary work. Thank you very much.
Thank you, Dr. Marian, for the wonderful case. Dr. Krishna.
Quite an interesting case. I mean, to actually have signet cell carcinoma in the stomach presenting to you with a leptomeningeal carcinosis. It's very interesting. So the first thing that, I mean, in the absence of metastasis to the parenchymatous brain tissue, I mean, how does the signal cell get there to the leptomeningeal things? I mean, because it needs to be secreted by the choroidal, the choroidal plexus, and since there is a blood-brain barrier, I wonder how the in the absence of parenchymal spread, how did it reach the CSF space and cause a meningeal leptomeningeal carcinoma?
How I treat?
Yes, I mean, I just wondered.
Yes, I heard with the with the sound, with the weird sound. How I treat?
Yes, how did it reach? I mean, it's a very interesting case without a parenchymal involvement.
Yes,
How did it reach the parenchyma?
Thank you. I'm sorry. Thank you. I treat the oncology service treat the patient with chemotherapy, but they insist that was a perineoplastic hallmark, and this would be better because if was paraneoplastic with the oncology treatment was okay, but the problem was with it was a carcinomatous infiltration, so the prognosis is worse and only palliative than palliative. He received only palliative treatment because he didn't respond to the chemo.
Any other question? Yeah, please.
Yeah, because I was just wondering, because in the absence of a parenchymal metastasis, how would the tumor cells gain access to the the subarachnoid space? How would it actually be secreted through the chorocapillaris to to be able to, through a blood-brain barrier, to intact blood-brain barrier, to be able to reach? I mean, I'm just wondering. I'm just thinking what the others might want to input in this particular aspect of a leptomeningeal carcinomatosis, in the absence of a parenchymal spread.
Okay.
Any other comments from other panelists or speakers? If there are no comments, I think we'll move on to the next speaker. Thank you, Dr. Marian, for the wonderful case. We have Dr. Heidi Martins. 1 minute. She is the founder of the Neuro-Ophthalmology section at the Hospital San Martin, University of Buenos Aires, Argentina. She is the Chief of Practical Works, Ophthalmology Cathedra of Undergraduate and Postgraduate. She is a full member of the Argentine Society of Ophthalmology and Argentine Council of Ophthalmology. She is in the Professor Superior course of Neuro-Ophthalmology. She is the Professor and Coordinator of Neuro-Ophthalmology Superior course. She is the author of several articles, works, and posters in national and international congresses. She is also the author of a chapter of Neuro-Ophthalmology in various books of ophthalmology and endocrinology. Over to you, Dr. Heidi, for your case presentation. You can. Please unmute. Oh, yeah. Right. Please unmute yourself, Dr. Heidi.
Okay.
Doctor.
Yes.
Yeah, right.
Now you hear me?
Yep.
Yep. Okay. Thanks for your invitation and your presentation. I'm also excited of being here. And I'm going to talk of a different topic. If ion is related or not with vaccine. As we know, vaccine development and approval usually requires 10 years. But forced by the COVID pandemic, COVID-19 vaccines have been developed in months and received authorization for emergency use. So we all were very concerned about these new vaccines And these two facts result in an exhaustive surveillance worldwide looking for probable adverse events. And also, millions of people were vaccinated simultaneously all over the world, providing a huge sample for evaluation. Most of side effects of the vaccine are mild symptoms, fever, myalgia, asthenia, but there are more serious ones like thrombotic thrombocytopenia and mortal ones. How can we establish that a particular adverse event is related to the vaccine? It's always difficult to establish without that. Requires temporal association, exclude any other possible etiology, and also the incidence of the event must allow to consider the causality and exceed the natural incidence of this particular pathology. When we consider thrombotic thrombocytopenia, the presence of platelet factor 4, that is a marker of autoimmune activation of platelets, allows us to establish the relation. With subtendinitis that has been associated with vaccine, if we must exclude myelinated and infection pathology, and if the MRI is positive, we can say that this ophthalmitis is associated with vaccine. If the MRI is negative, we can't exclude the relation, but we say that it's a probably relation with the vaccine. As ION is a multifactorial pathology, one must exclude all risk factors. And what's really amazing that there are very few references to ION associated with vaccine in all the literature. How can we analyze the temporal association? The Guillain-Barré syndrome has been strongly associated with vaccine, and the Guillain-Barré Foundation established that with the syndrome occurs within 4 to 3 weeks of receiving an immunization, it can be associated with vaccine. Passage time is more unreliable. But most studies reveal that the majority of symptoms and pathology appear within 10 to 20 days after immunization. So any new finding in this time range, especially in a healthy person, can be attributed to the vaccine. But with COVID vaccine, we have the trouble that they are new, we don't have experience. So it raises a global consensus considering 2 months a period reasonable. Beyond that, we can't discard side effect, but it's less likely. And what about ION and previous report of other vaccine? The influenza vaccine is applied annually to millions of people over the age of 50 or 60. And this population was also the target for COVID vaccine initially, living as a care health provider. And so we have a lot of population being vaccinated, but we don't have report. As you can see, there are only 4 reports of non-arthritic ION and only a few of arthritic ION, even though we know that vaccine induce immune response and hyperactivity. And this is really a strange thing. Now I'll show you the 2 cases. The first one was a male, 61 years old, who referred acute diminution of vision 17 days after first dose of the Sputnik vaccination. He consulted 2 days after, what means 19 days after vaccination, and he decided by himself to receive the second dosage of Sputnik. Here I must clarify that since the beginning of the pandemic, I've been working in the CONASEVA, which is the National Vaccine Safety Commission of Argentine, and we received the reports of all the country. And the main request is the patient must continue with the skin vaccination. But this patient decided himself, received second dosing without new symptoms. As you can see, it's a typical ION with inferior hemifield defect in the right eye, pale and blurred margins, and no other finding in all the examination. He was treated for arterial hypertension and he was obese. His evaluation include echo Doppler, MRI, cardiologic evaluation complete, all normal, but the blood analysis revealed that he has hyperglycemia and hyperlipidemia that were previously ignored. So we can conclude that we are in presence of a typical non-arthritic IOM. But 3 months later, he referred acute loss of vision the other eye, and at that moment, the CRP was elevated. The Doppler showed the halo sign. He had systemic symptom, so we changed the diagnosis to arthritic 1. And you can see here the compromise of the visual field in both sides. Second case is a male, 21-year-old, who referred acute diminution of vision within 24 hours, again after the Sputnik third dose. He referred that he was vaccinated at 3 p.m. When he arrived home, he felt tired and with headache, so he went to sleep. And when he woke up at 5 a.m., he noticed that he has severely loss of vision in his left eye. He said that he felt hypotense. He has dry eye, but he received a lot of medication for a lot of risk factors: diabetes, cardiopathy, hyperlipidemia, anticoagulated, treatment for prostate. His visual acuity was 220. The optic disc was pale, not blurred. Here you can see the visual field with central scotoma and inferior scotoma. The Doppler revealed atherosclerosis. He refused to make MRI, but we can agree that at this age, with this clinical presentation, the myelinity disease is not probable. And the question was if he must apply the second doses. So we analyzed the case at the commission and conclude that the risk for him catching COVID infection was greater than to continue with the screen vaccination, and he had no new symptoms. And what about the literature and the reports of ION associated with COVID vaccine? There are very few reports. You can see 8. Most of them don't have risk factor at all. Only 1 arthritic. And Pfizer was the vaccine most frequently related with this pathology. The one with Covishield was considered by the author a coincidence because he has an ION in the fellow eye 8 months before. And the one with AstraZeneca was related to a thrombotic event only because AstraZeneca is the vaccine most frequently related to thrombotic event, not because they found nothing in the blood. And we are in here 2 cases Sputnik related. We must add here that in Argentine, during the 4 months of the pandemic, the only vaccine available was Sputnik. So, of course, all our reports were related to this vaccine. And although we are in communication with Gamaleya, the institute that developed the Sputnik vaccine, they don't refer adverse reports at all. They don't have adverse events. So, if we consider the probable etiology, there are a lot of theories, but in fact, there are only theories. We don't have a real element or test that can prove the relationship with the vaccine. And most of these theories seem more related to explain arthritic than non-arthritic ION. So for finishing, we have this situation. Millions of people over 50s simultaneously COVID vaccinated, and millions that receive annually influenza vaccine. So if we consider it a mere coincidence, I feel that we might have many more reports all years, keeping in mind the natural incidence of ION. We have temporal association, but it's not enough. We have really very few reports, even from previous vaccine, not only for COVID vaccine. And obviously they don't exceed the natural incidence of ION. So I want to remark the importance of active pharmacovigilance and to report all adverse events, even if we feel that it's a mere coincidence. It's the only way to write to real statistics and more real conclusions. So I want to hear your comments about the situation. Muchas gracias por la invitación.
Thank you, Dr. Heidi. Dr. Naveed, over to you.
Thank you, Dr. Heidi. That was a nice presentation. I think it again highlights what Andy was commenting on earlier about cause and effect and whether how important that is. What was interesting is I thought in your case was that both these patients are very elderly people, and some of them had NAIO and risk factors. I think the first case had hypertension and diabetes as well. So whether this was just an NAION or an arthritic AION in the second case, for example, but was it related to the COVID vaccine? I don't think we have much information about COVID vaccine and AIONs in that. I would like to hear other people who've had experience about this, if they have any comments on that. There are, I know I was looking up some literature on vaccines and AIONs. I did come across a paper where the MMR vaccine was given for children, and a couple of them developed optic neuritis following that.
Yes.
But the field effects in those cases looked very much altitudinal, which was also interesting, not a typical central scotoma that one would expect. So there is possibly some role of ischemia playing on these nerves, but whether one would label it an AION related to COVID, and I think that's important because as Dr. Padmavati was saying earlier, is this some atypical NAION? And if it opens a whole new can of worms as to do you treat these patients with systemic steroids or not? As you all know, it's already quite a controversial topic regarding NAIONs. So
I feel that, as you see in the literature, in the other reports of the literature, most of the also treated the patients because they were very afraid of the relation with the vaccine and the autoimmune response and the hyperreactivity. But they don't improve. They seem like typical ION in his behavior.
I think we would tend to err on the side of steroids rather than no treatment at all in these situations, because we really don't know what exactly.
Yes, but we must situate in the beginning of the pandemic. We all were very concerned with COVID and with this new vaccine, especially with a new vaccine like Moderna and Pfizer that really are new mechanisms for vaccination.
Right.
We have Sputnik and the travel in Argentine that we don't have references of other countries with this vaccine.
Right.
But we don't have any other vaccine available for us. So
Right.
we must use it. And we have optic neuritis. And what really intrigued me is that this vaccine have different mechanisms. And although we found that AstraZeneca is the most frequent vaccine related with thrombotic event, we have reports with all the vaccine. Also with Sputnik, we had thrombotic thrombocytopenia with death and compromise of cerebral compromise, venous thrombosis, and retinal thrombosis also. Optic neuritis, we have 7 or 8. All vaccine produce this. So we can think that the adjuvants are responsible for this event because they have different adjuvants and they act in different ways. So the hyperactivity and the excitation of autoimmune response seems the more suitable theory for explain all.
I think even the temporal association that you mentioned, I think that's important. Again, that's a kind of an artificial number sometimes. Is it 2 weeks or 3 weeks or 5 weeks or 6 weeks or 8 weeks? At what point in time would you consider these as an association and not? And that's it. I guess obviously the closer it is to the event, then I think that assumes a greater significance.
2 months is a global consensus.
Dr.
But
Haley?
really we don't have experience. We just can't discard, particularly after that, because we don't have experience on long-term surveillance with these vaccines.
Maybe
But
we could ask the others in the panel. Do you have any experience about COVID vaccination? Gordon, I think you're raising your hand.
But just that's a real hand, that one.
Yep.
We've actually got a paper just coming out in Lancet Neurology, and I'm sure lots of people who are on this panel have been involved in it. It has 101 authors.
Okay.
Dr. Petzold is the first author, and Dr. Plant is the last author, and the other 99 are all professors.
Yeah.
So this was the Delphi process, trying to get a consensus on diagnosis of optic neuritis. And one of the most tricky was post-vaccination. I mean, post-infection in general, but I think post-vaccination is more tricky because, of course, if someone has optic neuritis and has a vaccination a month later, no one's going to bother about that. If it happens the other way around, then, you know, it's a potential case. I think it is extremely difficult, and it requires not literature search, because it is hugely biased.
Right.
Requires some sort of prospective study to really look at the association. And I think with COVID, we had an opportunity to do this, and I hope that the current data being collected here in the UK will be helpful, because here we had completely new vaccines with no past history, all being rolled out at the same, you know, roughly the same time. So I think there is an opportunity to have a real answer to this in this great population study that we've all been involved in.
Do you think the presence of thrombocytopenia versus thrombocytosis would help to differentiate the vaccine-related AIONs versus the arthritic AIONs?
Not really. I mean, there is this curiosity that was because in thrombocytopenia, it depends if your platelets are normal or not, doesn't it?
Yep.
I mean, it does seem to be a risk, you know, paradoxically, it does seem to be a risk factor for thrombosis, doesn't it? So no, I think it requires a really good controlled epidemiological study, which I think probably we have in the UK now.
Right.
Dr. Haley.
Something.
Haley, go ahead.
The report requires effort. You must do a job, so it's difficult for the doctors to make the reports. Yeah.
Right.
So it's why I recommend active pharmacovigilance, because active includes reporting everything and not what you want to report. And also I want to add that we have a couple of cases with intense headache that the neurosurgeon studies with MRI, and MRI, and he found cerebral venous thrombosis, but without thrombocytopenia.
Okay.
Different from the usual thrombotic thrombocytopenia.
I'd probably like to bring in Virender Sachdev. He's here. He did mention that he has seen a few cases of COVID vaccine followed by an NAION-like picture. Virender, were your patients also elderly patients? Or?
Dr. Naveen and everyone. No, I think a couple of patients that we saw were middle-aged, and none of them had any other associated risk factors. I distinctly remember the patient having the episode after the second episode, and it presented within maybe 4 or 5 days following the second dose of the AstraZeneca vaccine.
Okay.
So,
and it had an altitudinal field effect and a pallid disc edema and things like that.
Yes, a very typical picture, and the OCT angio did show a capillary dropout there in our patient.
How did you treat them? And did you steroids or just watch?
we gave the option of no treatment versus steroid, and the patient opted for steroids.
Okay.
But there was no significant improvement.
I can tell you one thing that
Yes,
I think without the need for any epidemiological study was definitely associated with vaccination, because my wife, she ran one of the local vaccination hubs. She witnessed thousands of vaccinations, and it's syncope in young males.
Okay.
they had to buy or rent rather dozens of yoga mats, which they put all over the car park just to put these 17-year-old boys after they fainted with their vaccinations. It was an absolute clear-cut case for
Gordon, that was the needle, not the vaccination. I have teenage sons.
Oh, don't spoil it. We didn't try sham vaccination, I'm afraid. We should have done.
Dr. Heidi, Dr. Heidi, I have one last question for the session. Do you still advise a temporal artery biopsy in these cases? Final word.
We didn't do biopsy because we don't believe it arthritic. In the first case, 3 months later, she turned to arthritic by halo sign, PCR elevated, and systemic symptoms. We don't realize biopsy because we felt that it wasn't necessary.
Okay, thank you. With this, we end the second session. Thank you all the speakers and the panelists on board. Handing over the podium to Dr. Satya. It's all set for you.
Thank you, Padma. So let me introduce the panelists for this session now. We have Dr. Rohit Saxena, who is the professor in charge of strabismus and neuro-ophthalmology at RP Center of Ophthalmology, All India Institute, Delhi. He is also the secretary of the Indian Neuro-Ophthalmology Society. He has 230 indexed publications, 50 chapters in national and international books, and has been editor of 3 books on strabismus surgery, including a video atlas. He has received more than 30 awards, including the Hari Mohan Oration by DOS, Excellence in Strabismus by SPOSI, Best of Show Video at AAO 2019, Best Video Presentation at SPOSI, Best Indexed Publication by SPOSI, and Best Paper Award at Asia Arvo. And he's also got the AIMS Excellence Award in 18 and 19. The next panelist that we have is Dr. Mahesh Kumar. He is the head and professor, Department of Neuro-Ophthalmology at Arvind Eye Hospital, Madurai, India. He was trained under Professor Nachiar. He has been in the Neuro-Ophthalmology Department of Arvind Eye Hospital, Madurai for the last 20 years. And he has edited a neuro-ophthalmology textbook for postgraduate students. He is the co-author of an Atlas of Imaging in Neuro-Ophthalmology and has several publications in national and international journals. He is a popular invited speaker in state, national, and international meetings. Next, we have Dr. Shikha Basi. She has already been introduced in the first session. We have Dr. Ambika. She was already introduced in the second session. And then we have Dr. Durga Priyadarshini. She is a consultant in the Department of Neuro-Ophthalmology at Shankar Netralaya, Chennai, India. She did her Neuro-Ophthalmology fellowship from Shankar Netralaya, Chennai, and has been working there for the past 8 years. She has presented several scientific papers and posters in national conferences and has actively been a part of the organizing team of Neuro-Ophthalmology and cataract conferences at Shankar Netralaya. And let me introduce the first speaker of this session. He does not need an introduction though. Dr. Neil Miller, is the Frank B. Walsh Professor of Neuro-Ophthalmology and Professor of Ophthalmology, Neurology and Neurosurgery, Johns Hopkins University School of Medicine, Maryland, US. He has over 570 articles and 93 chapters and 13 books, including the 4th edition of Walsh and Hoyt's Clinical Neuro-Ophthalmology. He co-edited the 5th and 6th editions of the same book. He's also co-authored 4 editions of an abbreviated version of the textbook, that is the Essentials. The 4th edition was co-written with Prem Subramaniam and Vivek Patel in 2020. He has also co-authored 2 editions of the Neuro-Ophthalmology Survival Guide, and he has given 62 named lectures around the world. Many of Dr. Miller's previous fellows and residents hold faculty positions at major institutions throughout the world, and many of them are here in this webinar. May I ask Dr. Miller to share his presentation, please? Dr. Miller, please. Yes, we can see that. But we can't hear you.
Neil, you're muted.
Still mute, Neil. Still mute.
Yes.
How about now?
Good.
Better.
Okay. Sorry, thought I'd unmuted. I just wanted to thank Satya for putting together this marvelous conference and for inviting me to speak. My title is One or the Other or Both. I'll let you all decide. I have no disclosures, and my objectives are to describe an atypical case of vision loss and discuss the underlying association among different presumed autoimmune disorders. This is a 27-year-old woman who presented with 3 days of acute left eye central scotoma, decreased contrast, decreased color vision, and some difficulties with eye movement, particularly pain. She had no systemic complaints and there was no preceding febrile illness, and she was seen by an optometrist 1 day prior to our seeing her. She had mild asthma, a little bit of myopia, but no ocular surgery or trauma, no meds, no allergies, a non-contributory family history. She had occasionally drank alcohol, but no smoking or recreational drugs. When we saw her, she had normal visual acuity, although in the left eye it was a bit eccentric. Her eye pressures were normal. She had a trace left RAPD, a little bit of slow color vision on the left, but with some red desaturation and a central scotoma. Her eye movements were full. Her external examination was normal. The eyes were white and quiet. Anterior segments were normal. Lenses and vitreous were normal. And here in this optos, you see the right disc. And you know, these pictures often look pale with the optos, but it really was pretty normal in appearance. And this is the left one. And everything looked pretty reasonable. And so the presumed diagnosis was a retrobulbar optic neuritis. She had the usual assessment for optic neuritis, at least in our institution. She had a normal MRI, brain and orbits with no definite optic nerve abnormalities. She also had a C-spine that was unremarkable. She had a variety of blood tests that you can see here, in particular, aquaporin 4 and MOG antibodies. And she had an LP that was entirely normal with all of these various cultures and assessments. So neurology saw her and agreed that she probably had retrobulbar optic neuritis, and she was placed on the usual, at least at our institution, IV methylprednisolone for 3 days and then oral prednisone taper. And at 2 weeks, her vision was subjectively improved by up to 70%, but she still had some persistent scotomas. When we saw her, her vision was 20/25. Again, IOPs were normal. She had no RAPD now. She had perfectly normal color vision. And she still had a central field defect, but it was definitely improved from previous. So here's her left disc, nothing impressive. So here's routine retrobulbar optic neuritis, would you do any further studies? And I would hearken back to a comment that I think it was Helen made in terms of when somebody sees a specific field scotoma, what you think about. Well, let's go on. Here is her visual field. Anybody want to comment on the field?
So
Looks like a big blind spot.
Yeah,
It does,
looks a little,
doesn't it?
that's all it looked like. Looks a little unusual for an retrobulbar neuritis kind of a presentation. And
Yeah, I agree, Rosie. Mhm.
any BEP that you would have planned for?
We didn't do that, but, and also note the nerve fiber layer,
This is
pretty normal,
at present.
ganglion cell layer. Sorry, Shika.
This is at presentation or after the intravenous steroids?
This is after the steroids.
This is after the steroids. So
Yeah.
this is the residual defect. Usually, optic neuritis patients do complain of some little loss of contrast, but this kind of thing, this is, yeah, maybe both. There's something else.
Okay, so
OCT, this OCT,
no, we did a simpler thing. We just did the autofluorescence, and you'll notice all of the dots and abnormalities around there. And in fact, if you go back to the original, which I moved through very quickly so you wouldn't see it, you can sort of get the sense of these abnormalities even at the beginning. If we look at the macular area, you can see the abnormalities in the retinal pigment epithelium.
Here you can see.
Yeah. So at 2 months of follow-up, her vision was almost back to baseline. She had no new symptoms. Neurology still thought she had had an atypical optic neuritis and recommended continued follow-up over a year. When we saw her, this is about the fourth time, she basically was back to completely normal. And you can see the resolution of a lot of these abnormal areas in the pigment epithelium. So we concluded that she had multiple evanescent white dot syndrome, MUDs, as part of this. But the question is, did she have two things, or was it always MUDs? You know that in MUDs, it's an autoimmune process, presumably at least, no genetic or racial predilection. And most of the people are young, healthy individuals with unilateral problems. Often these acute scotomas with photopsias and dyschromatopsias and this typical picture that we see on the OCT and on the fundus exam. And you can go through these various things of the early and late persistent findings that occur in these syndromes. But the disease is usually self-limited, resolves within a few weeks and with an excellent visual prognosis. Although, as you saw there, some patients do have, at least for a time, an enlarged blind spot. And I can remember probably 30 years ago or more, before Don Gass described the MUDs or big blind spot syndrome, a patient I saw who had a history that suggested some disc swelling. But when I saw him, absolutely everything looked normal. And I thought he was non-organic. And then it was only later when Gass described the big blind spot syndrome or MUDs or Azor, that I sort of thought, oh, I really missed it in the guy. And I actually called him, brought him back, apologized for doubting him, and did an ERG that was abnormal. And these are just some of the things that can mimic these issues, and I won't spend time on it because of our time things. But I want to ask the panel if this is a case of mistaken identity or two separate but related conditions. So Rohit, what do you think?
So I would think that just looking back, it would be easy for us to say that probably it was MUDES only, but I would have thought that, a little more baseline investigations that are more detailed, early clinical exam, like Shika said, in early fields, a more, closer disc examination rather than the optos would probably have helped us, give it a better understanding from the very beginning. But I would still say that I would stick with MUDES and not think in terms of, considering another pathology. More importantly, because I would say that if we harbor the thought of, an optic neuritis, then we are actually looking at a long-term prognosis and a closer follow-up of this patient. So we need to be, of course, it's good from an academic discussion what it was, but from a prognosticating point of view, it would be very important for us to, be a little surer. Maybe you just ask him to follow up. Like I said, a visual evoked response that may actually, help us now that he's recovered. So we would expect a VEP to be a little more delayed even now if it was an RBN. So maybe that would help us. And like I said, I would be a little careful to give, multiple etiologies to the presentation.
Yeah, I agree completely. And we have scheduled him for a VEP. You also bring up something that is a real annoyance of mine, which is the use of optos when you're dealing with presumed optic nerve issues. It just drives me crazy. But the residents have been taught to use optos, and it's terrible. There are cases of misdiagnosis that have been reported. This paper from 2016, a 25-year-old woman with acute left central scotoma, diagnosed with retrobulbar optic neuritis by neurology, normal MRI, and then noted the foveal granularity and OCT and fluorescein, diagnosed MUDES. This is from that case, not as impressive on the autofluorescence as our case, but still there. There was another one from Dan's group. I don't know if Dan's still on, from just was published, that was a similar sort of thing. And interestingly, had a mild right RAPD, which I thought was fascinating, with a little bit of optic disc swelling, but otherwise was normal. And this is from their case.
Right. Neil, it's interesting what you're saying. For Bonsai, we just refuse to include images from optos anymore because they just don't work.
Yeah.
Yep. And this was from your paper, Dan,
yep,
showing the multifocal ERG abnormalities and the fluorescein, et cetera. On the other hand, there are cases where they thought there were both. And this was a paper in the Journal of Neuro-Ophthalmology a couple of years ago, a 17-year-old girl with what was felt to be a clear-cut unilateral optic neuritis, as well as an exam consistent with one of these, whatever you want to call them. In this case, they called it Azor. And this was, you can see the pigment changes in that left eye, and the abnormality is better in both eyes here. Not much in terms of fluorescein, but clear abnormalities in the fovea. And then this more recent case of very temporal, we were talking about temporal plausibility, if you will, but this case from Graves Archives a couple years ago, last year, 3 patients who had definite separation, unlike our patient, of up to 60 months of after an optic neuritis, no prodromal virus illness, but and one of the patients had white matter lesions on MRI. So, it may be that this is some sort of process that induces some autoimmune changes affecting different ocular structures. So I would just summarize by saying that MUDES can be mistaken for optic neuritis, but also MUDES or one of these other similar syndromes maybe can be associated with a real optic neuritis related to the effects of on the immune system. But as we all know, if you combine OCT, fundus photography, autofluorescence, electrophysiology, and in one case, pupillometry, you can generally establish the diagnosis. And we had some help from one of our residents, and I think some of you know Fernando Aravallo, our retinal specialist who helped in this. So that's all I have. And Satya, in the interest of time, I'm thinking that the second case doesn't need to go. That's we can move on to other people. I hate to hold them up.
Neil, I haven't received any objection from anyone regarding time, so I think you should go on to the second case.
Well, if you want me to.
Yes.
I guess.
Yes.
Okay.
Although there are a lot of very interesting comments going on in the chat about this very case also. But yeah,
okay.
Extremely interesting.
Do you want me to do that first?
Yeah, I think so. I think let's do the damned case.
Let's look at
yeah.
Well, Andy comments that the relationship between the MUDs and Azor, et cetera, there back when just after Don Gass described these things, the question became, are you a lumper or a splitter? And I'm not sure it's really crucial. Claire points out that MUDs would give a trace RAPD, but not an obvious one. It's always interesting to me that I provide our residents with a 0.3 log unit filter because I never want them to say, I'm not sure if there's an RAPD or not. Andy, again, lumper versus splitter. I don't know, Zoe asked if pain has been described with MUDs with extraocular movement. I'm not aware of that, but since I don't see those cases, unless they're misdiagnosed, I don't know, but it's not something that I ever knew about. And the issue is that has also been brought up, and I mentioned the patient I saw years ago who had this history of perhaps some disc swelling. So I don't know the answer in terms of if there's enough disease to cause some sort of reactive disc swelling, and also enough disease with the photoreceptors to cause an RAPD. We know retinal disease can do that. I agree that a multifocal ERG and OCT make the diagnosis easily, although as you saw, the autofluorescence was enough once we realized that we should do it. I don't think in terms of MUDs, my understanding is that in general, they don't require steroids. They generally respond without it. So those are those. So just a quickie. And this truly is for the panel. So this is a 70-year-old woman with sudden visual loss in the right eye. We're seeing over a couple of weeks. She does have a history of breast cancer, but it was some years ago, treated successfully, apparently with surgery and chemotherapy and radiation, and was recently identified, assessed, and had no recurrence. She also has hypertension, hyperthyroidism, and Sjogren's. And she had a normal ACE and chest X-ray according to the patient, no allergies, the usual vitamins, etc. She has some cataracts. When we saw her visual acuity, she's a high myope, but her visual acuity was 20/40, 20/50. She had a mild, again, right, RAPD, but also a light difference of 70% difference in light brightness between the two eyes. Eye movements normal, no proptosis. You can see here a little bit of nuclear sclerosis, and her fundi appeared normal. Her field showed some mild field defect in that left eye. And here is an MR, and you can see the enlargement of the nerve all the way up to the globe. This is right behind the globe. And you can see the enhancement of the sheath with the low, the hypo-enhance or non-enhancing portion in the middle. It goes all the way to the through the optic canal. And on these coronal T1s with contrast, you can see again the irregularity around the optic nerve with this typical, I'm not sure how well it projects, but irregularity into the periorbital or perineural fat. And I used to think this was absolutely pathognomonic of this condition until Andy presented a case at, I think at our AAO course of sarcoid, which looked like this. But you can see here, it goes all the way onto the planum and surrounds the anterior clinoid. So I think it's pretty likely that this is an optic nerve sheath meningioma, whether it's primary or secondary. I'm inclined to think that it's secondary going forward and back. But what I want to ask is the management options for the patient, because would you do anything at all? Would you radiate, given the fact that you're going to have to radiate the globe, even if you went with protons? Would you, what would people do?
So I would think that the visual field of the other eye would be an important factor we need to consider, because we are not intervening or not radiating because we want to protect the vision in this eye. But in that process, I think we are increasing the risk of vision loss having in the other eye. Therefore, if you can see it going back to the chiasm, I think, one would think of erring on the side of treatment versus not. So, like I said, I would probably monitor for visual fields and see how that's, how that's
that in 50 years of dealing with these cases, I've only seen 2 cases in which the tumor on one side went across the planum and involved the other side. I'm not saying it doesn't occur, it definitely does, but it's really, really rare. Having said that, I agree with you completely that we're always worried that it's going to cross to the other side and get in the opposite canal or compress the nerve at the intracranial end of the canal.
So
Andy,
I was just mentioning about the case I saw, which looked exactly like yours, and I did the traditional thing. I told the patient it looks like a sheath meningioma. It's so characteristic, we don't even have to biopsy it. We radiate it, and then miraculously, the optic nerve sheath meningioma disappeared completely radiographically. And the patient was so grateful to me that I eliminated her tumor, but it was sarcoidosis. And the radiation.
Yeah, I think we recently saw another one like that, where the thing completely resolved on MRI, and that's not a meningioma. The other reason, and we'll have a paper coming out very shortly, we've now done next generation sequencing on 19 patients with sheath meningiomas, I think 11 primary and 8 secondary, and we've found specific mutations very similar, I guess not surprisingly, to the ones that have been reported in general skull base meningiomas, NF2, in patients, let me be clear, that don't have clinical manifestations of NF2, but the tumor has mutation in the NF2 gene, AKT1, several others. And so my thought is that at some point, patients like this, and this is one of the reasons I wanted to present the case, patients like this will undergo targeted therapy, much like we're now doing for optic pathway gliomas. So I think it's an issue because as you know, we've reported a case of radiation retinopathy in a patient who had an optic nerve sheath or presumed optic nerve sheath meningioma. And when they come all the way to the globe, it's just really tough in terms of, as Rohit says, you want to protect the other eye. You'd like them not to go blind in this eye, but you don't want to blind them or cause more problems by doing radiation. So it's a tough situation, but maybe within another year or so, we'll have some targeted chemotherapy. That's all I have.
Andy, would a CT scan help at baseline to differentiate? So probably if you think of a meningioma.
Yeah, so I've been doing a CT. If I see the hyperostosis or the tram tract calcification, I feel a lot better about that. I also don't think anyone should go blind or get radiated without a steroid trial. So that's the two things to do differently now. In the chronic people, I don't, but in the acute or subacute people, I do.
I agree with you, Andy, and it wasn't just your case that made me do that, but sometimes there is an inflammatory response, and I've seen a couple of patients whom I thought had optic nerve sheath meningiomas with field defects, gave them steroids, the lesion didn't go away, but the vision improved. And I sort of back off and say, okay, vision isn't quite as bad, so we'll see, we'll observe.
I think that also accounts for some of the cases the radiation makes people better, is that they're not actually treating the tumor, it's the inflammatory response, I think, and maybe a compartment syndrome in the canal that they're relieving somehow by reducing a little bit of edema. So I agree.
I agree. I don't know if Gordon's still on, but one of the points he made in passing was the inflammatory response that some meningiomas make when we were talking about the metastatic adenocarcinoma. And meningiomas, intracranial meningiomas at least, can cause huge amounts of cerebral edema. And our neurosurgeons would, in the past, would remove these things, and then the patient would have a terrible postoperative period because of post-op cerebral edema. And some of the cases we've seen, they looked so bad on MRI that it was hard to believe they had a meningioma. Everybody thought it was a more malignant process. So meningiomas can fool you with their inflammatory response.
So if you suspect, if it's meningioma-like, you should think in terms of giving steroids at the first go.
I think so. I agree with Andy. I usually give them a couple of weeks of steroids, 1 milligram per kilogram per day. I mean, I'm not going to treat them with IV, but I think it's reasonable to at least do that. I don't think you're going to hurt them with a couple of weeks of steroids. And if something miraculously occurs, then maybe you do something else. Of course, treating sarcoid with radiation isn't the worst thing in the world.
Yeah, sure. Great case. I think both of them were amazingly good. I think, and they really, widened the horizon, made us feel that, we can't have, very focused, a very tubular vision when you are practicing anything in neuro-ophthalmology or any part of ophthalmology for that matter. I mean, it really, at every stage, you should have a good horizontal, understanding. So you took us right from the optic nerve to the retina, and from the retina to the chiasm and the brain. So I think we covered all ends of the visual pathway from, retina, from the photoreceptors to occipital lobe. Wonderful. I think Neil, it was.
You're very kind, Rohit. Yeah. Thank you so much.
There's a question in the chat. I think Durga has asked something. Dr. Miller.
Yeah.
Yeah, the question is that in bilateral suspected optic nerve sheath meningioma, if they are negative for NF gene, do you go ahead with biopsy and then plan radiotherapy? How early, as in what is the minimum age that you have done radiotherapy?
At this point in time, we are not biopsying these lesions. I think you can, and some of it, I mean, obviously there are various different patterns on MRI, the fusiform, the one that looks like a big glob that you mistake for a cavernous angioma or solitary fibrous tumor, and then the one I showed you. But in general, we don't biopsy. If we think it's a sheath meningioma, and as we said, it doesn't respond to steroids, we would go ahead and radiate 54 gray and see what happens. I think it's rare, as it depends on the port, the extent of the port of the radiation. But if we're able to spare the posterior pole with stereotactic fractionated radiation therapy, or rarely stereotactic radiosurgery, or hypofractionated, everybody's doing something a little bit different, but almost everybody is now doing stereotactic procedures, then we will just go ahead and do that. The youngest person we've radiated actually was given protons at Children's Hospital, Pennsylvania, is a 9-year-old whom I saw, and he's doing very well. His visual function stabilized. I don't like to make the diagnosis of optic nerve sheath or any other, I suppose, meningioma in children without NF2, but this trial appeared to have it, and we decided to go ahead and have him radiated, and he's doing great.
Thank you, Neil. So now we'll move on to the next speaker. And that is Dr. Andrew Lee, who's Irwin Jean Lyman Centennial Chair in Ophthalmology and the founding chairman of the Blanton Eye Institute, Department of Ophthalmology at Houston Methodist Hospital in Houston, Texas. He is a past president and current chairman of the board of NANOS. He has served in numerous leadership roles at the AAO, including member of the OKAP committee, chair of the AAO Task Force on Aging, and later the AAO Committee on Aging. He has received the AAO Achievement Award, Senior Achievement Award, Secretariat Award, and Lifetime Achievement Award, and he volunteers with the Minorities in Ophthalmology Mentors Program. He has been the invited speaker at over 300 national and international medical meetings, and he has written over 500 peer-reviewed publications and 14 full text books, and has given 15 named lectures. Over to you, Andrew.
All right, great. Let's see about sharing my screen. Can you see the screen?
Yes.
So I want to thank the organizers for inviting me. Okay, so here's the case: testicular pain and vision loss. So that's the whole case. I was going to ask Gordon what his differential diagnosis of testicular pain with neuro-op is, but I don't see Gordon anymore. So I guess Dan Malaya or Neil will have to answer. What is the differential diagnosis for this testicular pain and vision loss? Are they there?
Somebody
Neil?
kicks you and your eyes well up with tears.
It's a bobblehead that I made of Gordon on the anniversary of his retirement. So we'll come back to that. So here's the case. They're 41. They're an uncontrolled vasculopath. They had 1 million risk factors: diabetes, chronic kidney disease, hypertension, high cholesterol, past ocular history, none. He wasn't taking any of his 10 medicines, which he was supposed to be taking, and he had the testicular pain. And the patient's self-diagnosis was, I've been treating my body like a carnival. He had 1 million vasculopathic risk factors in his family. He was married. He smoked previously, and he used every drug that you can imagine in Houston, Texas: methamphetamines, LSD, marijuana, mushrooms, but no IV drug use. He was very specific about that. The patient presented for a stroke workup because he had a stroke. He presented after having right arm symptoms of numbness, and a brain CT showed right chronic lacunar infarcts, but the MRI showed multiple infarctions in the left basal ganglia, left occipital lobe, centrum semivalvate, pontine white matter ischemic disease. He had abnormal gradient echo showing hemorrhage in his brainstem and his pons. A CTA was performed and was negative, and the full stroke workup was negative, including echo, EKG, bubble study. His blood sugar was 300 plus, his blood pressure was 246. His testicular pain improved during the admission, and he was started on dual antiplatelet therapy with aspirin and clopidogrel, Plavix, and discharged home. So this is just a run through. I hope the video is running of the MRI. Can you see, guys, running through there, showing the multiple white matter ischemic lesions, and in his occipital lobe as well, and his pons, brainstem. A lot of white matter ischemic disease here, all the way down, infratentorial and supratentorial. And so he was just discharged as stroke, but he had these gradient echo things, this hemorrhage right here, you see that hypointensity on the gradient echo, and he had other gradient echo lesions. So Neil, as you know, I was a fellow with Paul Brazis, and Paul Brazis retired, and now that Neil is retiring, it's very disconcerting to me when my fellow retired and my faculty member are retiring. So I hope that doesn't mean I'm going to retire soon. But
well, yeah. How do you think I feel when I see my students retire and I'm still working?
So Neil, what about this testicular pain?
Well, I wondered if he had a testicular germinoma or carcinoma and had a perineoplastic process was my thought.
All right. So he got second stroke, this time left-sided symptoms, numbness and weakness, left homonymous hemianopsia. First admission was right-sided. CT was repeated, which showed chronic small vessel ischemia, but now he has new infarcts in the right thalamus, mid-pons, midline cerebellar, vermis, more microhemorrhages on gradient echo in the pons. An MRA was performed, which showed he had tortuous internal carotid artery, but nothing else was seen. Repeat the stroke workup, echo, loop recorder, no AFib, and they switched him from antiplatelet alone to Eliquis plus clopidogrel. During the admission, however, he had low-grade fever, mild leukocytosis, and testicular pain. And this is where Neuro-Op was consulted. He was 20/20. His structural eye exam, the anterior segment was normal, but he had this multifocal cotton wool patches and this Roth spot. I don't know if you can see that Roth spot right there.
Yeah.
See that thing there? A white-centered hemorrhage appeared. And he had the homonymous hemianopsia on the left.
So he's throwing emboli from everywhere.
And his OCT.
Does he have an infection?
Andy, how about orchitis from syphilis with ocular manifestations?
So he was tested for the usual suspects, syphilis, hypercoagulable state workup, and on examination, he had this splinter nail hemorrhage, to Neil's point. So what do you think now, Neil? Infection-wise, are you there, Neil?
Well, I mean, that's present in some of these cases. The question is this an infectious process, or is it like, what is it, thrombotic cytopenic purpura or something of that nature?
So I thought I was a genius and said, oh, it's subacute bacterial endocarditis, it's infectious, and that we missed the thromboembolic source the entire time. But
except you did an echo.
Yeah, we did 3 echoes. They were all normal. Thrombocytopenia, the thing you just said, hematologic, and then the rest of the differential, which is not applicable, but vasculitis on the list, of course.
So Andy, does he have a pancytopenia is what you're saying?
He had a mild anemia, and he did not have thrombocytopenia. His SED rate was 17. The echo was repeated again, no vegetations, no arrhythmia. This is this 3rd stroke workup. A1C was 7.4, cholesterol was normal. But what about that testicular pain? Dan. Oh, Fiona wants to say about the testicle. Okay, go ahead.
I think you have to. I think you have to go south of the bikini line and look at the testicle.
You do in a stroke work.
I know.
Stroke workup, testicle exam.
These are difficult days.
The patient called and said, "Hey, I've got this rash on my skin. Does that help?"
Syphilis, I was saying.
He was Dan, he was tested twice for syphilis,
It
RPR.
doesn't look like the syphilitic.
This could be
graph.
lymphoma too, though. So it could be with that vasculitic pattern lymphoma too.
So he had an angiogram which showed beating of several small vessels, and he had distal occlusive disease, Sylvian branches of the right MCA, hemispheric and vermian branches of the left pica were also stenotic. What do you guys think now?
Well, is it really stenosis or is it multiple emboli closing them off?
They said it could be either, but they were favoring vasculitis at this point.
Well, it could be a primary CNS vasculitis. Well, it can't be primary because you've got testicular pain, but it could be a vasculitis involving the testicular region, I guess.
So then Fiona said body CT and PET scan. He had a full body scan and a PET scan, which showed no underlying lesion. No neoplasm was identified. CSF only showed 72 protein, but no white cells. Does that help? Fiona, does that help?
It's non-specific, but it could still be paraneoplastic. You just haven't found the source.
So the whole body, nothing. And scrotal ultrasound showed bilateral epidermoorchitis. A small nerve biopsy, sural nerve biopsy, was performed after his nerve conduction studies, showed a axonal neuropathy, which showed moderate axonal loss of primarily large myelinated fibers, but no active vasculitis, no amyloid, no intraneural inflammation or demyelination. Does that help? Neil, does it help?
Well, it doesn't help me.
Fiona, I got orchitis. Dan
I'm
said
sorry to hear
syphilis,
that.
but there's
I'm
no
sorry to
syphilis.
hear that, Andy. Yeah, no, I mean, I think he still has an inflammatory process with a vasculitic phenotype. You haven't found an underlying cause, but I know we're going to hear it.
Okay, so you guys like vasculitis? Here's your list. Small, medium, large. It's giant cell?
Giant cell
is
can do anything, but that's large. He's older than, he's what, 70 something? 72, right?
No, he's not that old. He's like, how about this one? So here are the diagnostic criteria for the diagnosis. Weight loss, which he had, libido, which he did not have, testicle pain, which he did have, myalgias, which he did have, mononeuropathy, for which he had a sural nerve biopsy, axonal neuropathy. He was hypertensive. He had chronic kidney disease, which they said was hypertensive kidney disease. He was Hep B negative. His arteriogram showed stenosis / vasculitis. We have no biopsy PMNs. What's the diagnosis? Dan, what's the diagnosis, you know?
Was he ANCA negative or positive, did you say, Andy?
ANCA negative. So amazingly, this is what this guy had. He had all the criteria for polyarteritis nodosa. The weight loss, the testicle thing, the mononeuropathy, the blood pressure.
I thought they usually had GI disturbance. I thought that was the. I thought the patients with PAN had primarily GI issues. They had bowel infarctions.
That's what I thought too. Occlusion of visceral arteries. Neil, I was not thinking PAN at all here.
Well, you know he has vasculitis, but Andy, if you go back to that slide, it's a lot of like non-specific end organ damage of a misspent life also.
That is the main point, is a lot of things on this list, you are just thinking he's just regular hypertension, regular hypertensive kidney disease. He's weight loss, that doesn't help. A lot of this stuff is just descriptive. I mean, that is the amazing thing about this to me. And what Neil just said, my concept of PAN was visceral occlusive arteritis. However, you don't have to have it. He was given IV steroids and IV cyclophosphamide. Fiona, I'm sorry.
No, sorry to interrupt. I was going to say, were you going to say no one suffers testicular pain without a course of steroids?
Here's his field. He got a little bit better. Isn't that great? And his fundus got better too. So we controlled all his risk factors. He still has the cotton wool spots, but way better than the rot spot and the badness that we saw initially. So this case to me is fascinating because I thought it was going to be subacute bacterial endarchitis. I found that splinter hemorrhage and I was so proud of myself, but nah, it wasn't helpful. He had the rot spot, splinter hemorrhage, the homonymous hemianopsia, and I thought, oh, this is endarchitis. We just missed it. But the testicular pain, and then I went down the whole route that Neil suggested initially, CNS vasculitis, but the testicular pain. And vasculitis can definitely cause stroke in young people. And to Fiona's point, PAN has some super strange diagnostic criteria. And testicular pain is such a prominent feature that the American College of Rheumatology put that as one of the defining features. But he had everything else: hypertension, chronic renal disease, the weight loss, the skin lesion. He was not Hep B positive, but he had myalgias. But these are the things that you should start to put together. So my main point in this case was PAN has weird diagnostic criteria. And one of the weirdest is, what about that testicular pain? So now you know about that testicular pain. It was the clue from the start. And I did not have a differential diagnosis, Neil, for testicular pain and vision loss. But now I do. Syphilis, of course, always, as Dan said, paraneoplastic, but PAN. So I don't know if anyone else has seen PAN like this, but I was.
The real question is whether anybody has ever asked about testicular pain.
Well, that's the strange thing about this case also, Neil. This testicular pain was not in the eye records at all because nobody from ophthalmology asked. In my record, I included it, but it was like buried in the, the guy's million complaints. He had everything was hurting him, including his testicle. I was like, dude, that has nothing to do with this. But it had everything to do with it.
Andy, the few cases with PAN that I've seen recently, there was some firm proof, either biopsy or some arteriography. I'm really puzzled. Those things are not among the criteria.
Yeah, the biopsy is, but you have to have something to biopsy. So the biopsy definitely is in the criteria. Polymorphonuclear cells in the biopsy is a definitive thing. In this guy, we gave him the steroids and cyclophosphamide. Everything went away. We CAT scanned his whole body looking for something to biopsy, but there was nothing. And the orchitis completely went away with steroids. So he didn't want to have his testicle biopsied. Not that I blame him for that.
Don't blame him.
So yeah, so he meets diagnostic criteria without the biopsy, Dan, I guess is my point. And there's no biomarker for PAN as opposed to the other ANCA related things, C-ANCA, P-ANCA. Sometimes their ANCA is positive, but it's not required under the ACR criteria. So it's a disorder that has no biomarker. It has all these strange criteria. And yeah, you got to ask about testicle pain, even if you're an ophthalmologist. It's such a weird thing.
Andy, thank you for a great case. I have a few questions, Andy.
All right.
Yeah, I had a chance to go through your published article also in the Journal of Neuro-Ophthalmology when I received this case report about 3-4 days back. And I understood that during his initial hospital admission elsewhere, did he have, you had told about his occipital infarct. Did he experience a right-sided hemianopia or did it go away? Because there
I didn't see him initially, but yeah, he had the initial on the right. Everything was on the right. And then I saw him on the third stroke workup. On the second one, he had the left side of things, but I still wasn't involved until the third admission. Right. The third admission, we found the rot spot and the left homonymous, but that everything that he had on the right was gone by then. So it was like a come and go kind of thing. So in retrospect, that probably was also a clue that it wasn't regular stroke, that it was somehow, but I really thought it was going to be endarchitis. That's really what I thought, but did 3 echocardiograms.
So he probably had a homonymous hemianopic field defect and probably went away. Probably.
I think so, but I don't know. He was not seen by ophthalmology during that admission at the outside.
Yeah, okay. So there is another question I had about this cutaneous manifestations, which I read it as a cutaneous leucoclastic vasculitis. And,
yeah, that's what he had. He had he had the cutaneous leucoclastic vasculitis. Dermatology saw him. Normally, it's livido-reticularis, which is like that purple net-like thing on your legs. He didn't have that. He had that non-specific thing. But to Dan's point, I was like, oh, this guy, syphilis guy, but it wasn't.
So even as per your diagram, it was dermal capillaries and venules which are involved in cutaneous vasculitis, leucoclastic vasculitis. And our case is more of a medium-sized arterioles which are getting involved. So do we really connect the two, or could it be just a coincidental?
So our rheumatologist felt that polyarteritis venosus is like a spectrum disorder. So it has like small and medium and large, even though it's predominantly a medium to large vessel vasculitis. And as Neil said, it's so easy when they have the visceral, mesenteric arteritis. That's the book version of PAN. And if he had that, this wouldn't be interesting at all, I don't think. But he didn't have that, Neil. So the book totally made me go down the wrong pathway there.
Okay. So again, as you said, there are no serological tests, right, for this, no biomarkers for this.
I wish there was a biomarker. So the ANCA is sometimes positive in PAN, but they don't use it that way. That's for Wegener's, GPA, eGPA, ANCA-related vasculitides. Not this, but sometimes their antibodies are positive. Like some people have ANAs that are positive, and that's not part of the criteria at all. I wish there was a biomarker, then we could have got the answer right away. Instead, you get these weird things, as Fiona said, very disparate things too. Myalgias, I mean, come on, weight loss. That just shows you that we don't know a lot of stuff. But the testicular pain, it was like so obvious in retrospect. I wish I could tell you that I knew what it was when he said my testicle was hurting, but I was really like, I don't care that your testicle is hurting. I don't care.
Thank you, Andy. Satya?
Can you hear me now?
Yes.
Yes.
Thank you, Andy. So we move on to the next presenter, and that is Dr. Valerie Pervin. She is from the Indiana University Medical Center. She is a professor of ophthalmology and neurology there. She joined in 1983 and has remained in Indianapolis since that time. In addition to journal articles and chapters, she co-authored with Dr. Kawasaki the well-received Common Neuro-Ophthalmic Pitfalls, a case-based approach to the specialty. She is a reviewer for many journals, has been an editor for Journal of Neuro-Ophthalmology, and served on several NANOS committees as a term on the NANOS board of directors. Particular interests include inflammatory optic neuropathies such as optic perineuritis and neuroretinitis, ischemic optic neuropathies, pseudotumor cerebri syndrome, and iatrogenic neuro-ophthalmic complications. Over to you, Valerie.
Thank you. Thanks so much. Share screen. Okay. Sorry, it's slow to do what I want it to do. There, okay. So, and you can hear me okay?
Yeah.
Yes. Yes, thank you. So thank you very much to Satya and other organizers for inviting me to take part. This is a great pleasure. My case is, I've called this, Are We Done Yet? And just as a warning or explanation, a preview, my case is not nearly as fancy or complicated as the cases we've been seeing so far. So maybe it'll be a refresher or maybe a break. But so this case is really geared not so much as a challenge for our panel, but really more as a teaching case for the audience, and specifically for an audience of general or non-specialized, non-neuro-ophthalmologists. So I hope that it will have some useful points. This patient was a 56-year-old woman. So we already know she wasn't complaining of testicular pain. That was not on her list. What she complained of was decreased vision in the right eye for the previous year. Sorry, get out of the, for the past year. She experienced sudden onset of a decreased vision inferiorly in the right eye, not associated with eye pain. She had no systemic symptoms and no other focal neurologic deficits. She felt that there was no change in her vision since that sudden onset. Her past medical history was positive for hypertension that was well controlled and mild hyperlipidemia. Her medications were hydrochlorothiazide and atorvastatin. Family history and social history were not contributory. On review of systems, she described a 15-year history of intermittent headaches that were relieved by caffeine and relieved by sleep. She denied loud snoring, excessive daytime somnolence, apneic spells. She was not overweight, and there was no history of recent weight gain. On examination, visual acuity in the involved right eye was 20/60. Vision in the left eye was 20/25. In the right eye, she missed 5 of 15 color plates. She identified all 15 in the left eye. There was a 2+ right relative afferent pupillary defect. Ocular motility and slit lamp examinations were normal. Here are her visual fields. In the left eye, the field was full. In the right eye, there was some generalized depression, but most prominently, an absolute defect that emerged from the blind spot and respected the horizontal meridian. Essentially, this was a form of an inferior altitudinal defect. At least this is how we classified this. Fundus exam in the right eye showed diffuse optic disc pallor. In the left eye, the disc was healthy looking. There was no disc edema. She had a relatively small cup disc ratio in that fellow eye. So summarizing, this patient had sudden onset of a right optic neuropathy 1 year prior with an inferior altitudinal defect and ipsilateral disc pallor.
She's got some cupping there, doesn't she, Val?
Well, I thought both in the involved eye you're talking about, the disc that's pale. It looked mildly diffusely cupped. This was this is not a brand new case. This is a pre-OCT case, true confessions. So there's not an OCT to document thinning. But no, I know exactly what you mean. It looks.
I only mentioned it in terms of an ischemic process would be very unlikely, at least an old anterior ischemic optic neuropathy, given the appearance of the disc.
So that's one reason to doubt, because the question that just showed up on your screen is this non-arteritic anterior ischemic optic neuropathy? So that would be one reason to suspect that it's not, that maybe it's not a good explanation, which will be useful. So so on clinical grounds, this looks like this resembled non-arteritic AION insofar as the story we had was sudden onset 1 year ago of an inferior altitudinal defect with a disc pallor, no pain on eye movement, no other symptoms. So the temptation was to diagnose non-arteritic AION, and is that okay? Really, that's the question. Is more testing needed? Anybody in the panel, and this is really a question for the audience to think about silently wherever you are, to just consider whether you think, is this good enough? Can you diagnose NAION clinically, which is how we diagnose it, right? It's a clinical diagnosis. There's no test that tells you somebody has NAION. So are there enough clinical features to feel comfortable about that, or is more testing needed? So are we done yet, or is anything else needed? So maybe I'll leave that.
Was there
open.
any progressive visual loss?
I'm sorry, was there what?
The progressive visual loss?
Well, there were no previous examinations. She did not seek medical attention when the vision first went out. So there's nothing to compare it to. By her report, it was sudden onset and had not changed since. So subjectively, it was stable, but we don't have a series of exams to look at. So it was just the one examination. So we could wait a while. We could wait and watch her. That's one option. So see if it, in fact, will bear itself out as non-progressive. Is this a static optic neuropathy? And so that's one option. Anything else we would like to do? So this is your chance before we all see what else was done and what it showed.
Well, you need to image her. I mean, you didn't see disc swelling. So regardless of what you think it might be, I mean, it could be a retrobulbar ischemic optic neuropathy for all we know, but you never saw the disc swelling. So she's bought herself an MRI at the very least.
Right. And that's kind of the point for again, the general audience. No disc edema was seen. And so we did get a scan. And this is not subtle. As I said, it's not fancy and it's not subtle. So what she had was a very large right subfrontal meningioma with right to left shift, compressing the optic nerve. There's mild surrounding edema. She underwent a craniotomy with gross total resection of the tumor, following which her vision markedly improved. Still normal in the left eye. The right eye improved from 2060 to 2025. The field defect, interestingly, the pattern changes. The field is clearly much better. There's no longer that degree of generalized depression that we saw before, and the inferior altitudinal defect went away. She now has a mostly relative secocentral scotoma. So this is OOPS, filed under OOPS. It's a serious miss. Non-arteritic AION is a clinical diagnosis, so we make the diagnosis based on the clinical features. Inferior altitudinal field loss is typical of NAION, but it is in no way specific. So what feature was missing here? And Neil's already gone for the biggest one, I think, the one that I think is the most important, or struck me, the disc edema was missing. The disc edema is what provides the A in AION, anterior, meaning the anterior portion of the optic nerve. So if nobody saw disc edema, you don't know the A part. You certainly don't know the ischemic part. It's not anterior anything. It's just an optic neuropathy. So and you don't have to have seen it yourself. It's okay if this is the first time you've seen the patient and now there's pallor instead of edema. But if somebody documented it either with photographs or a description, that's fine. But not without that, more is going to be needed. So that's the first pearl, is if disc edema wasn't seen, then you have to image. Second pearl, I think, is that despite how much importance we place on the time course for the diagnosis of different types of optic neuropathy, occasionally the time course is misleading. And specifically in this case, the fact that sudden onset is not the same as sudden discovery. So to clarify the difference, to make that distinction, it's often helpful to ask the patient specifically what they were doing when they lost the vision. And sometimes the answer you get is, let's say they were driving in the car, the window was open, something flew into the left eye. When they closed their eye to rub it, they discovered that there was sudden onset of visual loss in the right eye. Obviously, that's not sudden onset. That is sudden discovery. And if you just asked for the description, you would know that. And the third takeaway point that interested me about this case concerned the localization. So the visual field pattern that this patient showed had a defect that emerged from the blind spot and respected the horizontal meridian. So this is a schematic version of her defect. So this is a defect that emerges from the blind spot, respects the horizontal, and that we associate that with optic disc disease. That pattern is how the fibers are organized at the level of the optic disc. And so when you see any variation on that pattern, you would know this is disc disease, whether it's AION or disc drusen or papilledema or glaucoma, remains to be seen, but it has nothing to do with what is it. This is an answer to where is it. So this is anterior disc disease. As the fibers proceed posteriorly to enter the brain, the intracranial contents, they reorganize themselves to orient vertically so they can split at the chiasm, and the defects in this area point to fixation and rather than the blind spot and respect the vertical meridian. So the visual field pattern that this patient had said, oh, this is disc disease. And again, that rule is important and we use it all the time, but it's good to recognize that there are occasional exceptions. And the ones that I've seen are typically in this location. They're intracranial optic nerve, just as it emerges from the optic canal, often meningioma, compressing the nerves like just as they are a planum sphenoidale meningioma, compressing the intracranial optic nerves, not right in front of the chiasm, but right past the canal. And so just to be aware, not to outsmart yourself with in terms of the pattern, oh, I know where this is. Occasionally it just is telling you the wrong answer. So the next way to look at this case is to look at the question, do all patients with a diagnosis of NAION need a scan? So Neil's already gave us one rule. If you don't see the disc edema, yeah, those people need a scan. But who else? Is that all? What else? What other type, in what setting would you want to get a scan in somebody when you're entertaining a diagnosis of NAION? And that's really another way to ask that is, what are the indications for neuroimaging in presumptive NAION? And for that, I thought we'd open that up for discussion for anybody who wants to jump in. Whoops, sorry.
Valerie, I think it's a really, really good point because we get a lot of referrals from ophtho where it's assumed to be AION, often based on the field appearance because of sectoral optic disc edema, because it's a common optic neuropathy in a vascular path. I would add to Neil's comment, persistent optic disc swelling beyond 2 months. So over 2 months.
Okay.
Or progression or recurrence, all things that are atypical for AION.
Perfect. So that's what, anything else, anybody else, things on your list?
Other eye field effects?
Say again?
Other eye field effects?
Oh, yeah, that's a great one. So visual field defect in the fellow eye. And specifically, which type? Do you have something in mind, or why is that a warning sign? What does it warn you of?
So, temporal field effects are in the other eye. So that's what I would be concerned with.
Exactly. So maybe along the lines of a, what do you call it? Von Willebrand, the one that doesn't exist anymore.
A junctional scotoma.
Junctional von Willebrand.
Junctional scotoma is right.
It's the
we're all under caffeinated, Valerie. At least I am.
So we've eradicated junctional scotomas now.
Right. Well,
I just
they were outlawed. Yeah, go ahead.
I'm sorry. I would just extend the comment to retrobulbar ischemic optic neuropathy. That again, it's just as with NAION diagnosis, you need to see the disc swelling. With retrobulbar ischemic optic neuropathy, it's a diagnosis of exclusion, and those patients need imaging. And we had a very unfortunate situation some years ago when one of our ex-residents made a diagnosis. She had a woman who came in with evidence of a retrobulbar process, and she actually wrote in her note, this is probably retrobulbar ischemic optic neuropathy, a diagnosis of exclusion, but never excluded it with an imaging study. And a year later, the patient comes back with a large skull-based meningioma. So I think the other, just going back to NAION, if you don't have a disc at risk, a small disc, little or no cup, I think you make the diagnosis of NAION with great trepidation. I know there have been a couple of reports of presumed NAION with a normal disc or a normal cup, but for me, it's the same thing as making a diagnosis of IIH in a male or in a thin woman. So I think you do so at your peril.
Right. I think that the comment about posterior ischemic optic neuropathy, the warning flags and what might you be missing, and is even more pertinent, more striking. The way I was trained, Dr. Henry Van Dyke said, just assume that when you find yourself diagnosing impression, posterior ischemic optic neuropathy, just assume that you're wrong. Just assume that it isn't that. And granted, that was pre pre-MRI, early CT, and there were more ways to miss a small lesion at the orbital apex. But the rule still generally holds if it's not perioperative or some history of massive blood loss and hypotension. If you've got that, and if it's not giant cell, it's probably not posterior ischemic. So it the way I teach this is just follow that rule. Figure you made a mistake. So those are all. Let me write those down. So the ones we've talked about, so these are when might you want to do a scan? What are your indications for getting a scan in somebody you suspect has NEION? So disc edema not documented was the one that jumped right out at us. Progressive visual loss, Fiona suggested past 2 months. Is not one exact cutoff, but that seems certainly by 2. And I think, Fiona, didn't you say 2 months or did you say less?
No, I think progressive visual field loss or vision loss, but I think disc edema also persisting beyond 2 months. That's what I said.
Okay, so yeah, because I think for the persistent disc edema, my cutoff would be about 2 months. For progressive visual loss, you might say more than 2 weeks to pick up that 30% or so that have progressive NEION during the first 7 to 10 days, or 4 weeks. But the point is, I don't think you need an exact date. Well, what day does it become progressive? But extends more than expected. Visual loss that is continuing to progress, persistent disc edema, as Neil mentioned, no risk factors, for instance, age, or if it's somebody under 45, not a history of diabetes, hyperlipidemia, some other vasculopathic risk factor, and lack of the typical fellow eye disc configuration. And then another one I threw in was occasionally when you're trying to distinguish NEION from optic neuritis. This is usually people in that in-between age group, sort of mid-40s. They're a little bit young for NEION. They're a little old for optic neuritis. They had a little ache, but not pain with eye movement. The field defect isn't typical. Ones that sort of fall between the cracks. And you'd like some more help for when you're thinking it's not optic neuritis, that it's NEION. It certainly can be helpful to get the MRI because you surely expect to see optic neuritis on the scan, on the MRI in almost all cases, but the NEION, you would expect not to see that if it's non-arteritic. So that's anybody other ideas for when else? Anything I missed?
Well, we have a few comments here.
Mm-hmm.
So was this in the pre-MRI scan era?
No, the MRIs existed, but this case was maybe in the 90s or late 90s. The CT, I think, was because it was fast. We could get it right away. It was easy and fast. I have to admit, the CT was because I really didn't expect to see anything. I mean, the idea that who would think this was NEION? Well, I thought it was NEION. That was me. I thought it probably was. I knew enough to get the scan, to not just make that diagnosis without, but I honestly didn't expect to see a tumor or something fancy. So I think that the CT was just filling in, going through the motions a little bit. But I learned these kinds of rules. I learned that particular one very vividly from this case. If you don't see the disc edema, get a scan. And then for years, one of my retina neighbors in my group would very often, in asking me to see a patient, could you take a look at it? We have someone in my chair. Could we put him in your chair? Because it's and describe an optic neuropathy with disc pallor. Think it's AION, think it's NEION, but could you just take a look? And I would say, is the disc gone? No, but I think so. Why do you think it's NEION? So I think it's sort of a garbage bag for non-neuro-ophthalmologists. At least a lot of things get thrown in there. And so we would want people to be a little more discriminating, and particularly it's in the title, it's the A, which is what I would tell my colleague each time this happened.
Yeah, so the other thing is the length of the optic nerve is 50 millimeters, right? And your lesion in your case was a size of 60 millimeters, am I right?
The size of the
lesion, the entire lesion.
The tumor.
Yes.
Yes.
Yes. Okay. So now what this proves to us is the visual loss is not a function of the size of the lesion. It's just the extent and the location of the lesion and where it's compressing the visual pathway. Mm-hmm. Right? So very important to know that. Right?
It's certainly other variables besides the size knocks you out. This is a knockout scan, which makes it a knockout case, but that's not the only variable.
Yes. And then I am interested to know, because I read up a few studies which tell us about neuroimaging, especially MRI in AION cases, NAION cases. So there are certain findings in NAION in neuroimaging, on neuroimaging. So is that indicated these days? Is it being used by anyone in real or true NAION cases?
Well, that was another reason to show this case, another topic that I thought we might discuss, to see if some people are just routinely scanning. You know, if it's an optic neuropathy, if you're thinking it's a unilateral optic neuropathy with the disc edema, of course, get a scan. And maybe I'm just so old that we were used to diagnosing it clinically. A lot of things that I learned to diagnose clinically without scan proof or radiographic proof. And maybe nowadays everybody, of course, you get a scan. So comments from other panelists, if somebody clinically seems to have an AION, do you feel a need to, not these kind of mandatory cases where you really have to get a scan, where it'd be remiss not to, but just routinely to do that?
It drives me crazy, Val. The younger generation gets scans on everybody. I mean, it's just like OCT on everybody and whatever. I don't really understand that philosophy. I guess it's just people trying to be safe. And even people who say they don't get scans do. So now maybe we're lucky, because often we see the patients a couple of weeks later after the scan has been done and it's negative, and then we say we never would have gotten a scan on that patient. But right. I mean, if I were going to get a scan on a patient with disc swelling and an optic neuropathy, I would get a CT of the orbits, because almost certainly you're not going to see an intracranial mass causing unilateral disc swelling and an optic neuropathy. But it's crazy.
Well, Neil, I'm not old. I'm not young. And I do admit that I end up getting a lot of scans, but I think there's an ascertainment bias sometimes that we see slightly atypical cases. I do find the scan very helpful for diagnosing the disc drusen that might have contributed to the AION.
There's that.
An OCT is cheaper.
They certainly get that on everybody. But the cases nowadays, they present cases to me starting with the OCT findings.
Oh, absolutely.
And I'll say, well, is there a person that owns this OCT? Was there a story? Oh, right. 50-year-old woman. Did something happen to her? Oh, yeah, decreased vision in the right eye. It's like a surgical procedure extracting the stuff that I want to know. But it's a different.
Yeah, they get all these. We're all sounding like old people, but they get all these studies before they even see the patient.
Flow. It's different from flow, intracranial flow or CSF flow. This is patient flow, clinic flow. Right? It's a flow study, right? Satya, other comments or from other panelists or on the general topic? I just brought that back to show the lesion. Yes. Okay, well, thank you again for, was there, Satya, anything else? No.
No, that's it. Thank you so much, Valerie.
Thank you so much, everybody.
Just a question, now, because of earlier, it was very clear. I mean, like, NAION, older patient, younger patient, neuritis. But sometimes now that, with the confusion of NMO MOG coming in, we have, relatively older patients. And unfortunately, in India, with a lot of systemic diseases, diabetes, hypertension happening at a much younger age group, we have, NAION presenting at a much younger population. So about plus 40, you have a fair amount. In fact, we see NAION even in younger patients up to, 30s and probably late 25s also. So in those cases, I mean, sometimes that becomes an issue, because we've had, multiple cases being presented and discussed where, retrospectively an imaging is done, or retrospectively you're thinking in terms of, an NMO positive patient, not so young in the 40s presenting with the first time vision loss. So that's one condition where, imaging is touch and go, and you often don't know what to really, do about them. There's still, workup is tough.
Yep. Got it. Thank you.
Thank you. So we move on to the next case, and let me introduce to you Dr. Padmaja Sudhakar. She's an associate professor of neurology and ophthalmology at the University of Kentucky in USA. She did her medicine and fellowship in neuro-ophthalmology at Shankar Netralaya, Chennai, India. She did her fellowship in neuro-ophthalmology at Kellogg Eye Center, University of Michigan. She did her residency in the University of Kentucky itself. She's a clinical competency chair for the neurology residency program at University of Kentucky and the Grand Rounds Director for Neurology. She's also an inpatient neurology medical director at UK Chandler Hospital. She has several peer-reviewed publications and books. One of them includes the Shankar Netralaya Atlas of Neuro-Ophthalmology, as well as the SN Atlas of Imaging in Ophthalmology. She was conferred the prestigious A.B. Baker Excellence in Teaching Award from the American Academy of Neurology. Over to you, Padmaja.
Thank you. Let me just share my slides. Are you able to see my slides?
Yes, we can.
All right. Thank you again for inviting me. And I'm going to talk about an interesting case more from a neurology perspective. I have nothing to disclose. So this is a 24-year-old white woman who presented to our hospital with a 1-week history of very severe headache, reporting she had stress at work. There was new onset seizures, auditory visual hallucinations, pulsatile tinnitus, and transient visual obscurations. But preceding this or associated with this, there was no fever or any other illness. Her past medical history was significant for polycystic ovarian syndrome, hypertension, and migraine, which was being largely managed with the famous goody powder in the United States, which is an over-the-counter stuff. She was not vaccinated for COVID. This we saw her during 2021, where COVID was quite rampant. She was a certified nursing assistant, and if you know the state of Kentucky, all this is very common, that she was vaping, using plenty of Monster drinks and large amounts of coffee. She goes to an outside hospital. CT head is reported as normal. She's given a migraine cocktail to help with her headache, and then she has a generalized tonic-clonic seizure. They started her on levetiracetam, and then they transferred her to our hospital. In our hospital, her vital signs are good, exam is good, except that she was a little encephalopathic because she would say weird things like, "Mommy, you're dead. I'm so sad. Are we in heaven?" So we attempted to do a fundus exam, but there was severe photophobia and it was not possible. Preliminary labs were all looking good. EEG did not show any ongoing seizures, just slowing in the left frontal temporal lobe. So we continued on the levetiracetam, admitted her. And then we did another CT at our hospital, and they raised a question of vasogenic edema in the occipital region concerning for press. But at this point, blood pressure was good, all the vitals were good. We also did a CT venogram, and this only showed a stenosis at the transverse sigmoid sinus junction, more pronounced on the right side, but there was no venous sinus thrombosis. MRI, surprisingly, was found to be normal, so there was no more concern for press. So while she's admitted, 5 days later, she develops stupor, mutism, and oral dyskinesias. And now we were able to look at her fundus, and there was grade 4 disc edema concerning for papilledema. And due to the stupor, we could not assess her vision. Proceeded with a spinal tap, which obviously showed very high opening pressure of 54 centimeters of water with lymphocytic pleocytosis and elevated protein. And even though the panel, the CSF was negative for infections, there was a large concern for viral meningoencephalitis. And so she was started on IV acyclovir, and we added acetazolamide given the intracranial hypertension. Quickly, she developed apnea with bradycardia and worsening stupor and got intubated. So then we did a repeat MRI, and that was again normal. attempted a 24-hour EEG, could not proceed because of severe agitation. So the presumption here was there's ongoing seizures with hemodynamic instability. So they optimized the levetiracetam. And for some reason, they kept doing serial lumbar punctures and pressures were persistently elevated. And even got a lumbar drain, which is quite, I mean, this is not something which we commonly do, because they wanted to mitigate pressures and protect vision, which could not be assessed. And slowly the acetazolamide dose was also increased. Nothing changed the mental status. At this time, we just gathered an important historical information. I'll stop here. Any thoughts?
The main thought is that these kind of cases usually present to a neurologist rather than a neuro-ophthalmology. Such patients, you're presenting a case of encephalitis. I haven't seen many patients of encephalitis presenting with raised ICP. So this is like she has very, very elevated, that you're doing serial lumbar punctures. So that's something really new to me, that the patient with encephalitis presenting with papilledema. In fact, there are initially people thought if there's papilledema, there's no encephalitis. I wanted to know Dr. Miller's opinion regarding that.
Well, I think the real question is this an infectious process or is it an inflammatory process? And I think that, you know, if the person said they were swimming in a lake, you might expect some sort of parasitic process. If we have these huge number now of autoimmune encephalopathies, GABA, et cetera. So I think you want to try to get a sense of whether this is an infectious or inflammatory process. And I don't know what the historical information is, but you wonder if they were doing something, they were exposed to something. Is this West Nile? Is it this? Is it that? My own experience is limited, but I can say that in a lot, it's not unusual for me to see or be called to see patients with papilledema in the setting of encephalitis. I don't think that's all that unusual.
So that's true. And then like the serial lumbar punctures was like not based on our recommendation. It's something which the neurology team did because they were just worried that she was going to go blind. I'll proceed. So mother, who was there throughout from the admission, now opened her mouth and she said, you know what, when my daughter was 15, they removed some kind of cyst from her ovary. And then we digged in more and said, like, can you tell us more? We managed to somehow get some earlier reports. It wasn't just cysts, it was dermoid tumors, which were removed from both her ovaries. But like someone labeled her with this polycystic ovarian syndrome, which we actually take this history in all our pseudotumor cerebri patients. But I don't know if this was really polycystic ovarian syndrome. At this point, then we decided and got a CT chest, abdomen, and pelvis, and that revealed a 12 millimeter fat containing nodule on the left ovary. And now is this anti-NMDA receptor encephalitis. So immediately plan changed. They gave her IV methylprednisolone, gram daily for 5 days. And then they also gave her IVIG. And then the CSF was tested and the CSF NMDA antibodies returned positive. She underwent the diagnostic laparoscopy, left oophorectomy, partial salpingectomy with lysis of addition. And this was confirmed as a mature cystic teratoma. And this is, biopsy samples where, you can see hair embedded within the cyst. And this is multiple structures like adipose tissue, then sebaceous cyst. This is erector pylori muscle. This is like a hair follicle. All this very characteristic for a teratoma. Then she goes on to get a tracheostomy with a feeding tube, goes for rehabilitation, showed continuous improvement, regained consciousness. Everything was reversed, the tracheostomy, the feeding tube, and they continued on the levetiracetam, although she had no more seizures. 3 weeks from hospital discharge, she comes walking into my clinic, completely normal exam, no papilledema anymore. This is the visual field, this is the OCT, everything looking good. So the final diagnosis in this case was the anti-NMDA receptor encephalitis with intracranial hypertension. She was initiated on rituximab. She continues to remain negative for seizures. So eventually they will take out the levetiracetam. Repeat imaging with MRI has been again normal. OBGYN is monitoring the teratoma, and we have done multiple of neuro-ophthalmology exams. She's completely stable, no papilledema, and the acetazolamide was actually even stopped, within the first few weeks. So to describe this anti-NMDA receptor encephalitis, this was only described in 2007 by Dalamo et al. And patients typically have acute psychiatric disturbances, insomnia, neurological manifestations, and they have autonomic instability, and some of them have even gotten a pacemaker. 80% are women, and the mechanism is there's an IgG antibody which forms against the NMDA receptor, which plays a very crucial role in synaptic transmission and plasticity. It's seen both in the serum and CSF, but the CSF testing is more sensitive than serum. And it's classically associated with the ovarian teratomas as described in the original paper, because apparently the teratomas express the receptor and become an immunologic trigger for the development of the antibodies. But there's been association with other conditions like HSV encephalitis and against after some vaccination. So the definitive treatment is immune therapy and recognizing and treating the tumor. The first line immune therapy is your methylprednisolone, IVIG, plasma exchange. And the second line immune therapy becomes things like cyclophosphamide and rituximab. And then the prognosis is very good. If you get the diagnosis and get rid of the tumor, they're absolutely fine. These patients, do not have much neurologic deficits. But what interested me in this case was the fact about the intracranial hypertension, because we have seen several encephalitis patients. We always look at their fundus. We don't see papilledema very often. And so as far as this condition is concerned, it's a very atypical and under-recognized finding, which can pose a diagnostic challenge. And it could contribute to autonomic and hemodynamic instability. In fact, we mistook the initial picture as being part of a Cushing's reflex, which you can see with intracranial hypertension. But the good thing about the intracranial hypertension is that it's transient and self-limited. So the clinical significance is not clearly known. And when I looked it up, not many reports are there describing intracranial hypertension. In fact, none of even the reported articles talk about papilledema. And there was a retrospective study which said that maybe 42% can have elevated ICP. So we do spinal taps in all these encephalitis patients, and it's very important, to note the intracranial pressure, because if it's an NMDA receptor encephalitis, the intracranial pressure may suggest that there is possibly refractory or a very severe autonomic instability. So the teaching points for the case are, whenever we see meningoencephalitis, we think about infectious etiology first, but autoimmune should be kept in mind. Until you think about it, you won't order the appropriate testing. And, people who practice in the United States know when you ask for all these fancy tests like the autoimmune encephalitis panel, hospitals don't support really this, because insurance comes in play and they will question as to why, you know, you're getting all this. But in this case, it really clinched the diagnosis. It helped us change management, you know, with immune therapy. And then when we hear this history of polycystic ovarian syndrome, we think it's like it's metabolic, these people are obese. But I think we should get a little more detailed history in such cases, because maybe all polycystic is not really polycystic. And then as far as what really perplexed me about this case is the papilledema and intracranial hypertension, which is very rarely reported in these circumstances and very under-recognized. I don't know whether we really understand the mechanism behind it, but I think it's something that we as neuro-ophthalmologists need to pay attention. And that's all, and I'm happy to take any questions.
One thing, Paddy, since you're also into neurology, the patient had encephalitis, and along with that, very raised ICP. So when you drain CSF, is there any chance of phoning or something? You know, it's the brain is under a lot of pressure.
We don't really do a draining in such circumstances. It's more diagnostic. So we would get like, I mean, a good person doing it would get close to like 12 to 15 ml of fluid. But it's more for diagnosis. We never do like how we do a high volume tap in some situations.
So would you treat them with mannitol and dexamethasone and bring down the pressure? Nothing. You just sit
no.
Like, it's amazing the kind of visual fields and RNFL the patient had, despite, you know,
within 3 weeks, yes,
such an elevated ICP and encephalitis. Very unique case.
I'd make a couple of comments. First of all, with all due respect to my neurology colleagues, they don't do papilledema or any fundus very well. And I think that these patients come in and the neurologists are more worried about the neurologic aspects, and they don't really look at the fundus, or if they do, they don't get a good picture. So I think underreporting is more likely than not occurring. The other is just a plug for a great article. A couple of years ago, Eric Eggenberger at the NANOS meeting discussed autoimmune encephalopathies, including anti-NMDAR, and they subsequently published a paper in the JNO a year or so later. So I think for people interested, because these are somewhat confusing, there are so many of them, anti-GAD, anti-NMDR, etc. It's worth a look at this paper. I can't remember, Eric is the last author. I can't remember who the first author is, but it was just a couple of years ago in the JNO.
So I think we were very lucky, and I agree with Dr. Miller that people don't really pay importance to the fundus. Right now in my neurology program, we have 3 residents who've had prior neuro-ophthalmology training. So we really take advantage of them, and it's actually one of them who actually looked and found the papilledema, because if it's like a general neurology resident, or if, you know, there's always a confusion with this like slight visual complaint, ophthalmology team will be right away called, but then they don't like to dilate these patients because pupil is really monitored closely in the inpatient setting. But we were just lucky that one of those well-trained residents looked and found the papilledema.
One of the bizarre things that's happened in our institution is that it used to be that we could dilate both pupils, and we just put a sign up on the bed and sometimes on the patient's forehead that we had dilated the patient, but somehow they've decided that the safer thing to do is dilate one pupil only. And to me, that doesn't make any sense at all when you're dealing with a neurologically ill patient.
Another question, Dr. Miller and Paddy. Do we see patients with optic nerve dysfunction post-encephalitis? I mean, like, Patient has recovered from encephalitis, and I haven't seen that many patients with, optic nerve deficits post-recovery.
Yeah, I've certainly seen patients who had, during the acute period, either some sort of demyelinating process or even hypotension or something like that leading to visual loss. I think more commonly, they develop cortical problems from the encephalitis, and they're usually post-chiasmal, if you will, and higher disorders of visual dysfunction.
Yeah, I agree. I've seen just one patient who actually came with like a mild optic neuropathy post treatment, but not too often. And then we have a couple of children with this multi-system inflammatory syndrome with COVID. They've had optic disc edema, and it's confusing because we don't know whether it's intracranial hypertension or if it is an optic nerve inflammation as part of the syndrome, but we did see them with some residual optic neuropathies post-hospitalization.
Thank you. Satya, you are muted.
Okay, sorry for that.
Yes, we can hear you.
So the next presenter is Dr. Kathleen DeGrape from the University of Utah. She's a distinguished professor of neurology and professor of ophthalmology at John A. Moran Eye Center. She was the past president of the North American Neuro-Ophthalmology Society and also the past president of the American Headache Society. She worked with Eccles Health Sciences Library at the University of Utah and NANOS to establish the novel library, that's the Neuro-Ophthalmology Virtual Educational Library. Over to you, Dr. Kathleen.
Thank you so much, Satya, and I want to thank the organizers for inviting me to give my case, which I've entitled Headache, Papilledema, Aphasia, and Cells, Oh My. And I got this from, if you remember the movie, The Wizard of Oz, lions and tigers and bears, oh my. And so many of us, when we're in our clinics, we have cases that make us think, how am I going to put all of this together? So this is an 18-year-old senior in high school, and he has a very strong family history of migraine in his mother and sister. He'd have previous headaches that were low grade. They always responded to acetaminophen, but he was doing his usual exercises, and he did some weightlifting, and he developed tingling in his body, chest, arms, and for about 30 minutes, he couldn't speak. He fell asleep, and he woke up with a headache. He went to the emergency room because his mother made him go to the emergency room, and he had a CT scan, which was normal. And then he left for home, but on the way home in the car, his aphasia came back and he couldn't speak again. So the mother turned the car around, went back to the emergency room, and then they delivered TPA, thinking that he'd had a stroke. However, he had a normal MRI scan, a normal echocardiogram with a bubble study, and then he again had a very, very severe headache, and he was diagnosed as a complicated migraine. So he was treated with amitriptyline, 10 milligrams. He also got a ketorolac or Toradol shot, and his severe headache was also treated with sumatriptan, But when he took the sumatriptan, he developed another episode of aphasia, also followed by a horrible headache. Then he was given codeine and butalbital. And finally, a couple days later, he had some blurred vision, so he was sent to ophthalmology, who diagnosed disc swelling. This led to him getting a lumbar puncture that showed a mildly elevated opening pressure of 290 millimeters of CSF. The protein wasn't done, but he had, and glucose also wasn't done, but he had 112 white cells. So he was started on acetazolamide, but then he developed a post-lumbar puncture headache, so he had to have a blood patch, and then somebody put him on topiramate. So he was referred to neuro-ophthalmology, and on our examination, he was normal. He now had resolved, but he had an acuity of 20/30 in the right eye, 20/60 in the left eye. He had no relative afferent pupillary defect. His fields were full to confrontation, but you can see on his formal visual fields that he did have enlarged blind spots. Extraocular movements showed minor limitations of abduction bilaterally, and he had a 20 diopter esotropia in all fields of gaze. And you can see also from these fundus photos that he had significant disc edema. So he had further workup. He had a RPR, which was positive, but then an FTA was negative, and this was worked up further and felt not to be significant. He had Lyme workup, which was negative, a Bartonella, quantiferin gold for tuberculosis. He also had some TB cultures. Toxa was looked at. He had several viral titers. He did have a positive ANA, but all the other autoimmune titers were negative. He underwent a repeat lumbar puncture, and his opening pressure again was elevated to 330 millimeters of CSF. He had 135 white cells, a protein of 137, a glucose of 56 with the normal serum glucose. And he stopped all of his other medications except the acetazolamide. Everything resolved. He got some new glasses, and he was 20/20. So I'm going to ask our audience and our panelists to help us understand what might be the diagnosis here.
I may have missed it, Kathleen, but did the patient have a lumbar spine MRI?
No, he did not.
I always worry when somebody has this type of setting and has the high protein like that, there's something, a Tarlov cyst or an ependymoma or something like that in the spinal cord.
Absolutely. Very good thought. Very good thought. Any other thoughts here? So have I stumped the crowd? This guy has had multiple episodes of a neurologic deficit followed by a headache, and he's got cells in his spinal fluid. And he's got papilledema. And he said, his MRI scan showed no diffusion abnormalities, no other signs of anything else. And all of our cultures were negative.
Over what period of time were these episodes?
So the initial ones were kind of very closely spaced within, a few days. But then he was normal from then on.
You should give a clue. I know the answer, but I'm not going to tell now. You should give the clue to Dr. Miller.
No.
The diagnosis in the headache. It's a kind of headache.
And Helen Dinesh Meyer is on, at least she was on. I don't know if she's still on, but she has a wonderful case in the literature of this. Helen, are you on?
I think it's very late there in New Zealand.
Oh, so
It
she's
lends
probably,
itself to a very nice acronym. That's another hint.
She is
Yeah.
there. She's there, she's muted.
Oh, she's
she's
there.
there. Well, I'll just tell you, it's getting late for everybody. Let's see, I've got to get my slides to. So she has handle. And this is a very interesting syndrome. It's characterized by headache, neurologic deficit, usually sensory aphasia, sometimes motor, but mostly it's sensory and aphasia, and leukocytosis in the spinal fluid. And the key on this is that it really is a migraine-like headache, but you get these neurologic deficits. So often people get diagnosed as complicated migraine, but then if you do the spinal tap, you see these white cells. The deficits are usually short. They can last a few hours, 2 to 4 hours, with hemiparesis and hemisensory loss. And then there's CSF pleocytosis, usually over 15 white cells. And the whole diagnosis has to be kind of all connected, as in this case. And it's usually not explained by another diagnosis. What I thought was interesting about this case is having papilledema. And so one thing that I did was go back to the literature, because the previous cases I've seen of this, they did not have papilledema, but it's really not rare. So all ophthalmologists and neuro-ophthalmologists should be aware of this kind of syndrome. The bilateral 6-nerve palsies have been reported multiple times. The cells in the CSF can be between 10 and I saw a case up to 760. The protein is almost invariably elevated. Sometimes people have had a viral prodrome. The MR scan is usually negative. In fact, that has to be negative, because if you have a stroke or something like that, then you're off on a different pathway. The EEG is usually normal. The microbiology studies are also usually normal, and this is usually benign. It goes away. And as in this guy, he left my clinic and I said, come back if you have problems. And he's been fine. I saw him back a few months later just to be sure, but he was fine. We did treat him with acetazolamide. His papilledema resolved slowly. He had no further episodes, but he did have occasional migraine that we treated him with. So I think we need to recognize this syndrome. It's not very common, and you really do need to do a thorough workup, looking for other causes of meningoencephalitis. And Neil's point about getting MR of the C and L spine, certainly if his papilledema hadn't gone away, and if he weren't, completely normal at the end, I would have had to, go further to work up that elevated protein, et cetera. But when you see headache, papilledema, aphasia, sensory changes, and cells, oh my goodness, yes, we have to work it up and come up with what else that this could be. Yeah, Neil, I love it. You got to get a handle on the condition. I was wondering how many ophthalmologists have heard of this. Neurologists have heard of this because we sometimes see this syndrome, but I don't know how many ophthalmologists have.
The head neuro-ophthalmologist is nodding his head like this, and none of us, I think. But migraine should be a diagnosis of exclusion in where there is a focal neurological deficit. What would you say, Dr. Miller?
I don't know. I always worry about the diagnosis of migraine. It depends on the age of the patient, if they have any prodromes as a child, etc. But I'm just fascinated by what the underlying etiology of the protein and cells is. I mean, I don't normally think of migraine if you did a lumbar puncture in a patient with routine migraine, if you would see anything in the CSF. But I mean, and this isn't just a little bit of elevated protein. I mean, that's big time, and your slide indicated that it can be up to 700 plus. So I'm blown away by the case. This is brand new for me.
Yeah. You know, there is this meningitis called Mollare's meningitis that can present like this, okay? And then you do the spinal fluid and you see these, what they call Mollare's cells. They look like kind of giant cells with a bunch, and that's really with herpes simplex virus.
Right.
That people
one
can
and
get
two.
this.
Yeah, in fact, that's why I asked about the interval in terms of the things, because I was thinking of an HSV type meningoencephalitis, but I didn't. It was too close together.
They're too close together, and these cases are so typical that when I saw this guy, I said, "I wonder if you've got handle," but I couldn't wrap my head around the papilledema piece until I went to the literature and saw that, all right, 30 to 40% of the cases have papilledema and raised intracranial pressure, which I just had not seen that combination before. But this handle is, you know, it's a rare syndrome in headache medicine, and we see it occasionally. It's not very common, but to see it with papilledema is really bizarre. And Valerie Pervin asked a good question about papilledema in this kid. I mean, for him to have papilledema kind of right away like this, did he have underlying intracranial hypertension before this developed? I mean, I don't know. He didn't have any signs of that on his MRI scan. He didn't have an empty cella or anything else. So I'm not sure how quickly somebody gets papilledema with a handle case.
Yeah, I mean, we know that papilledema can develop within a couple of hours from the trauma cases. I would have thought that it was the protein that caused the elevated intracranial pressure.
Yeah, but then how long does that take to develop?
Yeah.
But it's an unusual syndrome, and I thought people might want to know about it.
Beautiful.
No, to answer the question, does handle always present with papilledema? No. In fact, most of the cases that are out there are without papilledema. But Helen Dinesh-Meyer has a really nice case in the literature, and there's quite a literature on handle. So if you're interested in it, I'm very happy to send you references.
So thank you, Kathleen. So we move on to the next presentation. Oops. That was hijacked. Give me a second. Okay, is this visible? Dr. Fiona Costello is Professor, Departments of Clinical Neuroscience and Clinician Scientist at Hotchkiss Brain Institute, University of Calgary, Canada. She is a chair to the Roy and Joan Allen Investigatorship for Vision Research and is working to establish a translational vision research program at the Hotchkiss Brain Institute. Currently, she's on the editorial board with several academic journals, including Journal of Neuro-Ophthalmology, the Journal of Neurology and Neurology. She has also worked in leadership roles with the Canadian Neurological Society, the Canadian Neurological Sciences Federation, the North American Neuro-Ophthalmology Society, the International Women in Multiple Sclerosis Network, and the Americas Committee for Treatment and Research in Multiple Sclerosis. Over to you, Dr. Fiona.
Thank you very much. I want to make sure that everyone can see this. Can you see this at all?
Not yet.
Not yet. Okay, hold on. I will get out. Despite all of the time we've spent on Zoom, I still have a...
We can see it now.
Oh, you can? Okay, wonderful. Well, I want to thank everybody. I know the session's running long, and I actually have, I hope, a fairly short case that won't have me rambling on like the last time we had our global festival, so I'll try and be brief. I'm very grateful to be involved and humbled to be following such wonderful cases and people. So this is a delivery with a punchline. So quickly, and this is an example, I think, of something we're all used to, where we sort of have to reverse the case because we're not seeing the patient acutely. So we have to reverse engineer this diagnosis. You're asked to see a 23-year-old young woman. She's just given birth to twins a month ago. So she's tired and not thrilled to be in the clinic, but she does describe being referred for blurred vision. 4 weeks ago, she developed blurred vision, binocular horizontal diplopia, and headache, and does note in her history that she had been treated with a blood patch because it was presumed she had intracranial hypotension. She's known to be heterozygous for factor V Leiden mutation. She has no allergies and is currently using no medications. And her pre-pregnancy BMI was around 29, but she had minimal weight gain over the course of her gestation as she was quite unwell. So this is the examination that you're seeing. And 1 month ago, there were fields done during which time she had enlarged blind spots in both eyes. Her acuity is good. She's 20/20. She has no RAPD, but you were told that she had a fundus examination that showed optic disc edema, and you're seeing her with the images shown here on the right. So I'll let that percolate a little bit. And I want to ask, does anybody have any questions at this point? And if not, that's okay. I have a question for you.
Dr. Fiona, what was the BP?
Blood pressure was normal. I'll say 120/70.
Okay.
Good question.
So there was no preeclampsia or anything?
Nothing like that. The delivery and everything went quite well. She was really ran into troubles with more extreme headaches postpartum. But she had been nauseated, not well, prepartum. Okay.
J. Lawton Smith used to say that if you saw a patient following pregnancy and delivery, it was one of two things, either pituitary apoplexy or venous sinus thrombosis.
Those are excellent diagnostic considerations, but I'll give you a hint, it's not that. Something subtle, it's not that.
And one more question, why she was suspected intracranial hypotension?
That's a really good question. And in fact, she was. That was the reason for the blood patch. I mean, it stands to reason. You know, you have a patient who's feeling unwell, has a headache, just had an epidural. It's a reasonable hypothesis. Okay.
It's a hypotension.
So there was concern that she may have developed intracranial hypotension with a CSF leak due to the LP, well, due to the epidural, I should say. All right. So my question now to the group is, which investigations, and these are not necessarily exclusionary, would you like to order? Would you like an MRI scan of the brain in orbits? And I'll, for Neil's sake, add in venography. Would you like to repeat the opening pressure and do CSF analysis? You know, she's had an epidural, not a diagnostic LP. Would you like to do fundus fluorescein angiography? Does OCT come into play? Would you like a peripapillary RNFL and perhaps macular ganglion cell interplexiform layer thickness testing? Or is there something else you would like to do?
How about hematologic evaluation?
Okay, her hematological process, so Neil chooses E is normal. Her cell count with differential is normal. She has no thrombocytosis or thrombocytopenia. Her INR is normal. PTT is normal. And I can show you some results just to kind of keep things moving. These are her MRI findings. Would anybody like to comment? And the pertinent findings are shown. These are both post-contrast, T1 post-contrast studies. And I will add that the MRI scan of the orbits, because I knew that question was coming, was normal, and venography studies were also normal. As a credit,
well, at least I mentioned the pituitary. I mean,
nothing gets by you. Nothing gets by you, Neil. It could be easily mistaken, and this is a hint for a pituitary adenoma. She didn't have a sudden onset history of, apoplexy with vision loss, headache, ophthalmoplegia, which is really important.
And
well, she's got a
hypophysitis.
Stalk. So
Yeah.
she's got an adenohypophysitis, I assume.
Correct.
Lymphocytic hypophysitis has been seen like this after pregnancy too.
Yeah.
Yeah. Or perhaps throughout.
Yeah.
Okay. And because I knew you were all dying to know, she has an opening pressure that was initially high with 30 centimeters of water recorded, but her CSF studies were completely unremarkable, including her cell count, glucose protein, all cultures, oligoclonal bands, and cytopathology. Neil did ask about relevant blood work, but it might not be her kind of hematological profile that gets our attention. She was actually hyponatremic with a normal prolactin, had a low morning cortisol, and an inappropriately normal TSH for low free T4. It's really hard to assess FSH and LH in the postpartum phase, and she has a normal serum IGF-1. What do people think? If we were to reverse engineer what went on here, and I'll go back maybe to her fundus photos. And I only have a couple more slides, not a lot.
But in the immediate postpartum, prolactin be normal?
Well, the prolactin at this point is normal. It's a month later, but you're right. But we have to be mindful of not confusing the peripartum state in terms of her neuroendocrine interpretation.
There was no lactation failure.
Yeah, she has, we'll just say that her prolactin, let me rephrase, is not a factor. We don't have a prolactin deficit, no prolactin secreting lesion. I raise that only because lesions of this nature can sometimes be mistaken for pituitary adenomas.
And you said the CSF was no cells?
Completely unremarkable. So what do you guys think of the imaging, the fundus imaging here and her, in terms of this picture?
Are these rot spots, multiple rot spots?
That's a thought, but she doesn't have any. I'll say she was worked up very thoroughly for an subacute bacterial endocarditis. She's got negative blood cultures. She has a normal serum C-reactive protein. She has also had no fevers. She's not unwell.
Well, it's not really a Terson's, but I suppose you could argue that there was some elevated intracranial pressure, sudden rise.
Okay, so a diagnostic procedure was performed. And that was a deep dive into the history. So this patient described retching for hours daily leading up to her recovery. She was quite unwell. She felt acutely worse, actually, after the blood patch, but she now feels a month later relatively back to normal with no signs or symptoms of raised intracranial pressure. So she lacks pulsatile tinnitus. She doesn't have a headache. She has no transient visual obscuration. She feels her vision is improving. She no longer has double vision. So what do people think happened to this lady to explain this series of events in this case? And this is just honestly a garden variety kind of brain teaser that we have pretty regularly in the neuro-ophthalmology clinic.
The fundus picture is for sure, it's showing some abnormality with the blood.
Right. Now I'm also standing on the shoulders of giants because a lot of really important investigations have been done. But I'll say the diagnosis here was a little convoluted. So she had hypophysitis with a neuroendocrine derangement. And this actually presented likely with nausea and vomiting prepartum. That's been described. She actually had, like many of our patients, raised intracranial pressure, but in her case, probably had it exacerbated by the blood patch that was done with the presumption that her nausea and vomiting or headache were due to intracranial hypotension. And then she developed retinal hemorrhages caused by her profound retching. And so the moral of the story in this short story is really a shout out to Hickham's dictum, or John Hickam. The patient can actually have as many diagnoses as she damn well pleases. And our job is to put them together in the right order and sort of sew the case up, if you will. So I thank you for your attention. Any questions?
It was a great case, Fiona. I have few comments on the case. Like, if such a patient comes to like our clinic, first thing we'd like to rule out is preeclampsia, but you have told that was ruled out, and associated HELLP syndrome, probably a liver function test and the platelet counts, and I believe everything was ruled out. And so you say that probably the patient has had intracranial hypertension and the blood patch has aggravated that, right?
Yeah, like I think that's quite interesting, and I'm not sure how many people have seen it. Basically, a precipitous worsening of manifestations of raised intracranial pressure, which let's face it, and Kathleen can speak to this better than I can. There are a lot of patients going in and having babies with occult idiopathic intracranial hypertension. This is part and parcel of the pregnancy weight gain, hormones of pregnancy, but the fact that as a society, our BMI is collectively increasing. So there's a lot of it out there. So if you do a blood patch for the wrong reason in the wrong patient, you could actually precipitate or create a tipping point where you rapidly augment the symptoms of a patient who's otherwise tolerating them well. I've certainly seen this in the outside the context of this case. Have others? So a blood patch.
Can I?
Yeah, please do.
Yeah, no, an intracranial hypotension. If you get typical intracranial hypotension and everything else, and you put the blood patch on, sometimes these people can go to massive intracranial hypertension and have, very severe headaches. So that is one of the things we teach in intracranial hypotension, that these blood patches can really raise your intracranial pressure markedly.
And here in
I
India,
wanted to make one other comment about this case. Just one other thing in pregnancy that I always think about when people have a lot of nausea and vomiting and retching and all that kind of stuff. If they get double vision with it, you want to always think about thiamine deficiency. We forget this sometimes, and I've been burned on thiamine deficiency more than once. So I want to raise that to my colleagues.
That's a really good point, Kathleen.
Kathleen, can I just ask, when you talk about intracranial hypotension, are you talking, does it matter if it's iatrogenic versus spontaneous in terms of the blood patch issue?
The cases that I've seen where the pressure's gone massively up afterwards has been in spontaneous intracranial hypotension, not in a simple lumbar puncture.
Exactly. I mean, we've been doing blood patches for ages and ages after a lumbar puncture, and I don't know that I've ever recognized, it may have occurred, but I never recognized this particular issue. But certainly from spontaneous, I can understand it.
so what is your experience in IIH leading on to spontaneous CSF leak?
I've seen that myself. And I think the patients spontaneously decompress themselves.
Yeah.
And I think that's another diagnosis, teased out by history, because often if their leak is substantial, you don't see a lot of disc edema. And, I have in that setting myself worked with ENT to use Diamox to reduce CSF pressure so that their surgical intervention and the seal will hold better. Have you all done that as well?
Yes.
Yeah. And I mean, I think that I put this case up because this is a sort of a high anxiety circumstance. We have a postpartum patient with a lot of, if you don't ask the right questions, spurious findings that could lead you down the garden path. Then I really think when I haven't been able to figure out, I think two things have occurred to me in this session. Neil, you raised one of them, which is one thing that's wonderful about neuro-ophthalmology is no matter how long that you're in practice, and Neil has been in practice for 150 illustrious years, but no matter how
feels
long,
like it.
No matter how long, we see something for the first time all the time. So I think that's a beautiful thing about what we do. But I think really importantly is when in doubt, go back and retake the history. Because it's the series of events. It's like taking that history from the beginning of the gestation to the end that helps you sort out what piece of the puzzle deserves to go in what place, in what order, and then the picture becomes clear.
Fiona, but I still have that doubt whether those are multiple hemorrhages or it's a Roth spot. I thought I saw a few Roth spots there. So you can get multiple Roth spots in eclampsia. You can, I mean, like,
so, you know, it's really good, like a good question, actually, because I don't see a lot of Valsalva-induced retinopathy, which is typically characterized by pre-retinal hemorrhages, which is why I think it's better termed as ocular findings of Valsalva maneuvers, which can include intraretinal hemorrhages. And so that's what these were deemed to be, but we could have missed the pre-retinal hemorrhages earlier on in the patient's course. Because these often typically resolve. Not that I can talk with any degree of authority about typical resolution of retinal hemorrhages. I'm a neurologist, but you know, often you'll hear in the literature described by about 6 weeks, there's good resolution. Have people seen a lot of Valsalva-induced ocular complications, including retinal hemorrhages in this context? Perhaps we missed those too, because we're not seeing these patients acutely.
We've seen a couple of hemorrhages, small, you know, sometimes subconjunctival hemorrhage, streak hemorrhage, but not like this. That's why I was wondering if there is some other blood pathology.
I know you want to give this patient a fourth diagnosis, which I'm not against. But she was very thoroughly evaluated, because I think you raised a really important point. You have to rule out a cause of Roth spots, a hematological derangement, particularly in someone who is factor V positive and who's been through a hematologically vulnerable period in a pregnancy. So I think those are really, really important points. But
it's a really good question in terms of the Valsalva retinopathy. I mean, that's a lot of hemorrhages in both eyes. You know, normally what we see is a hyaloid hemorrhage in the macula or something like that. But that is a lot of hemorrhages for Valsalva.
Yeah. If you look at the literature,
retching a lot, maybe.
Yeah.
Maybe it is that plus something else. The blood vessels were more tortuous because of raised eyes. She did have IIH, you said initially. So
she had an opening pressure of 30.
So I mean, like, there was something.
One more question to Dr. Fiona or Neil Miller. Like, if the initial MR venogram was normal, would you go ahead and still, if you want to rule out sinus thrombosis, especially in a case of with a background history of factor V mutation, like, you know, contrast venogram or a DSA, would you suggest to do, or would you treat it as an IIH?
Excellent question. I'll say, and this is again really rooted in history. So I would have a very, very low threshold to do and even repeat a venography study in someone immediately postpartum with any concerns for raised ICP or any neurological deficits, to be honest with you. But this patient's actually much better. We're chasing a retreating enemy. So it may be hard for me to justify repeating a venography study in that context. But I think to the other good points, we often will repeat things to convince ourselves that we're not missing something in this case. But this patient went on to have a beautiful course of recovery.
Yeah, in the acute setting, a CTV is good enough, I think. I wouldn't.
I mean, I'm a neurologist. Yeah. If you sneeze, I'm going to do a CT venogram.
Right.
Thank you.
I would say that an MRV may not be good enough because it deals with flow rate. And so I always worry if we do an MRV in this setting that we're going to miss like an occlusion just because of the flow rate not being correct. But we like CTVs, and as Fiona says, for patients doing well, no papilledema, no headache. Next case.
And I also think it's really important to say that in your note. So we always say why we're doing tests. I think it's sometimes really important to say why we're not. And so in a patient with no longer any evidence of disc edema, resolving clinically with no manifestations of raised intracranial pressure in terms of the symptom profile, with this history, and you've done a deep dive into like the series of events that led to the constellation of findings and the evolution of findings, then you can say, this is why I'm not doing a CT venogram, because I think that that part of this picture has been adequately addressed and I'm chasing a retreating enemy. And so as I've progressed in my career, I'm not quite at 150 years, but it feels like 110. I'm actually saying why I'm not doing tests as much in my letters as why I am doing tests. Because these questions invariably come up.
Great case.
Thank you, Fiona. So we've gone on for a record 6 hours now. And thanks to all the speakers and panelists for this session. Have a good day and good night, and see you again tomorrow. Bye.